Commissioner Eggers.
Good morning. I'm here, Brian.
Thank you, sir. Commissioner Seal.
Good morning.
Good morning. Good to see you. Commissioner Welch.
Good morning, Brian.
Good morning. Commissioner Long. Oh, you're muted, Commissioner Long.
Of those providers that are.
All right. Commissioner Long, can you unmute just to verify?
And clearly we are no.
Okay, I guess nobody heard me say happy birthday, Commissioner Seal.
Happy birthday.
All right. Commissioner Justice.
Good morning, Brian.
Thank you, sir. Commissioner Peters.
Morning, Brian.
All right. And Commissioner Gerard.
Morning, all.
All right, Madam Chair, I'll turn it over to you.
Yes, thank you. I notice on our agenda that we have citizens to be heard first on the agenda, but I'd like, since this is technically a work session, I'd like to move that to under the local state of emergency, because that's the only thing we'll be taking comment on. If that's okay with everyone. Okay. Barry.
Good morning, Commissioners. The first item on the agenda is an extension of the local state of emergency. That would extend it from July 17th through July the 24th. As you know, we continue to deal with COVID response. I'm very proud of our testing efforts, but we do have community spread, as you know. We've increased our testing capability to almost 4,000 tests per day. We've significantly ramped up the way in which we're doing our testing. The Mojave site has been a great addition. You do not have to have symptoms. And there was a report this morning about the lack of test kits available. That is true for some sites. However, we have plenty of test kits and ability to test at the Mojave site. So if you need a test or want a test, you can come to that site and receive a test. If you look at the percent positivity, and I'll let Dr. Cho comment on this, we're still seeing increased numbers. We're averaging, over, a 7-day period, approximately 300, in the mid 300s per day. You do have some spikes, but we also see that some of those spikes occur on days where I think it's kind of a data dump, because then we will have one day where it reports 7,000 tests or something. So there are some issues with, you have to look at these averages because, labs get backed up and it's when they report. But our percent positivity over the last 7-day average is about 9.3%. So it's still running below 10%. We're not seeing the 28% that they're seeing in Miami, but that's I'm not trying to sell or say that it's not an issue. We still have widespread community spread, and it's impacting us in a number of ways. It's impacting our nursing homes. One of the items I'd like to report on is we're very pleased that we're able to work with the state, and we'll be announcing. We're not going to announce the location today because there's still details to work out, but we have a 120-bed super skilled nursing facility that'll be designated for COVID residents or patients that will be stood up here in Pinellas County in the near future. That will then allow us if we have a COVID positive resident in the hospital that does not need advanced care, we'll have a place to be able to put them, and that way the hospitals can then focus on the issues that they need to deal with. It also allows us to decompress where we have issues within our skilled nursing facilities. So there's a number of good things coming in terms of our response that way. The mask, we believe, is still, now we're seeing it for a couple of weeks. We're seeing widespread compliance. There are some areas of non-compliance, obviously. We'll continue to work on that. But I think that's reflective in that percent positivity. It is having an impact. We still need to look at certain areas, bars, restaurants that turn into bars and things like that. But overall, I think you're seeing a lot more compliance, and I think that's taking effect. So I would turn it over to Dr. Cho, let him comment, or Dr. Jameson regarding any specific issues they'd like to outline.
I'll start. Just to give a little background in terms of our trends, this afternoon we'll be at 12,368 cases with close to 300 deaths. Of note, and that's something I think I've mentioned on previous calls here, we have seen an increase over the last 3 or 4 weeks in terms of our weekly death counts. In terms of percent positivity, I think Barry covered it. We have seen a 7-day rolling as of this morning at 369. Happy to report our rolling average for percent positivity is now down to 8%. And I think, as you alluded to, it's a function of increased testing. We did have the Mahaffey site open with generating anywhere from 800 to 900 a day, so that could be a contributing factor. But I'd like to think in part that some of the policy decisions we've made as well, including the mask ordinance and the closures of the bars. Obviously one of the biggest metrics we follow is the healthcare system capacity. They continue to be strained. Although there is still somewhat of availability, if you look at our numbers in hospital and ICU beds, I can say in terms of beds, in terms of ICU, in terms of those on the vents, we are still hitting the highest numbers we've seen here in Pinellas County. So they're still having that growth there. We are seeing community widespread of COVID, and as I mentioned previously, it's mainly occurring in the congregate settings and indoor settings. So continuing to practice social distancing is essential to really getting past all of this, making sure that we wear those masks, because certainly we don't want to continue to strain the hospital systems. One of the messaging campaigns we hopefully are launching this week more so is asking for donations for convalescent plasma. And so what that is a promising a treatment where people that have recovered from COVID have developed these antibodies, and you can give that plasma to someone that is hospitalized for COVID, and is starting to see some good results with some of the studies out there. But it is dependent on those donations. So we are asking for those that have been diagnosed with COVID and have recovered from it to contact OneBlood, and I think we're going to have some messaging on that soon. With that, I'll stop there.
Dr. Cho, I have a question about that.
Yes, ma'am.
You read everything, but I read something about maybe the antibodies don't last. Is that true, or something that just came across randomly? I mean,
So again, with this just being a novel virus, I think we're learning more about it as we go. I think that some of that study that you're referring to does need to be validated. So what they've found is that immediately or soon after the infection, you do have neutralizing antibodies. These are antibodies effective enough to protect your body against the COVID infection. The longevity still remains to be that question. And there was one study that did suggest that they do fade potentially in 3 months. However, I'll note that there are other parts of your immunity that, even though you may not detect the antibodies, it could be in the memory cells, can activate when they see the virus again. So the second time, hopefully you can get less severe of an infection. And there's other things like cellular immunity that's also in play here as well. So it's too early to say in terms of longevity. I did have a similar concern, as it is related directly to the development of a vaccine. And just recently, the New England Journal of Medicine published a report on a promising vaccine. I think it's moving into phase, I can't speak on it, phase 2 or 3, I think. So it did show that they were able to generate the antibody response. So keeping an eye on both the longevity studies and the vaccine studies, I think, are going to be key moving forward.
That was helpful, thanks. Any questions for Dr. Cho? Yes, Commissioner Justice.
Thank you, Madam Chair. Just a couple of questions. One, I wanted to give Dr. Cho a chance to just address some of the emails I've been getting about I guess there was a lab in Orlando that had some issues with their results, and kind of talk about what % of that is statewide and how that actually impacts or doesn't impact our numbers.
And I saw similar reports. I can't speak to the extent. It appears that it's a lot of the smaller labs. So in terms of the impact on the numbers, the % positivities, because I think the report does mention some concerns that the negatives haven't been reported. I think at a statewide level, they've reached out to those laboratories, and hopefully we'll get more data on that piece of it. And I think that's what we do. Just because there are some limitations on exact numbers at times, I think what's more important than some of the exact numbers is the trend lines that we're seeing. So seeing that, for example, the case counts have have maintained, at least in the 7-day rolling average, at the mid 300s is reassuring. And hopefully we'll see that not just flatline, but decline. And obviously that would be a more positive trend, as well as the percent positivities and the trend lines for that. But to your question, I'd like to think the impact of that is minimal, but I'd have to see all the labs that were involved to really understand that.
Thank you. I think that's important because I think people who still don't believe that this is a real situation, they'll point to a story like that and they'll want to discount every bit of results and data we have because of one particular bad case. And they'll want to throw out everything. So I think it's important to hear what you just said. The second thing, if you could touch on, I thought was really interesting the other day was from the tracing information we have so far, that I think you said 3/4 of the cases were household or within the house, and not necessarily you couldn't find one institution or one type of facility, but it was based in the house. If you could just kind of talk about that a little bit.
Well, I think I was referring to the ones that were contact tracing. Obviously, the household is going to be the biggest thing. What we've seen as one of the biggest transmitters or transmission that occurs, obviously in the household. You're in the same household, same roof, indoors, same ventilation. So household is obviously one of the biggest risk factors, but it's followed really close by a work setting, right? In a work setting, in terms of narrowing it down, we've seen it all over the board. I think I've mentioned here from anywhere from businesses to gyms, to country clubs, to anywhere. So anywhere that we can have it. And that's why I think it is important that we continue to practice that social distancing in any setting, especially when it comes to indoors. So it just underscores that message to that piece.
Thank you.
Commissioner Welch? Okay.
Thank you, Madam Chair. Dr. Cho, a couple of days ago, we had a bump in a large increase in deaths. About 25 were reported. Can you speak to that and explain what were the drivers for that?
So sure. So with the death, we work closely with the medical examiners. We do have to go through this process. We validate, we do count, according to our report, the residents of Pinellas County. So some of that we need to sort through when we get there. So there is a validation process. But it also depends mainly on when the facilities, the hospitals, the care facilities report to us. So there is sometimes a lag. So even if you have a death count of a 26, it's spread out over a few days in terms of the date of death, and we do report it based on the date of death, not necessarily that particular day.
Okay. Madam Chair, I have some other comments. I don't know if you wanted me to restrict this to questions for Dr. Cho or just wait.
Yeah, why don't you hold on to that. Okay. Commissioner Eggers?
First of all, I wanted to thank you for your responses. We're getting a lot of emails on different sciences out there that talk about the validity or the how well masks actually work as a deterrent. And I know that you've had several comments, so maybe you could just make another comment as it relates to anything new that you've seen out there that either validates them or calls them into question or whatever. I just think it's important because that seems to be an area that creates an awful lot of tension and emotion for whatever reasons. I mean, there's a lot of different reasons. I'm not trying to isolate it just to medically, but if you could just speak to that part of it.
Sure, I'd be happy to. I think it goes in part, again, I think we're learning more about this virus every day. There are some limitations and gaps into our knowledge. It's just, as I mentioned before, we have decades to study other diseases, other infections. We're really learning as we go along. But what the studies are showing that it is effective in decreasing transmission. The CDC just recently updated the webpage, and so I encourage anyone to check out their webpage where they cite the evidence in the various journals to sort of validate that point on the effectiveness of transmission. To me, in terms of masks, it's really a way to really get back to business for the most part, right? It's just, this may be our new norm to sort of, because our objective here should be to slow this spread, right? And try to have and keep businesses open, to try to live a productive life. And I think that is one of the components that may need to be in place to maintain that kind of sort of normality or close to normality if we can. because ultimately what we've seen in the hospitals, what we're seeing in terms of the increase is may not be potentially sustainable, especially if we see another surge. And that would be my biggest concern within the healthcare systems, that if they overwhelm the healthcare systems, then there's going to be a lot of consequences, including deaths.
Okay. Thank you for now. That's all I had for now. Thanks.
Thank you. Commissioner Seal?
Yes, my question is actually for Dr. Jameson, and it's concerning how we're doing with our EMS personnel, as well as what you're seeing in the ERs and the hospitals. Thank you.
Sure, thank you. I was in the hospital till fairly late last evening in the ER, and I can tell you that the ERs are an interesting place right now. There's a combination of people being scared to come to the hospital, with a lot of people there being very ill. We certainly, at least in the ER I work in, have lots of COVID positive patients there, some of whom are not terribly ill, some of whom are deathly ill. And so we do have a bit of a spectrum right now. I think if I could maybe just circle back to Commissioner Justice's comment just a minute ago on the reports about the testing, that was very disappointing to me to see those reports. And the context I have to put it in is what I see firsthand in the hospital. And a month ago, there were 8 patients on ventilators in Pinellas County from COVID. And yesterday there were 54. And so whatever you think about the various testing numbers, I want to be sure that people understand that the hospitals are seeing a real impact of this. We are seeing people who have families and loved ones who can't be with them in the hospital while they are critically ill. We have numbers hospitalized that are the highest today that they've ever been. We have our hospitals, as you heard, canceling or postponing elective surgeries. And I would emphasize that elective doesn't mean optional. Putting off those things is not a small impact. And so I think in the hospital, clearly the healthcare system is stressed at this point from a physical standpoint, but also, frankly, from a human standpoint. Your healthcare workers are exhausted. They've been at this for months. It is incredibly hard to care for patients with COVID, to strap on that mask and that gown and the eye protection and knowingly walk into that room day after day is exhausting. And so I think from the hospital standpoint, I would just share that message, that I have every confidence that our hospitals and our healthcare providers will work until they drop to help keep our community safe and do what we have to do. But you should know that the hospitals are stressed and strained, and so are your healthcare workers. So that's the hospital side of things. On our EMS side, I would say we're also pretty tired. We are doing a lot of extra work. Imagine what it is to put on your full PPE and be out in the heat that we've had over the last week or so. Mm-hmm. It's not easy. Imagine what it is to deal with folks who are scared to try and convince that patient that's having the stroke to go to the hospital, even though they're scared that they might get COVID there. So where's that balance? So I'd say the EMS system is also taking steps to deal with what we're seeing, but we are stressed, both in resources and in terms of our people. We're doing a great job, and we're there for the community, and we have maintained our response times. We have maintained our standard of care. The paramedics are doing just amazing work out there every single day. I can't salute them enough for what they're doing. But we are stressed, just as the healthcare system is. And so if I were to give you an honest assessment, that's what it is.
Thank you. Commissioner Seal, did I call on you yet?
Yes, you did. And Dr. Jameson, thank you for your information. And I'm just so grateful for our healthcare workers and for our EMS personnel and for all of you. Thank you so much.
Thank you. Commissioner Long?
Thank you so much, Madam Chair. And Dr. Jameson, I just, from my heart to all of your folks on the front line, they are truly our unsung heroes, and my heart aches for them. And when I say my prayers at night, I include all of them because they are really special angels here on earth doing the work that they do. And so my question is, and I don't know if it's for you, Dr. Jameson, or Dr. Cho, but I am aware from people that I know personally about the shortage of remdesivir, and I would like to know a couple of things about that. Number one, what is the exact supply chain for getting that particular drug into the hands of our physicians? And number two, is it as dire as I have been led to believe in terms of the supply that the hospitals have? I know a couple days ago, there was only one hospital in the entire region that had a very small supply of it. So could you address that at all, please? Oh, hello.
Dr. Cho, did you want to take that one since the state is generally?
Yeah, sure. So I was going to mention that we do have speak to the hospitals regularly. We do have a hospital work group, and it's something that we bring up every call, just to look at to see their supplies, and how they're doing in terms of their pharmacies. We've had a few hospitals that do still have the remdesivir. There wasn't, I believe, an interruption in terms of the supplies, but my understanding is that we should be getting more from federal HHS shortly. I know the Florida has worked even with New York to get additional supplies here to us, and I know some of the hospitals here in this past week have received additional remdesivir. In terms of the exact numbers in which hospitals, I don't have that on hand.
Well, I hear your answer. Somehow it's not very comforting. And Madam Chair, if I might be so bold as to suggest that as a commission, we take a stand on requesting from whoever it is that we need to make the request from, that there be more, that we have a really solid plan to get more of these types of supplies that are desperately needed here in Pinellas County. I mean, it seems to me that from what I've heard on the calls we've been in, as I've heard Commissioner Eggers say so many times, we have been talking about some of these things for months. And clearly, there's got to be a supply somewhere that we can get our hands on. For crying out loud, the rest of the world has figured this out. We should not be held so hostage by this supply chain that we have no control over. And I'm very clear on how that all flows and how it all works. But at the end of the day, our citizens are expecting us to take some action and to do something. And it seems to me that that is the very least that we can do, is go on the record and make this request.
Okay. I mean, I certainly would be glad to do that if I know where the specific request should be made. You know, I mean, I think that's something we routinely do in emergency management and Barry's office, but I understand your point about as a commission, certainly, you know, you can authorize me and Barry to put the commission's name on any request like that we have.
Well, and I would just ask Dr. Cho where that would come from, because I mean, obviously we get requests all the time through our emergency management operation, and we have fulfilled those. The PPE that we supply has, you know, we're running 2 warehouses now, and so we supply all the EMS, our nursing homes, and even hospitals with PPE as requested. But I don't know about this particular issue, and so I would defer to Dr. Cho to say, is that in a supply chain that we would even be part of, or is that through the hospitals? I don't know the answer to that. The reason I wanted to ask him, I'd be happy to track that down, Commissioner. And if there's a way in which we could impact that, I'd be more than happy to push that. But I don't know the answer to that.
And I'm sure our congressional delegation would be delighted to help us with that if we had a federal request.
Absolutely. I think we need to start making those kind of requests and somehow get a handle on this, the best that we know how to do within our authority.
Right. Dr. Cho, where would that come from?
Ultimately, I think the holder, so I can tell you the Florida Hospital Association just over the past week or two sent messaging out to the hospitals on ways they can contact and order the supply from the federal DHHS directly. So I think that they're probably the keeper of the supply chain for at a national level. So that at the same time, I believe that there are some state efforts on trying to get state supplies as well. And I can get more. I can look into it a little further for additional contact information on who to contact.
But Commissioners, just based upon that, I can work with Dr. Cho, and we can add that to what we do through our emergency management request forms that go to the state and to obviously to the national stockpile.
Now, wait a minute. I hear what you're saying, but from my perspective, I think that the more we as a commission can weigh in and request this kind of thing, it just adds another level of urgency to the situation. Keep in mind, people, this is something that is being asked from almost every community in the state of Florida. We are in crisis in this state, as far as I've been able to tell, unless I'm just living a different reality here. And I can think of 3 or 4 of these kind of things that as a commission, I think we have a responsibility to weigh in and do our part to ensure that these things are being paid attention to. And I have heard over and over in our policy calls how many times our folks have been asking for this stuff, and we still don't have enough of it. I am over it. Thank you.
Commissioner Eggers? You're muted, Dave.
You're muted.
Thank you. It has to be once at least, right?
Yes.
Between Barry and Dr. Jameson, that kind of to the issue of a supply of PPEs, specifically masks for our hospitals. There was a report today that said that I guess nurses were saying that there was shortages of masks at hospitals, and I'm assuming obviously we're in touch with our hospitals if we can help, although we may not get the same kind of masks. And the hospitals, I think in the article, were saying that's not the case. So that's the first part of that is on the supply side. The second part is back to your comment about the stress that's going on within the hospitals. Are you seeing that stress manifest itself between the folks that are on that front line working every day and what policy setters are trying to do? Or just a quick comment on that, because I think it's important that our residents continue to hear that as part of the things that are driving us, and that is to take care of our hospital system, whether it's capacity or quality of care or whatever it is.
So let me address the first piece, which is the PPE. So understand, hospital systems have large purchasing systems. Their drugs, their PPE, and everything is obtained through corporate purchasing policies. They do not come through the county unless they run short and they request that from us. And that occurs even within the nursing homes. We are not the primary supply of medical supplies and equipment for hospitals or for nursing homes. We have and stood up to where we are able to support them if they run short or they have needs. That's one of the early things we found as we went into some nursing homes where they were running short on PPE, but they hadn't requested. We didn't know that. But as we found that out, we made sure that they understood that we were able to support them where they're running short. So first, I think we need to put in context our role in that and working with the hospitals. I saw that same report, and if they're running short, they certainly can request, and we will support them. And doing that, that's the reason, as you're aware, we we stood up a second supply chain to be able to stockpile and make sure we're ready for any shortages that anybody has in Pinellas County.
So really, Barry, the point is we're not getting those requests right now in numbers from the hospital at all, and even really from our long-term care facilities.
Well, we do, but I would have to defer, and Kathy Perkins and Lourdes is on the line, and so they certainly can speak to what type of request they're getting. But if we get a request, absolutely, we fulfill that request, and they've fulfilled thousands of requests where it's where people have had issues or running short or anything like that. So we're prepared to support them, but it's based upon a request because again, the vast majority is done through normal purchasing supply channels of those institutions. And we're there to support them and back them up, but they got to request that of us. If I don't know that they need something, then it's hard to support them.
Yeah, well, it certainly wasn't meant critically at all. It's just simply meant as a position, kind of what our position is. How are we set to help if needed or if asked? So I appreciate again Kathy and all the work that they're doing to secure those PPEs. I think that's an important component. And I think we do have that product. We're not as aware perhaps of what their issues are within the supply chain of the hospitals, but we're assuming since we're not hearing from them that they're probably okay. At least that's what they're claiming as well.
Well, and so we have regular calls. I know, Lourdes, you talk about it, having regular calls with the hospital executives. I mean, I think we can put it out there that we're willing to help in any way politically that we can to hurry up things in the supply chain if that's needed at any time. I mean,
right.
Yeah, and those are the calls that we have, and Barry, nailed that answer as far as their corporate. But we do have nursing homes that we are assisting because we get a report from them. So if there's something that they can't get, Season over in Kathy's shop gets right in her car at any hour of the day or night and has supplied, gloves, masks, gowns, etc. We are supplying the testing sites, including the Baycare Tropicana with PPE. Advent is bringing up a site. We're providing all of the PPE for that, so it's constant.
So Dr.
Support.
Jameson, thank you, Lourdes. For Dr. Jameson, then from within the hospital that you live in half your time, if not more, are you sensing any shortages there from inside? Or any problems, complaints that you're getting a feel for?
No, I haven't personally seen that, but again, I'm only in one hospital. I've had everything I need there, and I'll tell you that we've actually in the last week or two, we've actually increased the level of PPE that we're using due to the increased amount of disease we're seeing.
Well, thank you both for those responses. These articles come out and you just like to get to the heart of the issue that they're trying to raise and either, do away with it or address an issue that there might be there. And again, I think it's just, again, the messaging to our residents are that we are supporting our hospitals when they need it. We're supporting our long-term care facilities when they need it. But at this point, everything seems to be okay as far as PPE goes. And I know your point, Chair, that's a great point, and that we do stay in touch with them daily, the hospitals, if not every other day. So we have a pretty good handle on what their needs are. So anyway, thank you for that time. Appreciate it.
Thank you. Yes, Commissioner Peters.
Yeah, I was just wondering if we could get Lourdes to talk about the hospitals and staffing. I was taken aback when she made a comment on the call on Tuesday about staffing nurses. I think when I heard it, I was really surprised, and it's something I hadn't thought about yet. And I think the public would find it interesting because the people I've repeated it to have said the same thing, that was something I hadn't even considered or thought about it. And so we talk about hospitals and is it the beds or is it staffing? And if she could kind of elaborate about what happened at Bayfront, I'd appreciate it.
Sure. And what we've been talking about when we meet with the hospitals, and it's exactly right, Commissioner Peters, it's more an issue of staffing and having nurses. So we have put in a request to the state, Kathy Perkins has through her office for
Lourdes.
the HCA hospitals.
Lourdes, you're breaking up a little bit. Your connection's bad wherever you are right now. I mean, we'll try to, I would say go ahead and continue comments, but we might have to mitigate that.
Yes, we've put in requests to the state for nurses for the hospitals. That is correct what you said.
Oh, okay, so the other question, what I was looking for is that there was issues with, and maybe you can explain it to me, and I misunderstood because I can't ask questions on that call. So you said that we contracted with some nurses, or there was a contract for nurses to go into one hospital. And while they were there, they got a call that they would get paid more money to go to a different hospital. So they walked out and left. Was that true? Did they just walk out and leave and go to another hospital because they could get paid more? Is that kind of what's going on? Is there price gouging going on?
Yes.
Oh,
Yes,
okay.
that's what the hospital reported.
Okay.
And commissioners, based upon your request, we also have a few of the hospital CEOs that we've invited virtually to our meeting on Tuesday. So you'll be able to talk to them directly.
So I just want to finish that conversation. And Commissioner Long suggested we send a letter about the medication, but I think what's going on really is almost price gouging. And I think that's a real problem when we contract with nurses to go into one hospital and then they up and walk out and leave because they can get more money in another hospital. Is that something similar to price gouging? And is that something that we should bring up to the Attorney General and that we can rein that in, because we can't have nurses walking out in the middle of the shift when we have patients that need to be taken care of. And so, you know, we're going to consider writing letters. I think that's one to the Attorney General that we might want to consider. Just a thought.
Right. I think I would want some more clarification on what's actually happening. I guess I heard, and we lost Lourdes. What I was hearing was that the state had a contract for a lot of money per hour for nurses. And so it's not necessarily private agencies that are setting that price, it's the state of Florida. Is that right, Lourdes?
The state has provided the hospitals with contracts that they can go out and work with these providers for nurses through the state contract.
Which is somewhat more than what the hospitals are paying directly.
Yes, and that is a national issue. That is not a Florida issue. That is not a Pinellas County issue.
Okay. Well, I'm not sure what the solution to that one is then. Again, if we figure out there needs to be advocacy somewhere, I feel very comfortable speaking on behalf of this commission, and I know Barry does.
And
if there's something we can address.
I would ask Lourdes if they bring that, have you discussed this on your emergency management calls with the state? I mean, obviously they're aware of it, so.
Yes, they are aware of
it. Okay. There's a lot there unsaid. And maybe we need to address this next week with the hospital execs and see if there's any way that we can insert ourselves in the process or at least boost response.
Yeah, because like our nurses, our contract nurses down at the Mojave site, that's went well. So, you know, in some areas it's working just fine. I'd like to get clarity from the hospital CEOs as to what's actually occurring within the hospitals, and is there a way that we can assist in that? Happy to do that. I don't, if the state's aware of it, I'm not exactly sure what to do, right? But we certainly would weigh in and opine or help in any way we can. We haven't seen that at the Mojave site. Those nurses are working their butts off and doing a great job. And that, to my knowledge, we haven't lost any.
Right.
And we also have some at the Tropicana site as well through the Department of Health statewide, and they're perfect.
Okay. Commissioner Akers?
Yeah, I'm just trying to understand this dynamic a little bit, and maybe it is a very complicated one. When we hear that there are additional nurses available through a contract, you just kind of say, oh, great, and you don't know where they're actually being recruited from or where they're coming from. It's not like they have a warehouse of nurses just sitting there waiting to be called upon. So they're obviously recruiting them from somewhere. And I think that's, to Commissioner Peters' point, and I think it's a good one. I don't want to be a part of any system that is, I'm not sure what the right word is, but cannibalizes nurses from other hospitals in the middle of a shift or otherwise. I mean, the fact that we're having this issue, just moving pieces around on a board doesn't make a whole lot of sense, and it certainly doesn't leave the folks that are working in our hospitals feeling very good about themselves if they're being picked off or new people are coming in there that have been pulled down from a hospital across the way or something. So I think that it could potentially be a major issue going forward with our hospitals, our own hospitals, but also hospitals other places. I don't want our nurses being taken away as part of a contract either. So whatever is maybe helping us in turn really may be hurting somebody else, and at some point it's going to end up hurting us. So it's an issue, and I think we need to at least try to understand the dynamic, but at least have a statement that says we don't support that at all. I feel strongly about that. Thank you.
Commissioner Long?
Yes, my comment is more of asking for a clarification, because I thought I heard somebody in the conversation mention nurses walking off in the middle of a shift. Nurses are licensed by the state and they have an ethics requirement. I believe that would be considered abandonment. And I'm pretty sure the nursing medical board would take action against their license, and or the health department would, somebody. You can't just leave a patient in the middle of a shift. Is Dr. Jameson, Dr. Cho, are either of you able to answer that question, just for clarification? Because if they're licensed, they have to be licensed in Florida, I'm thinking, don't they?
Generally, yeah, they would be licensed state by state. There are some reciprocity. I'll just say that when other areas of the country went through their surge, there were many brave nurses and physicians and other healthcare providers from Florida that volunteered to go up there on contracts to augment their staffing. And so that is something that happens as one area of the country surges. I did not hear anything in the conversation specifically about somebody leaving in the middle of a shift or abandoning a patient. I think my understanding was that they were just seeing extreme competition for these nurses, and therefore people were able to demand higher prices, and they were disappointed that they weren't getting folks because they were being outbid. But I would have to defer the exact details to the folks that were in charge of that particular hospital.
I'll add to Dr. Jameson's point. Yeah, I haven't heard the walking out of middle of the shift. That does constitute abandonment to some degree. So I don't think that's occurring on a major scale. I think it's to what Dr. Jameson mentioned, that they may be floating from system to system, but it's hard for me to say. But with that being said, I think we need the input from the hospitals to really further this discussion. I know they've been working really hard behind the scenes, trying to do more overtime for their staff. I know the hospital systems have been working with the locum tenens, so I know their staffing challenges and needs are changing from day to day. So I think having them to speak on their current need and what they were with the gap, despite some of the efforts that they've made over the past week, is going to be important to this conversation.
Okay.
Thank you.
Anything else right now before we take public comment? I do want to say before we take public comment that we've gotten a number of emails related to the school system, and Dr. Cho, I know you wanted to say something about that. We don't have any authority over the school system and whether they open or not, nor does Dr. Cho. So I understand your distress. I have a bit of distress myself about the schools opening in a few weeks. That's a scary notion, but Dr. Cho, I know you wanted to speak to that.
So thank you for that. So in terms of the reopening and the discussions, DOH does serve on a more advisory role. I've been working with the superintendent through our medical committee, comprised of myself and a number of other medical professionals and infection preventionists as well, experts. So giving the guidance, trying to align with the CDC guidance in the traditional model in terms of distancing, in terms of masks. So in some of the good points of the plan, it has been, it's a well thought out plan. I appreciate and applaud the efforts of our superintendent, Dr. Grego. It does give the options for families, including the traditional, the MyPCS online, as well as the virtual. There is, with the traditional model, are going to incorporate a component with the masks. And I know that the superintendent and the school board has ordered over 500,000 masks, I believe. Additionally, some of the efforts that they've made includes, just so that there isn't interruption or at least address the technology gap, that they ordered an additional 41,000 laptops as well. So I appreciate their planning, their insight on some of this. Some of the concerns with the traditional model, and something I've expressed here as well, is just because we are seeing the disease out in the community, there is that potential, good potential. We shouldn't be naive to the fact that we won't see cases in the schools. We will see it. There has been some recent studies that does show that children, especially younger children, are less effective transmitters and spreaders of the illness. However, it's not impossible. And certainly the spread, and especially to the vulnerable population, is a concern. The other issue is if you follow the isolation guidance, when they do have a case within the schools, that there will be interruptions with classroom closures. And if there's a larger outbreak in clusters within a school, that it could result in school-wide clusters, resulting in interruptions from a childcare aspect, but also from an educational experience point of view. So those are some of the concerns. I think I've expressed them here before as well. But again, working with the committee, working with the schools to maximize any of the social distancing with the traditional model. And and I spoke to Dr. Grego and speak to him on a regular basis. We'll have a continued discussion with him as we move forward, monitoring the trends.
Thank you. Commissioner Welch.
Thank you, Madam Chair. I happened to listen to that school board workshop since we had a free Tuesday. And I agree with Dr. Cho. It's very informative. And I think Dr. Grego and his staff have put together the best plan they could. It does have an option for parents that choose to keep their kids home, actually 2 options to do that. But as Dr. Cho said, it's inevitably going to lead to some spread. And, we're going to hear from the public, and there are going to be folks that want us to do more, including a shutdown, and folks that want us to eliminate the masks. But as I think the sheriff said on your EPG meeting, there's probably no bigger potential impact than, 100,000 students going back to school. Even if only half of them go back, 50,000 spread out across the county. That's the real concern. And I think, Renee Flowers and Dr. Carr and other school board members had some, I think, really insightful comments on that. And they are not just going forward and putting the kids back in school. But I think that's something we really, when we talk about Dr. Jameson saying our hospitals are already stressed, we should be concerned, is this the spreader event that takes us over? So I'm really concerned about that as well, Madam Chair. I will note my daughter, who was accepted to FAMU, was notified that they will be all online for the fall. So if universities are going to be online, you wonder why K through 12 is going that same direction. My question to Dr. Cho is, when you have that event that's inevitable at a school, do they have the access to rapid testing? And the reason I ask that is we're hearing from folks in the community that think they're sick. They go to get a test, and that might take, since we have Mahaffey, it's much better. But you take the test, and then it's 7-10 days before you get results back. And folks don't know what to do in that interim period. So where are we on getting more rapid tests for the community? And then if someone is sick, they get a test, should they self-isolate until they get the results back, or what are we advising folks to do? Those 2 questions.
So let me start with the rapid test. I think we've done well as a community, just working with various community partners to really increase that access to care, access to testing, with Mahaffey just doing it anywhere close to like 900 a day. They've been just amazing, along with our community partners in CHC, Baycare, DOH doing those testing. So I think that's great. But to your point with the rapid testing, just with the more testing that we're seeing, sometimes it does back up, especially if you use the larger labs. so delaying some of the test results. In terms of what we're planning to do and having early discussions with community partners is with the limited supply of those rapid tests, how can we leverage it for the school? So we have started engaging that conversation to see what we can have if we do identify a case within the schools, for example. So that we're still working on that, but looking to find and partner with ways to do those rapid testing. And I apologize, your second question. Oh, in terms of someone's with a test pending, especially if you're doing the test, when you are presenting with a test, and especially if you're symptomatic with the classic symptoms of COVID, yes, you just because you don't have the test on hand doesn't mean that you're not infectious, right? Yeah, if you're symptomatic, you're essentially infectious. In fact, if the studies does show that even if you're asymptomatic or 2 days before the onset of symptoms, you're still infectious. So beyond the test results, I think it's important, more importantly, to make sure you take that personal responsibility to stay at home and isolate accordingly, wait for the test. What we've seen here, unfortunately, in some cases is people symptomatic with a test pending, showing up to work, you just expose your whole workplace. And we don't want more of this. And if I can reiterate and repeat that message, that it's important to isolate if you are showing the symptoms, any symptoms of COVID. So.
And just one final follow-up, do you see a point in time where a person going to a testing site like Mahaffey will get a 24 to 48 hour turnaround? Is the technology moving in that direction? And I guess to Barry, is this a supply issue? Is there anything we can do to get that kind of rapid test here for the community?
I think they're moving towards that, and I know the governor mentioned something that's what he's striving for at a state level to get the more rapid turnarounds. It's just, again, this is a global pandemic, and the strains within the lab capacities is sort of at a national level. So if you use these national labs, they do get inundated. They've seen massive tests nationally, so that probably is resulting in some extensions and turnaround issues. But in terms of the rapid test, I know that we've talked about it. There are, again, and Commissioner Long probably will be upset with this, but supply issues with some of the reagents and stuff like that. So again, working to see how we can do some of the turnaround tests. With that being said, we are looking at other options, and rather than the traditional PCRs, continue to look at new testing technologies out there, including the antigen testing. Earlier studies aren't showing it's not as sensitive, meaning that they'll have some falsely negatives, but more and more studies are showing its effectiveness. But the advantage with something like that, and something we're exploring for some of the settings, is that it does have that turnaround time about 12 to 15 minutes. So we're looking at other options similar to that.
Thank you, Dr. Cho.
Commissioner Eggers, I just promoted you.
Yes, thank you for that promotion. Yeah, just Dr. Cho, you just said something about, if you're asymptomatic, even you might have a symptom or two, but I don't know what technically asymptomatic means, but if somebody goes and finds out that they've been exposed to somebody who has been tested positive, so they don't have any symptoms, they have no reason to believe to go get a test except they bumped into or saw somebody close by or near. So they're going in for a test. They're asymptomatic at that point. Should they as well quarantine? I mean, if they're worried, I would think that if they're worried about being near somebody that did get it, that they should quarantine until that results of that test come back. Is that right?
I agree in the quarantine, and now we'll keep pushing out that information. There is a DOH developed an infographic to follow those types of instructions. If you do have a positive, if you're in contact with somebody that's positive, it tells you and encourage people to isolate. So I think the end quarantine. So I think that's important, and we'll continue to push that out. There's this graph I'd like to share with the community or push it out to more.
Yeah, I just think that's so important, because when you figure that out and you go, oh my gosh, and now it's going to inconvenience me, or it's going to put me at, my, kids going to school, whatever it is, whatever the situation is, and they want to get back quickly. And then you have to wait 3, 4, 5, 6 days to get a result. And we've had people email us that some of their horror stories about the wait, or going to a place and, they're not testing there, or they're going to another place. And so the whole system can bog down for a week. And so it just kind of says, well, I probably don't have it anyway. and then they just go back to work before they even got the test result back. And that, so I think the whole system, and I'm really glad Barry talked about the Mahaffey being a really great testing site. So people, if you need it, a test, I know it may be a little out of your way, get down there and get a test. Again, to the point of the return of the results, I think that's just as critical almost, because a week wait, people are like desperate to get back. So anyway, just a comment. Thank you.
And I understand we're really, again, we're pushing on these test results and stuff, but that it's not an issue that we can really control, and it's not because we're not trying. But these are everybody is trying to ramp up testing nationwide, and here are the results. So,
question about tests, Doctor, and I'll call on you, Commissioner Peters, in a second. So how long does it take if you know the answer to this, after you've been exposed to actually show up positive on a test?
The lab results, we've seen, test results just from like Mahaffey come back in, 2 or 3 days. Most of the time it's 3 or 4 days.
No, I mean, after your exposure, how long before you're going to, whatever test they're taking shows that you're positive?
I'll defer to Dr. Cho on that.
So no, there's these graphs. So in terms of infectivity, you are up to 2 days, infectious 2 days prior to the onset of symptoms. Usually with the PCRs, I think it changes from study to study and the exact PCR, but it usually takes about a week or two before the PCRs show the positivity. Generally, you show symptoms about 7 to 5 days from exposure if you are going to show symptoms. What's tough about this particular infection is that what we're finding is that the variability in terms of different symptoms that we're seeing. The classic ones are the fevers and the respiratory symptoms, but people have presented with things like diarrhea, body aches, headaches, and stuff like that as a sort of the presenting symptoms. So it's insidious. It's difficult because of this wide variety of symptoms that they show. What's interesting, one of the interesting symptoms that not a lot of infections have is the loss of taste and smell, which is sort of unique to this. There's not a lot of infections other than things like severe sinus infections and other allergic reactions to medications that really present with that kind of symptom. So I think that's almost very indicative if you develop that kind of symptom.
Okay, and I guess the other point of my question was, so if I was exposed yesterday, how long, maybe I should have phrased it this way, how long should I wait before I go to a test to see if, 1 day, 2 days, 3 days?
Oh, I see what you're saying. Okay, and that's why we quarantine for the 14 days. You can develop, that's generally the established incubation period. So you can technically develop infection anywhere between the time you're exposed and 14 days. Oh, wow. I think the fault that some people make is that the same day that you're exposed and you're not showing any symptoms, they go and get the test. You're not going to be, chances are you're not going to be positive then. It takes a bit for the virus to grow in your body. Maybe near the end of the 14 or after the 14, if you're really curious that if you've contracted it, would be more prudent, especially if you don't develop symptoms in the interim. But getting that test as soon as you're exposed, it doesn't necessarily always help if you're not showing any symptoms.
Well, that just makes things more complicated, doesn't it? Commissioner Peters?
This is for Dr. Cho, and I hesitate to bring it up, but I'm going to. So there was an article, an interview, where someone from the World Health Organization said that it's very rare that an asymptomatic person with COVID will transmit that disease. Is that accurate or is it not? It certainly has spread like wildfire. I've seen the interview. And so I'm curious what your thoughts are. Is it factual that if you're asymptomatic, you are not, it's very rare to transmit this particular virus?
Well, and I can't speak to the World Health Organization comments. I'm vaguely familiar with that. I think that comment was made about a month ago. I think the next day or two, I think they had some clarifications to that comment. And I can't remember the details of that specific comments or even the original comment. But in terms of the asymptomatic spread, there's clearly shows evidence of asymptomatic spread. And in terms of the readability, readily it's spread is another question. We're not 100% sure. I think what also complicates this is that people, just what I mentioned before in terms of the vagueness of some of the symptoms, people are artificially falling into the asymptomatic category when they're minimally symptomatic or they're not noticing that they have symptoms. So it's, we almost say pre-symptomatic in a lot of these cases. So I think that further compounds it. There are some studies, to your point, that with asymptomatics, they may have lower viral load, which does decrease the transmissions. But again, I think we're learning as we go, and to say that definitively, I'm not sure that's there.
Okay. Yes, Commissioner, or Dr. Jameson just gave you a demotion.
Sure. So I would just address that comment as well. I am familiar with the comments that she made and the fact that clarifying comments were issued. I thought perhaps I could read a quick statement from the Harvard Global Health Institute regarding that comment. They said, quote, "The WHO created confusion yesterday when it reported that asymptomatic patients rarely spread the disease. All of the best evidence suggests that people without symptoms can and do readily spread SARS-CoV-2, the virus that causes COVID-19. In fact, some evidence suggests that people may be most infectious in the days before they become symptomatic. That is, in the pre-symptomatic phase, when they feel well, have no symptoms, but may be shedding substantial amounts of the virus," end quote.
Yikes, thanks. Okay. Any other questions? Yes, Commissioner.
We'll
County
leave it
Attorney
at that.
White. Yeah.
And Madam Chair, I know that you already touched on this and that we've heard some comments from Dr. Cho, but just again, before we take public comment, to comment on the issue, because I know there's a lot of community concern about the reopening of schools. I did reach out to the school board attorney and communicate with him on this issue. And again, just to reiterate, the county commission doesn't have any authority over the school system. That's with the school board. And just to bring clarity, it was an order issued by the Secretary of Education that is compelling the school systems to reopen. What it states is at least 5 days a week for all students. Now, I know that there is language in here that talks about advice of the Florida Department of Health and local departments of health. Again, we've already heard Dr. Cho's comments on the school and their plan. Also, I want to clarify for folks, the local Department of Health, even though we call it the Pinellas County Department of Health, it is a state agency. It is not a department of county government. Certainly, one of the things that would bear on this issue is this is an order of the Secretary of Education. That individual certainly has the authority to rescind this order. It could also be addressed by the governor through executive order. And in fact, the order reopening school states as much, that subsequent executive orders could certainly bear on this issue. So again, just wanted to reiterate some of what we've already heard. But again, the reopening of schools is something that this board doesn't have jurisdiction over. That lies appropriately with the school board or potentially with the Secretary of Education or even the governor.
Thank you. Okay. So do we have any public comment, Brian?
Sure. At this time, if there are any members of the public that wish to speak on this item, please hit *9 if you're coming in on a telephone line, or raise your hand virtually in the Zoom meeting. And Madam Chair, it appears we have about 8 or 9 speakers that wish to be heard. What is your wish as far as time on the public comment?
Well, I think the norm 3 minutes is fine.
Okay. So we'll go with our first speaker. Our first speaker is Dawn. I do not have a last name. So Dawn, if you'll go ahead and unmute yourself, give us your first, last name, spelling, and address, and you'll have 3 minutes to address the board.
Yes, good morning. My name is Dawn Bowler, B as in boy, O-H-L-E-R. Address is 66 South Avenue North, St. Petersburg, 33709. First, the percentage number of cases has been inflated as came out on the news on Tuesday, which included 2 locations in our local area. Second, when it comes to deaths, it has also been announced on more than one occasion that our numbers include deaths of other causes, but still test positive for COVID coronavirus. Example, someone in hospice is dying of an X, Y, or Z cause, tests positive and dies, it's a COVID death. As far as the PCR testing, I have a question. PCR is also referred to with HIV, hepatitis, some STDs, other communicable diseases, and even some cancers. My grandmother had just recently tested negative multiple times in a matter of weeks, came down with C. diff, in which PCR is also mentioned in research, and is now suddenly testing positive for COVID or coronavirus. Is it probable that the tunnel vision and mass testing urgency has removed the proper vetting of these tests, leading to a higher positive rate that can be due to for other medical causes, leading those now potentially undetected medical causes to be ignored, or ignored misdetection of other types of less severe coronaviruses, such as a common cold, to be part of these numbers, especially given it just came out announcing a test to determine difference between flu and coronavirus? There has been a significant narrative change from COVID-19 to coronavirus. We still periodically hear COVID, but coronavirus is very much used now and defined as a type of common virus that infects humans, typically leading to an upper respiratory infection. And there have been seven different types of human coronaviruses identified. So I guess my question is, how do we actually know that the testing outcome is accurate given other potential things going on?
I think we'll return to that later. Okay.
Okay, Madam Chair, our next speaker is Mr. Dave Waddell. Mr. Waddell, if you'll go ahead and unmute yourself, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Happy birthday to you, Commissioner Karen Seal. I can't finish that. Time is precious. Honorable Chair of the Board of County Commissioners and staff, I want to thank all of you for your dedication. I'm going to read you a real-time scenario of my exposure. April 2nd, 2020. I picked up Buddy my lab's antibiotics. April 24th. This is at the vet, 2020. Buddy and I visit the vet for a checkup. May 26, 2020. Buddy and I visit the vet for a checkup. June 8, 2020. Infected staff employee at vet last day of work. June 9, 2020. Infected staff employee tested positive for COVID-19. June 10, 2020. I drop off Buddy's file and related surgical paperwork. June 12, 2020. Buddy and I visit the vet. The vet is in surgery and we cancel. June 16, 2020, 2 hours spent waiting to see the vet. He determines we can hold off on surgery and keep an eye on things. Does blood work. We had sat in the office the whole time, 30 patrons. June 17th, contacted by the vet clinic as a courtesy that I may have been exposed to COVID-19 by an employee at the clinic while they remained open, that they were voluntarily closing and notifying exposure to clients. I asked if other personnel had been infected and told that they cannot provide that info. I was then directed to contact the executive director, which I did immediately. We spoke and I explained the seriousness of the situation and if he was going to contact the county health department. I was shocked when he said no and asked me to forward his personal cell contact info and the name to the health department. June 17th, I contacted the county health department. As you can see in my opening statement, no real direction and no information as to how to proceed. In fact, I was discouraged from getting tested. June 18th, I again contacted the county health department on 4 attempts to gather information on my exposure, but that HIPAA did not make that possible. Now, if we're not going to roll back the business openings, I suggest that we have mandatory reporting by businesses of any employee that tests positive and that they close down for 2 weeks. This is happening thousands of times a day in this county, and the self-policing and civic responsibility clearly is not working. This is a tool in the toolbox. These businesses are regulated with oversight by not only the county and the state, and you do have the authority to require mandatory reporting. If you want a tool in the toolbox, because contact tracing right now is off the charts, we're not going to be able to do that. But mandatory reporting could be a real key for us to at least slow the exposure.
Mr. Waddell, your time has expired.
Please, I don't understand why, if we're going to keep businesses open, we can't require them to report. Once again, I want to thank you for your dedication and God bless all of you. Please consider mandatory reporting.
Thank you.
Madam Chair, our next speaker is Trevor Burgess. Mr. Burgess, if you'll go ahead and unmute yourself, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Thank you. In the past 2 weeks, over 5,000 Pinellas County residents have tested positive for COVID. You heard today we're at record levels of COVID hospitalizations. We're at record number of our citizens on ventilators. We do not have sufficient supplies of the one FDA-approved antiviral. We are at record levels of dead neighbors. We can learn from other countries, states, and counties that have properly controlled the spread. Do not ignore these lessons. We must control indoor gatherings to reduce spread. You are late. You should have taken action weeks ago. But don't let another week pass without limiting indoor gatherings to groups of 10 or fewer. Thank you.
Thank you.
Madam Chair, we have 10 speakers remaining. Our next speaker is Ms. Karen Mullins. Ms. Mullins, if you go ahead and unmute yourself, give us your first, last name, spelling, address, and you'll have 3 minutes.
Good morning, Karen Mullins, 678 Oakwood Drive, Dunedin, Florida. I just want to make 2 comments. Number one, yes, we know that you guys cannot deal with the school board, but you will be dealing with the ramifications of the schools opening. And we are going to be hit hard when they do open. And that is on the county. The second thing is, yes, Dr. Cho works for the state. The state is not doing their job. We have to do it for them. Please start bringing in some more restrictions. We have to do this. Dr. Jameson, thank you for your report. Dr. Cho, I appreciate what you're doing for the county, but the state is not doing what it needs to do for us. We have to do it for ourselves. So please, 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 let's take care of this and do as Commissioner Long suggested.
Been tremendous, and not a word mentioned about a bird. You should be happy about this. So please, we want some action. There need to be further restrictions. People, they don't wear their masks, right? We have a mask ordinance, that's great. But here's what I think we need to do. Stay in place, shelter at home until the numbers come down, then have everybody wear masks and go back to normal life with everybody being masked. That's not going to happen in my household because my husband works for a very large corporation based out of Oldsmar, and they've shut down, and they're not bringing workers back. So, you know.
Your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Thank you. Can you hear me?
Yes, ma'am.
Thank you. My name is Allison Barden, Seminole, Florida. I wanted to address the whole, if someone can actually answer the questions that are being proposed by us. When a person is testing positive and they go back for to get tested again, they're trying to get cleared to go back to work. If they test positive, one, is that positive test just identifying that the RNA is there but not active, or is it identifying that it is active? Furthermore, if it is tested positive again, does that actually count as another positive case, even though it is the same person? So if somebody could address that. Also, something that is happening, when tests are positive, the Department of Health is getting notified, and they are calling and trying to do the contact tracing, which I commend them for their efforts. However, the actual labs are reporting to the DOH, but then they are not reporting to the individuals in a timely manner. So in this respect, I'm getting a call from the Department of Health, and I'm still waiting for official results from LabCorp. So if there's anything that we can do, obviously they have the information. Why is it they cannot notify the individual? They are only going to the Department of Health. And with that, I'll concede my time. Thank you.
Thank you. We'll try to get to that after public comment.
Madam Chair, our next speaker is Tara Siegel. Tara, if you go ahead and unmute yourself, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Good morning. My name is Tara Siegel, Tarasegall. I live in St. Petersburg.
Okay.
I was just wondering, I know that we can't address the opening of the schools, but we have talked about how that would affect the community. I haven't heard yet what the specific criteria that the health department is supposed to use on whether or not to open the schools. So I was wondering if maybe Dr. Cho could address that in a public way. And I'll concede my time.
Thank you.
Well, again, the public health department does not make that decision, but they're simply advisory. Next speaker.
Madam Chair, our next speaker is Glenn Reihing. Glenn, if you'll go ahead and unmute yourself, first, last name, spelling, address, and you'll have 3 minutes to address the board.
Thank you. My name is Glenn Reihing. Last name is Reihing. I live at 524 61st Street South, St. Petersburg, 33707.
Thank you.
And anyway, last week I spoke at this group about the use of the National Defense or National Disaster Medical System, a federally funded group coming out of the VA that provides disaster teams to areas of the United States where there are overwhelmed with medical issues. And I haven't heard any discussion today when you were discussing about the needs for nurses that had any issue that brought any light to this issue as to whether or not you guys contacted them. So again, I would reiterate that it might be a good thing that if you're looking for extra help, extra hands on board, to contact the National Disaster Medical System. The other point I'd like to make is, and Dr. Cho and Dr. Jamison would be more interested, bear me out on this, was the fact that with the kids going back to school, and I know you guys don't have any issue on this dog in this fight, but the thing is, you got to consider if you got an 8-year-old kid that is COVID positive, but asymptomatic, which means he is not showing symptoms and he cannot show symptoms up to 14 days, you put him in a schoolroom and the air handlers in those schoolrooms are not efficient enough to circulate the virus out of the classroom. So my question is this: how efficient are the air handlers in those classrooms to get rid of the COVID virus? Because now you've got 30 kids in a classroom sitting all day with an infected kid, and it only takes one, and now they're inhaling COVID virus. And so anyway, that is a question that I've been trying to get an answer to. And I realize that if the board opens that Pandora's box and find out that these air handlers are insufficient, it's going to run into the millions of dollars to retrofit the air handlers in order to make them sufficient enough to protect the kids. But my question to that is, how much, what price is a kid? So, and that's my time. Thank you.
Madam Chair, our next speaker comes in on the phone line, last 4 digits 7233. If you'll go ahead and unmute, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Joellen Murphy, JoElin Murphy, Dunedin, Florida. My concern is everything needs to shut down for 3 weeks, including the bus service, because you have bus drivers now getting sick. Everybody needs to close down for 3 weeks and let this stop. Them poor doctors and nurses do not have to lose their life trying to help others. I thank them for their job, but it's very seriously out there. If you don't know anybody that has it, I do. A 29-year-old girl who almost lost her life. We need to take this serious. And if we're waiting for the governor to do something, we might as well all die tomorrow, because nothing's going to be done. We need to step up and do something. Thank you.
Thank you.
Madam Chair, we have 5 remaining speakers. Our next speaker is Adnan Kampara. Mr. Kampara, if you'll go ahead and unmute yourself, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Hey, how you guys doing? Can you guys hear me?
Yes, sir.
Yeah. Adnan Campera, Largo, Florida. How's everybody doing today?
Good.
Good. Can anybody on the board actually confirm how many people I'm addressing in the meeting besides the board? How many other participants are in the meeting?
We have many in the meeting plus online, whoever's streaming in to view this. So
Okay.
I can't give you an exact number, sir.
That's okay. I appreciate the platform. My message is actually to the people. I just want to just voice my concern and just let you know, I do not believe any of this pandemic. I believe this is such a scam. Anything that has to do with the rules and the legislation and the lockdown that the Board of County Commissioners, the state, local, federal government has been put in place, that has killed more people than COVID has or ever will. I'm telling you right now, this is a scam. Break this lockdown. Do not comply with these rules. Do not wear masks. Do not social distance. That's my time. I don't need 3 minutes to tell you guys. Use critical thinking. Do what's right.
Whoops.
Thank you.
Madam Chair, our next speaker is Christine Petroulis. Ms. Petroulis, you'll go ahead and unmute yourself. Give us your first, last name, spelling, address, and you'll have 3 minutes.
Thank you. Can you hear me okay?
Yes, ma'am.
Okay. My name is Christine Petroulis. I live at 9924 Indian Key Trail in Seminole. I am a teacher and I am a registered nurse. And Dr. Cho, I'm tickled to see you here. I feel thankful that you're here. So thank you for all that you're doing. But I am absolutely petrified for the teachers and the children that have to come back to school. Right now, about 50% of the teachers in my school have a medical condition that can end them in one of the local ICUs. Are we prepared for the number of teachers with medical conditions that are going to come back into school because they do not have the ability to quit their job because of their pensions and their health insurance, or give up their careers for their lives? There are a lot of teachers with serious medical conditions that are on immunosuppressant drugs, that have family members going through chemotherapy. Do we have the space in the hospital to handle the influx as what's about to happen when we open the schools? Please consider them. They're really, really scared, as am I.
Thank you. Madam Chair, our next speaker is Reverend Andy Oliver. Whoops, hold on, let me make sure I unmute the right person here.
It's not Andy Oliver.
Yeah, Mr. Oliver, if you'll go ahead and unmute yourself, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Hi, Andy Oliver, pastor at Allendale United Methodist Church, St. Petersburg, Florida. I listened to the long school board meeting the other day, and I'm hearing a difference of opinion between the school board lawyer. Also, I checked this out with school board member Flowers. This was in the conversation between school board member Carr and the lawyer. The Cochrane executive order requires schools to open in August. Many school districts are opting to delay the start of school. The lawyer said there were 2 ways to give the school board an opportunity to delay the start of school and still be within the Cochrane executive order. One is for the health department, the local health department, to advise that it's not safe to reopen, and that gives them the ability to skirt the order. The other way is for the county commission to move us back to phase 1. Moving us back to phase 1 does not mean the school board has to delay the start of school, but it gives them the option to delay the start of school and to do so within the Cochrane executive order. So I'd like some clarity around that, because whereas I do think we all should be washing our hands, I don't think the county commission should be washing their hands of the authority to be able to give the school board the proper ability to make the best decision. I would also be interested to hear from the doctors what ways they're going to be advising the school board if things remain as they are now or worse about delaying the start of school. Thank you very much, all of you, for your service. and especially Commissioner Welch for your continued witness at Black Lives Matter. Thank you.
Thank you.
Madam Chair, our next speaker is Mr. Orlando Acosta. Mr. Acosta, if you'll go ahead and unmute yourself, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Good morning, Orlando Acosta. That's A-C-O-S-T-A. I reside at 1155 53rd Avenue North, St. Pete, 33703. Thank you very much and good morning. I respectfully request the board implement and enforce, without exception, a mask requirement for all who leave their homes. The benefit of such an act is evident in the low or declining COVID infection rates in populations who've done so around the U.S. and around the world. The simplicity of the rule makes practice and enforcement by everyone more likely. And for those claiming they cannot wear a mask for health reasons, they shouldn't be exposing themselves to the virus in the first place and remain at home. Bona fide citizens at risk are already protecting themselves as necessary. I also want to thank the board for its new COVID-19 testing site at the Mahaffey in downtown St. Pete, free to all residents and regardless of symptoms. I and my 3 stepchildren got tested there this week, and the process was superlative for its organization and efficiency. Now, we got tested because their registered nurse mother tested positive at Bay Pines, and that was despite all their best efforts at controlling infection internally. The infection most likely occurred externally. She, like so many other medical professionals in our area hospitals, is succumbing to the unpatriotic cynics in our community that are spreading the disease through their willful negligence, succumbing to the bully on this board and her selfish supporters undermining basic science and public health practices, and succumbing to the fraying of America's social fabric that would bind us together in common values and against a common threat. She and I are the second generation in our families to serve in the military, continuing an almost unbroken line of service our fathers started over 5 decades ago. We don't shirk our duties to country or community, nor bend to any threat, even Mother Nature's. We adapt, we improvise, we overcome like every good American. And right now, we're adapting to the lack of leadership in Washington and Tallahassee by not sending our son to his first quarter at Dixie Hollins. We as a community have not done enough to ensure his safety, nor the safety of his classmates, nor the safety of our neighbor, a teacher at Largo Middle, nor the safety of all the faculty and staff who've helped us raise our children. With science being compromised in Washington and Tallahassee, we are dependent on our local medical experts to remain committed to science and their profession. And we offer you, our county elected leaders, our support in doing the right thing for the greater good of our generation, and especially the next, so they can get back to school. Again, thank you very much, and thank you for all you do for the citizens of Pinellas.
Thank you.
Thank you. Madam Chair, our next speaker is Amy Wright. Ms. Wright, if you'll go ahead and unmute yourself, give us your first, last name, spelling, and address, and you'll have 3 minutes to address the board.
Hi, my name is Amy Wright. Last name is W-R-I-G-H-T. I reside in St. Petersburg. I'm just asking that you guys continue the state of emergency and that you take all efforts to, enforce that, we are complying, but also that, that we're doing everything that we possibly can. I'm someone who has gone through chemotherapy. My husband is a frontline worker, and we didn't even know that he had COVID. The only way we found out was because he did a routine test because he needed an endo. And so there's people like me out there who can't protect themselves when they go to doctor's appointments because they have family members who are getting exposed and bring it home, or they go to doctor's appointments and get it. So I understand that there are a lot of people that are viewing this as unconstitutional, but there are people like myself that have a right to go to the doctors, and we have a right to be safe, and safety goes above constitutional rights. So I just hope that you guys continue to extend this state of emergency because it really is making a little bit of an impact for people like myself who just need, we stay home as much as possible. I don't ever go out, but I have to go out in order to receive treatment, and I have a right to be safe. And I just hope that you guys take that in consideration because my life matters too. And I don't want to die from COVID when I'm working really hard to survive cancer. So I just hope you guys take that in consideration. Thank you.
Thank you.
Madam Chair, our next speaker is, I have first initial S, last name Mack. If you can go ahead and unmute yourself and give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Hi, my name's Susan Mack. I'm in North Reddington.
Thank you.
I was just wondering, what is the threshold for ending the mask mandate? Is there a threshold, or are we just making this up as we go along? Thanks.
Thank you.
And Madam Chair, there are no other members of the public that wish to be heard on this item.
Okay, great. There are a few questions in there. I guess the last one we don't really have an answer for yet, but I'm sure we have some ideas.
Madam Chair, just for the record, we did have one more hand go up. Do you want to still entertain public comment?
Sure, but this will be the last one.
Okay, so our next speaker is on the phone line, last 4 digits 2856. If you can go ahead and introduce yourself, give us your first, last name, spelling, address, and you'll have 3 minutes to address the board.
Yes, my name is Marcus L. I live in Seminole, Florida. I just want to address the board and vent my frustration for these mask ordinances. As you know, where there's lawsuits being filed all over the place, Hillsborough County had to recently update their mask ordinance. I ask you if there's any talks about updating your mask ordinance here in Pinellas County. Also, that being said, I wanted to ask everybody, what is the current statistics as far as the testing rates? There was a recent study or article that was done citing the 30 testing facilities that were actually reporting 10 times the positivity rate. The numbers that you guys are reporting, the numbers that these experts have been giving, have been lied to us from the start. You need to stop the mask mandates, stop all this bull crap, open up the schools, open up the public. We need to get back to the governments. That's all I have to say. Thank you for your time.
Thank you. Okay. A couple of questions, I think, for Dr. Cho. One lady asked, how do we know when we do a test that it's actually COVID-19 and not the flu or something like that?
Oh no, so I think I wrote that one down. In terms of the PCR test, there have been a number of validation studies. It has really great sensitivity, specificity, means it attributes to the accuracy. In terms of the PCR, it's specific to COVID because it gets nucleic acid and looking at the RNAs. So it does not cross-react with C. diff, as I think the caller mentioned, which is a bacteria or other viruses. I think other diagnostic tests such as antibodies can more readily have cross-reactivity with the common coronavirus, but that is not the case to my knowledge with the PCR. So I would argue that the PCR is pretty accurate. Regarding, I think another caller mentioned the persistence of the PCR. So what we're finding, and I think what the studies are showing now, is that usually in terms of the infectivity, it does go away in 10 plus days. So there are some individuals that may continue to show persistent PCR positive. But a huge study out of Korea did show that it was more dead viruses. It does not really confer infectivity. I know the Infectious Disease Society of America looked at that recently as well. And the evidence right now is showing more that the persistent positive denotes, does not represent infectivity, that you're infectious. In terms of the positives, in the positives, the DOH, in terms of the percent positivities, it only counts that person once, so they don't count one person that tests positive and getting the same test and remaining positive. They've eliminated those duplicative tests about 2 months ago, I think, so that you are looking at the unique positives when you're looking at, I believe, both the case count and the percent positivities when you look at the DOH graphs. There was a question on LabCorp. I know LabCorp has a portal. The major labs do report their findings to DOH. So when we go into the contact investigation piece of it, we do notify those folks. But they may have to. The caller needs to probably call LabCorp to get the results, or just again, or leverage their portal. That's the questions that I wrote down. And again, with the school board, again, working really closely with the superintendent and talking to him on a pretty regular basis, working along with the medical committee to make those recommendations, consultations, and advisement.
Thank you. There was another question that we had last week about the National Disaster Medical System. Barry, are you aware of that and what that's about and whether we have any kind of access to that?
I'm not aware of it. Lourdes is on the line if you are, but Dr. Jameson, Dr. Cho may be able to speak to it.
Sure, I can give a little bit of a background. The NDMS is part of the federal response model for major disasters, operates, I believe, under the Department of Homeland Security, Secretary of Preparedness, I believe. It is a federal resource similar to what you see when FEMA deploys teams with field hospitals, field morgues, urban search and rescue teams, et cetera. It's generally used for major disasters. And any request from that would have to be a federal tasking to have those resources respond. And so Lourdes or somebody from emergency management can confirm that that goes from a local request to a state request to the feds for those types of resources to be mobilized. And so that's not something that's currently activated, but it is something in the national response framework.
Okay, thank you. I mean, similar to what we would do with FEMA, I guess, in a national, yeah.
Yeah, if we had
we talked about accessing FEMA funds to address some of this, but
well, yeah, and I'll defer to Lourdes on this, but yeah, we're on these calls and talking about resourcing, and so typically a request like that for this or any type, we request it of the state obviously then request of the federal government. I know of this. I don't know whether there's been discussion about any utilization of that type of resource, but I'll defer to Lourdes on this.
Sure, that's not one that I believe we've put in, Barry, but I know with Dr. Cho, with the augmentation teams for the long-term care, we do have teams that are coming in, but it's not from this site, just so folks are aware.
So to answer that question, we are accessing some other resources.
Yes.
We've activated a number of resources, and right. We will bring this up on our call, and we'll talk to the state about this. But understand, typically, when locals request things of the county, we tell them to ask what you need. Let us figure out how to source it. Well, the state does the same thing with us, and so when we say we need nurses, when we say we need PPE, when we put in these requests. Then they determine the method by which they source that and provide those resources. But I will follow up on this specific area. But it isn't that we haven't requested the resources. It's just not specifically regarding activating these types of teams.
Right. Okay. Commissioner Eggers?
You'll have to unmute Commissioner Eggers.
Okay. Yeah, just maybe, I don't know if it's Jewel or Barry or who might speak to this, but I think Dave Waddell talked about mandatory reporting, and it does seem a little disingenuous when problems come up at a place and they're not required to report, and especially if it's interacting with the public and that their business interacts with the public, as an example, a restaurant, for example. So that was the first question. The second one, there was, I think it was Reverend Oliver asked about the two ways to go around the Secretary of State's mandate to open schools, or whatever he called it. He didn't call it a mandate, but anyway, the Cochrane order, through the health department declaring it not safe, or the county commission being able to do that by going back to phase one. I think the governor is the one that goes from phase one to phase two, but just maybe a comment to those two items.
I'll let Joel just speak to the things she can speak of, then I'll follow up.
As to mandatory reporting, if I understand what the request was to require businesses to report when they have, I'm assuming, an employee, or possibly, I don't know how they would know if they had a patron that tested positive. We could certainly look into the ability to require that. My initial thought, without having looked into it, is that we could require it. Now, that said, we do not get the data on reporting of positive tests. We're not the public health agency. We are not the recipient of that data. And I'm honestly not even sure that the health department would have the ability to share that kind of information with us, because it's basically personal health data.
Right.
Yeah,
I
go
can
ahead,
also
Dr. Cho.
bring it up to our DOH legal on that. I'm sure that they've had those discussions at a state level as well. Yeah, I think some of the barriers have been some of the private information. If you think about it, having an employer having access to their health information, does about HIPAA, does the public health statute, does that cover that? Something that I have to look at.
And certainly, like, you know, we've indicated we could certainly look into it. I would have to say it would really result in a voluntary effort at best, because there would literally be no way to enforce it. You know,
this is going to change each and every day. So somebody's got a test result. Okay, now they're going to be, you know, they get a test. Now they're no longer positive, and then a different employee. You know, the ability to track that, and for us to have that information and act on it with 20,000 businesses, and you know, think about that. We've got the contract tracing. So the way in which you get to someone is through the health department. When they have a positive result, then they in turn do the contract tracing to see who that person has been in contact with. That's occurred within businesses. That's occurred within county government. You know, and that's a way in which you isolate that. It doesn't necessarily, you know, put some kind of a, you know, scarlet letter on that business is somehow unsafe or something like that. That's the contract tracing to see where they come into contact with, who they came into contact with, to where then those people can take proper precautions and get tested, self-isolate, and things like that. And that's the way in which to manage and handle that.
Okay, thank you. The next, there was another question too.
That's on the school board side and the legality of us on the.
Just. I mean, that was a comment made, and you know, I don't want to just leave that sitting out there with
that one. Definitely is a Joel comment or a Joel response.
I wholeheartedly disagree. The county does not have jurisdiction over the school board. We do not have the ability to require them to do basically anything. The state certainly does. Now, when we hear folks make comments like, well, the county could roll things back to phase one. Phase one is not part of the county's plan, nor has it ever been. That's part of the state's plan. Now, you all are aware that you do have broad authority under Chapter 252 rather. Certainly, you all closed your beaches here in Pinellas County before the state took really any strong action on any sort of closure. At least here, you know, within Pinellas County. They may have in other parts of the state down south. You all did have a safer at home order that didn't go quite as far as the one that you implemented after the state took some action. But keep in mind, you all had taken some steps before the state took their action with their safer at home order. So you have some independent authority to do some things. You do not have authority over the school board. And, you know, again, in reference to phase one, phase two, that's a state plan. It really doesn't have anything to do with the actions that you've taken here locally, except that it may inform some of the decisions that you make.
Thank you both. I really agree with your interpretations, but I just wanted to get that out there because they were just kind of questions that were very definitive and hanging. And I think we just need to try to address as many of those as we can. Thank you.
All right, thank you. Okay, there's nothing else. I just wanted to say we had a TDC meeting yesterday. I think it was yesterday. And, you know, talking about how to recover from this whole thing. What does the public think about the traveling public, I should say, the visiting touristy public that is so essential to our economy here. And I think I'll send out this information. They're trying to fashion a new campaign to draw people to the area safely. And it was very interesting to see the research that was done behind the campaign about how people feel about traveling to our destination. And overwhelmingly, people cared about how safe we are, how much we're paying attention to guidelines, how much we're enforcing the things that we have in place. And I've just found that fascinating. I mean, if you read our email, sometimes it's, you know, let's do away with all the restrictions and what do you think you're doing? But the people who are at the basis of our economy, tourists care about how careful we're being. So I just want to send you that information because I was struck with how clear that was. Anyway, anything else before we entertain a motion? Yes, Commissioner Welch.
Thank you, Madam Chair. Just wanted to weigh in with a couple comments. And as we anticipated, there are going to be folks on both sides of the issue saying do more or do less. And just, and listening to the EPG meetings and just observing in the community, it does seem that the masks are working. And, for every person that wears a mask, that's a person who might not be transmitting asymptomatically. So every person that wears one is a win. And, as has been conveyed, we're seeing pretty good compliance just, in Publix and Home Depot. Those are two places I go. So I'm seeing pretty good compliance. And even at the gas station, I was observing the other day, a couple of folks were going inside to pay and didn't have their mask on. They saw the sign on the door, turned around, put the mask on, went in and paid for it. I mean, that's what we were trying to do, just remind folks of why it's important. And a lot of folks are complying. As was discussed in the meeting, though, going back to a safer at home, does it really get to where the problem is? It's more of a shotgun approach, and I get folks are concerned, but I think we have to be surgical. And I think Barry and the EPG have identified things like the bar hybrid restaurants and some of the large gatherings that I think we do need to concentrate on. But I think we're at a good point now with continuing the mask, which is a different ordinance. It's not what we're voting on today. But I do think the schools represent a tipping point. It's not our jurisdiction, but just the numbers of folks who are going back and where our hospitals are right now. I think that is really where the most danger is, quite frankly. So I know the school board is working with this, and they're being advised by Dr. Cho and others. But I think that's really where we need to focus and where the school board is focusing, because it is all connected. What happens there is going to impact our hospital system and EMS and all those things. So Dr. Cho and Dr. Jameson, thank you for all your work, and thank you for supporting the school board. And thank you, Commissioner Eggers, for clarifying that stage 1 question, because that was the first time I'd heard that as well. But anything, just personally, I think anything we can do to support the school board, we ought to do, because they've got a very difficult decision, and it is going to impact the entire community going forward. Thank you, Madam Chair.
Yes, Commissioner Eggers.
Yeah, and then, thank you, Commissioner Welch, for your comments. I do think that we continue to try and understand, what flexibility our hospitals have, and we're learning more about that. And we've had some people say they've called the hospitals and they're not overwhelmed. Well, we know that they are. We know that they're tight on numbers. There is a room there. But we continue, I know, in those EPG meetings to talk about that super SNF or other location that needs to be set up independently of long-term care facilities or here in the county. So a location has been identified, and I just think that for our own sake, for relieving the pressure in the hospitals, for relieving the pressure at the long-term care facilities, for whatever the school outfall is. I mean, the kids, the teachers, especially those who might be more vulnerable, that get infected, are going to get to the hospitals, and we're going to have to find relief valves. And so that facility, again, that we've talked about since the beginning, and I know it's complicated. This is not a criticism. This is just, I really think that needs to be of great importance to try to establish, or at least get it further along. Because if we said, okay, we need it today, it probably wouldn't be available at least for 6 months. I'm just guessing. I don't really know the condition of that facility that we're talking about, but I would say it's a far cry from being ready. Now, maybe I'm wrong, but I think we ought to know that. We ought to know if it's available. We ought to know how long it would take to set up, and we ought to know how it's going to be staffed. if it can be staffed, because of, we've heard about all those staffing issues. And so I just want to, encourage staff, and I know that they are looking into it, that can keep that as a priority. That's just my opinion. And that was the only comment I had. Thank you. Appreciate it, Madam Chair.
Did I imagine that, Barry, you announced this morning that we have a super sniff coming online?
We do, and it will be ready soon, within days. Okay, so that is a 120 bed facility, and we will be, staffing that. We're really working on the staffing issues. So that's one piece. I do want to say this because you guys hear it a lot on our executive policy calls, but not necessarily to the public. We have since back in February all kinds of alternative plans for contingencies. So we're preparing for hospital surge. We're working with the hospitals on what that looks like. How do we staff that? We're working what happens if the hospitals are overwhelmed. And the same thing, we're doing that with the nursing homes. That's how the super SNF come online. But we've looked at different alternatives. Should it be done in conjunction with other counties? Should it be done one for here? So all these different contingencies are being modeled. We're working with resourcing them and the impacts of different scenarios. That type of planning has been occurring since back in February, and there's way too many to discuss on this call. But just for reassurance, because sometimes, what happens if? Well, we're doing that. We're doing that each and every day, and our staff is working with all of our community partners on how to address various scenarios should, things, materialize and get worse.
Well, just for the sake of those people that didn't hear it the first time, Super SNF is a skilled nursing facility that's specific to COVID. Because it took me a while to figure out what that meant. Dave, Commissioner Eggers?
Yeah, just follow up with that, Barry. And again, I really appreciate your comments. And I would say that every time that I've heard you all speak about these long-term care facilities and getting beds available or having beds available, they're already full. So this is the first, today's the first we've heard about this new 120 bed facility. And again, that's awesome news. I look forward to hearing more about it and how it affects what we have today, or if it's, quote, already full or already spoken for. And so I just want to make sure again that we hear reference to that facility, that other facility. I don't even want to talk about where it is or anything because it's still so early on. Do we have a chance at landing that, or is that just a remote thing and we're just going to have to make do? I am worried about this hospital thing. That's what generated my comment and the comment from Commissioner Welch. So that's why I bring it up. So
this facility will come online and we will have access to it. It is a state facility, so it's not just for Pinellas residents, but that's also one of the reasons we're working on that. When you stand up a facility like that, we can't do that in a vacuum. We've got to work to make sure that it's going to be utilized. Some of the early, we've been talking about this since February. Well, when we were talking about facilities before, and then you work with the nursing homes, and they were taking measures themselves. So you don't want to build it or put it online and then nobody utilize it. And you also have to have the staffing and all the various things. So we've been playing these scenarios out, but it's very dependent upon working with the state, working with our community partners, including the nursing homes and the hospitals, for some of those decisions. Had this situation gotten bad back in February, we had plans in place to be able to pull the trigger at that time also. And so, but then things change and alternatives change, staffing changes. And so then you have to kind of revamp your plans. This is a direct result of what we're seeing within the community now. And again, it is ready to go, and we will be announcing that very soon.
Okay. So essentially, we're going to be dealing with our long-term care facilities as to use what the chair said about the SNF facilities. It's going to be our long-term care facilities. There's really not going to be an independent location because of not only the amount of work we have to do with the state, the amount of work we have to do with the hospitals, the amount of work we have to do to get them fixed up. So we're going to have to take the surge or whatever additional pressures we get from the school system opening up within the system that we have. And again, back to those 120 beds, Barry, you just said, I didn't even know that. So you clarified that for me, that is not just for our county, it is for multiple counties. So again, you know, how many of those beds are available for us? And I just think that, I mean, again, I'm not trying to, you know, state of alarm here, but I just think just trying to get an understanding so that we let our residents know what we're dealing with in terms of surge capabilities, because that's the area that we're all concerned about right now. So thank you.
To clarify again, that is a separate facility.
Yep.
It is.
Not within our current long-term care facilities.
That's correct. Lourdes is on the line. She can clarify that. She's worked on this, but yes.
Yes, it is a separate facility. They are currently testing. There are some patients already there. Some are positive. The negatives, we are working right now with our EMS system to place them elsewhere to open up more space.
Thank you. Commissioner Welch?
Thank you, Madam Chair. Important issue, so I just want to ask one other question. So how are patients designated to go to this facility? You said there might be other counties involved, so how are patients designated to come here?
Right now, we're just trying to stand this up, and I would ask that we not get too much into the weeds on this, because we're trying to work that out with our community partners and with our nursing homes, and frankly, we want to make sure that we have those plans in place before we put that out publicly. Those are some of the details that are being worked out. The staffing is the key, and we only got confirmation on that with the state yesterday. So if we can work some of those out, we'll have more to report maybe on our executive policy call.
Follow up.
Yeah.
So obviously that's going to be important information to judge the benefit to Pinellas County in relieving, you know, our hospitals. So the other question, if you can answer it now, if not, we'll wait, is what is the geographic area that these patients can come from? Are we talking Tampa Bay or is it statewide?
They can come statewide, but I just want to reassure everyone here, things are still in the works. This is very positive. One of our very large hospital corporations, they are the ones putting this together, so it gives me lots of confidence regarding the staffing. It's already has beds, equipment. This is a very good thing for our county.
I agree, Lourdes. Just want to get information on it. I appreciate it.
So I guess I have one more question before we go ahead and
wait.
do something. Yes, Commissioner Long.
Yes, I'm sorry, and I just would like this clarification at some point, Barry, when you're finalizing your plans, because I'm not clear on if the patients for the Super SNF are going to come primarily from the long-term care nursing homes, or are they coming out of the hospitals to free up beds in the hospitals? So if you can discuss that, even if you take it up on the policy call, I'd really like to be clear on that. Thank you.
If we can continue to finalize the details on some of this, we'll have that for the policy call tomorrow, and then we can be able to put that information out more publicly. How about that?
Great, thank you.
Okay, and I just wanted to know, circling back around to sort of what Florida and the Tampa Bay area looks like in the national news, which is not good right now. Sheriff, maybe you can speak a little bit to how many complaints you may have gotten or how many citations we may have written. I know that St. Pete has done quite a few. Do you know in the rest of the county what we're doing in terms of enforcing the mask ordinance? And, you know, in whatever limited travels I've been doing, I see people very much complying with the, you know, occasional ridiculous exception. But I'm just wondering if what you're seeing and what's happening with your people on the street.
Yeah, Commissioner, consistent with your observations, what we're seeing is overall is really, really good compliance. You do see the one-offs, and I would say again is that when you see people who are not wearing a mask, remember for the public that there's a lot of exceptions, and there may be very valid reasons such as medical problems and all the other things that we've discussed And, I'm assuming that when I see somebody without a mask, because you just don't see a lot of it, the prevalence of certainly people that are making that good faith effort. And that's also consistent with what we're getting and not getting as far as complaints. We certainly know that people know how to complain, and they do, and we're not getting them. So we actually get probably less than 10 a day as far as complaints about it. We do get some complaints about the bars quote, and we're not issuing any violations because when we go out, we find that they're in compliance. Most of the complaints we're getting are because people are misunderstanding what the ordinance requires. As an example, we get complaints about the bar is open at X restaurant. Well, the bars and restaurants are not closed. So we do go out, we respond to these and make sure that they, one, have a food license. And then if they do have a food license, that they're in compliance with all the other requirements. So, we've had a couple, and I say literally a couple, that have not been in compliance. And once we've given them the warning, they shut down because they shouldn't have been in business. But overall, and I haven't had any direct conversation with Chief Holloway about it. I know that they had some issues. And remember, they do have a very robust on downtown St. Pete. They have a very robust, restaurant bar area down there. And that probably is where they were seeing some of their issues. I know they had a few on Clearwater Beach that they addressed. And so, but overall, there's not a lot of need for enforcement or citations around the county because by and large, people are doing the right thing. So that's what we're seeing out there on the street. And it's consistent with all the information I see personally, what I'm getting from the deputies and supervisors that are out there, and what we see coming into the communication center.
All right, that's good to know. Thank you. Anything else? I will entertain a motion if somebody has one.
I'll move.
Second.
We have a motion from Commissioner Welch to extend the state of emergency and a second from Commissioner Long. All in favor, please raise your hand. Motion carries unanimously. All right, next item on the agenda, and I think we'll at least get through this before we take a break. Sheriff's budget. And Sheriff, you're on, or whoever.
Yeah, I think I'm on.
Yeah.
So I'll just begin with saying that we met our target, submitted a budget that was consistent with the target that we received. So if anybody has any questions on that, I'm happy to answer any questions about it. There were 2 items that we submitted that were outside the budget. One of those is the cars, the vehicles, and we have been submitting that outside the budget target for probably about 8 years now or so, maybe 6 years, 6 and 8 year range. And it was all after the recovery period, or as we went into the recovery period from the economic downturn. Previously, as some of you may remember, is that we did have our necessary vehicle purchases that were baked into the budget. And as we came out of that recession, is we had to take them out because we didn't buy cars for years, like 5 years. So we were in such an upside down situation, we had to recover from it. So the decision was made to take it out, and they remain out. And that's the discussion point today. And Barry and I will continue to talk about that and look at that model and maybe make some changes to that model as we move forward. But for this year, it is an additional requirement. We do have, to give you an idea, we have 142 vehicles that need to be replaced. And again, I just want to stress that this is vehicle replacement. We are not adding to the fleet. These are not additional cars. These are replacement vehicles. So we have 142 vehicles that need to be replaced. 67 of them are patrol vehicles or cruisers. The remaining run the gamut from jail transport vehicles and vans to some radar trailers, some message trailers, some beach 4x4 vehicles. And just to give you the kind of the landscape of what we're replacing for patrol vehicles is the oldest car that we're replacing is 21 years old. It's a 1999 car. The latest model is a 2016. The average age of the replacements of the patrol cars, the average age is 10 years old that we're replacing. The highest mileage car has about 140,000 miles on it, and the lowest has about 60, but it's a 2007 vehicle. And the average mileage for replacements is about 105,000 miles. One of the things that we have to keep in mind when we're looking at patrol vehicles is not the mileage, but what really is the wear and tear on those vehicles is the idle time. Those vehicles idle more than they run, and it just really tears up the engines. We have a very, really robust and I'll say sophisticated analysis process we go through when we decide whether to replace a vehicle. There isn't any one thing. It's a combination of mileage, the vehicle condition, the maintenance records, and we look at every single vehicle and we get as much as we can out of them. On the administrative vehicle side, or the non-patrol vehicles, the oldest one's a 1998 vehicle. The latest one is a 2015. The average age of those cars is 14 years old that we're replacing. Highest mileage is 170,000 miles. The lowest has about 23,000 on it, but it's a 2005 Dodge van that for other reasons is now in poor condition. The average mileage is about 91,000. So what we need to replace those cars, the total cost is about $6 million. And our plan is to finance the purchase of those vehicles as we have for the last 6+ years now. And the amount of money that we need to finance those cars in the FY21 budget is $1.7 million. I understand from the administrator that number is in the budget. So that's the ask, though, that is, and really the need that is outside the target and outside what we submitted. Again, that's consistent with what we have done. We have one more item that's outside. So, Madam Chair, if you want, I can either, if anybody has any questions on that, or I can just move on to the other item, or whatever the preference of the board is.
Commissioner Eggers?
Hey, just a quick question, Sheriff, on the car selection that you have. I'm always curious as to the benchmarking that you do with other sheriffs around the country. What on anything, really, benchmarking on anything, number of deputies per population, all that, but specifically to the kind of cars that you're using. Obviously people are using all kinds of cars around the country. How is this holding? How are the new Tahoes? Are they holding up? Is there a change needed? Do you see a change coming? And just kind of that comment, just generally how we stack up with other organizations like yours.
Well, we buy under contract. We buy under the state contract. We buy under a contract that's negotiated through the Florida Sheriff's Association. There's really only a couple of manufacturers of police vehicles. Remember that these vehicles are not the vehicles you go and buy off the lot. Is that they have different suspensions on them, they have different features on them, and we buy them through the manufacturer that are equipped with certain things. So Ford, Chevy, Dodge are the ones that have the products that are out there. And these Tahoes are not new anymore. We've had a Tahoe fleet now since about roughly somewhere around 2012. So we're 8 years. We've already been on second cycle of these. It is important to have a consistent fleet, and we're not inconsistent with others around the country. And what pretty much happens is that agencies go through an evaluation process, as we did in 2012, when the Crown Vics were no longer made. Everybody, I think, remembers the really quintessential police car, which was the Ford Crown Vic, and they stopped making it. So when they stopped making it, everybody had to go in a different direction. And some went with a Ford product, some went with a Chevy product, some still have the Dodge product. And we went through an extensive evaluation. I'm not sure if you were on the commission then, but we went through a very lengthy discussion about this when we went to it, and decided to go with the Chevy product. So we're just one of many that use the Chevy product, but it's a widely used product around the country.
And then just another question to that, and then maybe it's for Barry and OMB, but is there a descriptive place where we can see the debt that the sheriff has for his automobiles that are being paid out over time, just so we have a sense of that flow of funds over the next, say, 4, 5, 10 years kind of thing?
So our debt service amount, Commissioner, we have several loans. Our total debt service amount right now is about $13 million. And of course, we'll pay off more debt this year. We'll pay off more debt next year, even with adding the debt for this new purchase. It'll keep us right around the same because we're paying off additional loans. The interest rate that we're paying is about 1.7%. We've been as low on some of these as about 1.2% over the years. So the interest rate's very low. We do them on 4-year loans, and it has proved, to be effective, especially when we were, faced with, and I guess you all were faced with, coming up with at times $8 or $9 million a few years ago. Remember, because we didn't buy cars for so long. Now we've got them on a good replacement cycle, and we have a 5-year forecast. And if we keep on this cycle with how we're doing it and financing and keeping these same interest rates, I don't see our debt service really expanding that much because we're paying off loans as we're adding, and it's on a cycle. But Barry and I have certainly had discussions about perhaps a different model going forward. We'll continue to have that discussion as we prepare for the FY22 budget.
And we did have this discussion. Well, we did have this discussion, and it would be to get them on a right schedule where we're not talking about vehicles. That's something that needs to be replaced. They do have a replacement system, same methodology we use into a point factoring system, and you look at age and mileage and repair cost and all those various factors. So they have a similar model that's kind of the industry standard, but being able to have that schedule, retire that debt, and put them on a regular would be a goal that we have. We had some initial discussions on that, but frankly, Sheriff and I are kind of busy these days, so we ran out of time. So we thought let's continue this. It's very low financing cost, and we'll continue that discussion.
Thank you, Barry. And just a final question on this is that thank you for mentioning the idle time. I think that's an important component, especially with the sheriff deputy cars, because that's what they're doing all the time. It seems like they're either sitting there or they're responding to something, or maybe doing some patrolling. So, but the last question, are you going to talk about the plane purchase coming up, or is that just a separate question? Talk to me a little bit about the plane, and when I went up in the helicopters talking to the pilots about the plane and the benefits to it, seemed pretty substantial. But if maybe you could just speak to that, to the qualitative
there's nothing
benefit.
in this budget about it. I mean, there's nothing in this budget about it. I mean, if you want me to talk about it, it has nothing to do with this budget. There's no request in this budget for it.
I just said new next to the stuff we got, so that's why I'm asking. So
yeah, it's in the debt service. It's in the debt service, so there's nothing new. It was purchased last year. There's nothing new about it. It was purchased from the Pennsylvania State Police. We used to have 3 planes. We have 1. It was financed. The purchase price of the plane itself was about $800,000, and it's financed. So it was a nominal out-of-pocket expense. It's a 20-year-old plane. And I'm happy to talk to you about anything else you want to talk about it, but that's really what it is.
No, nothing. I thought it was some pretty good reasons to have it, and I just thought that would be
But
interesting.
it's used for surveillance purposes. It's used for all types of operations. It's used for traffic enforcement. It's used for, we've had some great successes with it, using it for surveillance. Yeah. One of the ones recently, if you all remember those people that were blowing up the ATM machines, is that we used it extensively in the joint operations with a bunch of different agencies to apprehend those people who were putting those explosive devices. And the plane was instrumental in that, and being up on surveillance for 5-6 hours at a time, which is what a helicopter can't do. Right. So it really has a very, very important. And remember is that the Pinellas County Sheriff's Office flight section is the only law enforcement aviation section in Pinellas County. Other police departments, St. Pete, Clearwater, none of them. We support all of the law enforcement aviation needs with our helicopters and with the airplane for every law enforcement agency in the county, and work a lot of joint operations involving our federal partners as well. So it's important, and it really has a lot of operational use. The plane provides a different aspect that the helicopter can't. The helicopter is not designed for long-term surveillances and being up for an extended period of time. The other thing that it has, and we've seen the benefit of it, and you'll continue to see the benefit of it, is being able to, especially if we have a situation where you need to see, or we all need to see video, in the video downlink system where you can look live real time, you can see it right now. It'd be important at a whole different, bunch of different aspects And the plane can do a lot of things that the helicopter can't do.
Okay, well, thank you for that. I thought that was an important aspect to add to the fleet to do some of the work that we need to be done, that needs to be done. So appreciate that, and probably have some comments later. Thank you.
Commissioner Welch.
Commissioner Welch, you're muted.
That's because I'm following Dave Eggers. You rubbed off on me. Sheriff, I don't know if you're in the middle of your presentation or if you're ready for questions or comments now.
Well, and I'm happy. I have one other thing I need to talk about, and I'm happy to, if you want, we were kind of on the cars, and I was going to go to one other thing and then take any general questions if that works for you, or whatever the will of the board is. I'm flexible. So.
Madam Chair, I'll come back after the sheriff hits his next one.
Okay, great. You can go ahead then.
So the next thing I wanted to bring up, which we needed, is $748,000, and it's for enhanced jail security. We identified some issues at the jail that have to do with screening. I've had a lot of discussions with the county administrator about it. He's been out at the jail, and I would say that a lot of due diligence has been done in evaluating that need. And it has to do with screening in North Division and in Central Division. We need to make some revisions to the lobby in both. And it's really the result of a situation we find ourselves in going back in the jail design. So we're going back now over 10 years ago with where the checkpoint is, because people come through the checkpoint and they can walk into the jail campus, if you will, or the compound or the facility, whatever you want to refer to it as, and they're not screened. And so people are actually walking into the jail itself and the jail proper without going through screening. So that's not a good environment to be in. And remember that the majority of the staff out there, because it's a jail, are in a secure place. They're not armed. So we need to make some enhancements. And this is all because we've identified some vulnerabilities. And it's always best to do those assessments proactively. And if you identify vulnerabilities, to eliminate the vulnerabilities, not wait for a problem to happen. The worst thing that we want to do is have a situation where we know we've got some weaknesses and we don't harden those weaknesses. And then we're trying to react because we had an issue. So this is for some positions, and it's also for some equipment that I know will bring us to where we should be. And this probably is a short term in the sense that under the jail master plan, we are looking at some long-term planning that would create a reception center of sorts, a screening facility out there that would then down the road eliminate the need for what we're doing today. But that's a few years down the road. And in the meantime, we really need to enhance the security and employ what we're going to strengthen it to make sure we don't have
and
a
more
problem in the
importantly,
county jail.
commissioners, this would be reused as part of if you went to a reception center. So it's not wasted money. But these, again, what the sheriff just said, these absolutely are necessary from a security standpoint, and we support it.
Okay, any questions about that? Okay, Commissioner Welch.
Thank you, Madam Chair. So this is not a brief conversation, but I don't want to take a lot of time now, but I know this will be a continuing conversation. But since the sheriff is here, I think we need to talk about the kinds of investments that we make as a county and have been making. And Sheriff, you were part of a great discussion on Tiger Bay with Jabari Edmonds from Black Lives Matter. And this whole issue of funding or defunding the police, we need to talk about Pinellas County's approach and where we've made investments, whether it's our CRAs in Lellman and South St. Pete that are specifically to reduce poverty and provide ex-offender training and early childhood education and things of that variety. But also, I think just on 3 issues, and Sheriff, you already talked about these at Tiger Bay, but I think it's worth talking a little bit about it now. What we've done with your APAD program and Safe Harbor, and also the mental health program, both the pilot and the expansion. I think it's worth talking about those things because those are things that other communities are talking about doing, but we've been doing them for a while. So if you could hit on Safe Harbor and APAD and mental health, Sheriff.
Sure. You know, one of the things I said when I talked at Tiger Bay and have talked in other places and have had discussions with, as you mentioned, Jabbar Edmond and other people, and a lot of things that people in the community have concern about, have desires for, and it really, really resonated with me that we're really doing not as good a job as we need to be in getting the word out about the things that we already have in place. And I know from that discussion, the reaction from Jabbar and from others was, I had no idea. And you're right, the things that we are asking for, you're already doing. And we are making a tremendous investment in things that would be in the sheriff's office and that I'm responsible for, that most certainly would be considered non-traditional law enforcement responsibilities. And we undertook these voluntarily, willingly, with a lot of desire to try and do things better, to try and not just take this hardline law enforcement approach. Many times engaging people in the criminal justice system and quote locking them up is useless. And a lot of the things that people are doing are not criminal justice problems. They are really social problems that traditionally the criminal justice system has been used to quote solve. And I put that in the biggest quotes possible because it doesn't solve anything. So as an example, Commissioner, we saw it back in 2010. So think about that, you know, everybody, that's 10 years ago. We saw a jail population that was breaking out at the seams. We had about 3,600 people in the Pinellas County Jail. We had 400 inmates on the floor. So we looked at it analytically and realized that a whole lot of those people that were in the jail were in there on minor crimes, social crime. A lot of it related to homelessness, for trespass, for disorderly conduct, for urinating in public, for minor possession of marijuana, a whole lot of very minor social crime. The criminal justice system became a dumping ground for a social problem. So as opposed to continuing down that path, we said, whoa, let's do this differently. And I know Commissioner Welch, as you remember, and others, and Commissioner Seal remembers, it wasn't without a lot of angst from people in the High Point community that we said, you know, we got to do something. And the Sheriff's Office opened Pinellas Safe Harbor, which is the only, and I say this, the only sheriff-run homeless facility in the country. And it is the largest homeless provider of services in Pinellas County. In non-COVID times, we have an average daily population of Pinellas Safe Harbor of 400 people. The average daily cost to house somebody in the Pinellas County Jail is $126 a day. The cost to house people at Safe Harbor is $17 a day. And we're breaking that cycle of homelessness through drug treatment, alcohol treatment, mental health services, job skills, life skills, programming with social workers, and we're keeping those people out of the criminal justice system. That's what the Sheriff's Office is doing. And we've got community partners, but the bulk of it is in our budget, and we're doing that to provide these services and to keep people out. Get to APAD, Adult Pre-Arrest Diversion Program, is that traditionally you commit a crime, you go to jail. But we realize that, you know, a lot of people just have ups and downs in life. They make mistakes, and there's a big difference between people who commit criminal acts as opposed to just making a mistake for a variety of different reasons. And every first mistake that somebody makes or first act that they engage in shouldn't affect them for the rest of their life, so that they can't get a job, so that they have problems getting into the military, so they have housing problems. They have all kinds of barriers because they made one mistake that they shouldn't have made. So what we did, now we're going on, I think about 4 years now, is that we established the Pinellas, and this is the only one in the state of Florida that I'm aware of that is not pay to play, which means you don't have to pay a fee to participate in it. And so it's run by the Sheriff's Office, Adult Pre-Arrest Diversion. There's a whole list of offenses, I believe about 13 offenses, including marijuana possession. Possession of marijuana paraphernalia, trespassing, retail theft, even battery. And so if somebody goes to Walmart today and you steal something from Walmart up to $750, is that back before APAD, you get cuffed and stuffed and taken to jail. And you get booked in, and then the state attorney gets involved, and the public defender gets involved, and the courts get involved. And you know what? Because it's your first time offense and you just made a stupid mistake at Walmart, you took something you shouldn't have taken. You know what you're going to get out of that? you're going to get community service. So we said, whoa, and then you're going to get a criminal record, and you're going to get an arrest record. So we don't do that in Pinellas County today. What we do is that when the deputy goes out or the officer goes out and you're at Walmart and you stole $100 worth of something, we're going to do an evaluation right there. And as long as you don't have a criminal record, you don't have any other barriers to participating, you're going to get a card. And the card says, go to the adult pre-arrest diversion office within 48 hours. We don't take a report on it. We don't document it. We don't do anything that's going to give you a criminal record. And when you show up and you go through a screening process, guess what you get out of it? Community service. And it works. And we have very, very low reoffend rates or recidivism rates for people who go through the program. The Pinellas County Sheriff's Office has led the state now for several years in juvenile pre-arrest diversion, or as people call it, civil citation. We have about a 96% civil citation compliance rate. And we lead the state. We have the highest number of juveniles who engage in criminal conduct that we don't engage in the juvenile justice system, that we put through diversion of any other county in the state of Florida. We partnered with Directions for Living, and we established a mental health unit. And the Pinellas County Sheriff's Office mental health unit is one where we go out when somebody calls and it's a suicide call, a mental health call, somebody has an issue. What we try to do where we can is to pair the deputy with a mental health professional, and it's a dual response to that call. And trying to reduce the number of Baker Acts and trying to then provide follow-up services. One of the voids in the mental health system is case management. And what these deputies and these social workers do is to provide follow-up services. So we're screening every call, even if it didn't come in as an initial mental health call, if it was mental health related, and they're going out on a daily basis and we're following up with these people in the community and trying to prevent it from becoming a crisis, trying to prevent it from becoming that Baker Act. So we're engaged in mental health. We're engaged in the mental health field. We've also established the Pinellas Integrated Care Alliance, or PICA, and it's a partnership between the county and the managing entity, Central Florida Behavioral Health. Also, Baycare is involved in others, where we are bringing case management out to the street and engaging people who are the highest utilizers between the criminal justice system and the mental health system. This past year, we partnered with the Pinellas County School Board to eliminate, as best we can, or certainly reduce, the number of Baker Acts and kids with mental health issues. I've got deputies that are assigned with social workers from the school district that are in the schools, and then importantly, taking it outside the schools to the homes afterward. We have HOME, which is the Habitual Offender Monitoring Enforcement Program. That's because we got kids that have, and the criteria to get monitored by HOME is you have to think about this. You have to have been arrested on more than 5 felonies within the last year. So you got a 14-year-old that had 5 felonies, but we don't just stop with that. Is that we also have a partnership where we're providing counseling services and trying to get to the families to get these kids into and break that cycle and get them into the right programs and the right services. Because what we found is that it's not the unavailability of services for these kids. The kids would go, but their families won't engage. So you got to get to the families. So I can keep going, Commissioner, but I mean, there is a lot of stuff that we are doing that is community-based. And quite honestly, a lot of it is outside what people consider our wheelhouse. But we're jumping up and saying, you know, we want to be here and we want to do it, and we are, and we've got to, and I appreciate the opportunity because we really need to get the word out more about it. And there's more than that we're doing.
Well, and I appreciate it, Madam Chair. And I think that, you know, I've served on JDAI for a while, so I've known about the juvenile diversion and worked with you on APAD, which actually you expanded. It began as just decriminalizing marijuana, but you added a number of violations and made it truly countywide. As we move forward, you know, I have no illusions that we're perfect, and I know we can all do better. But having that discussion going forward with the community, we need to understand where we are as a community, what we've done, and then understand where the gaps are, where we can be better. And I know you have conveyed to me that you're willing to be part of those discussions. You're talking to folks already. But I think that's the next step for our community is after the protest, let's move to some real dialogue and then any policy changes that need to happen. But I think since we're talking about your budget, it's worth talking about, here are some things that are already in the sheriff's budget that we've been doing for years. And then let's talk about how we can get better as a community. So thank you for your response. And Madam Chair, thank you for allowing me to ask those questions.
Well, thank you for asking those questions. All right. Sheriff, do you have anything else on your budget?
No, I don't know. I think we're good. Those are the only two things that we really need to bring to the board's attention that were outside. Everything else is that we were within the target and met the target, and look forward to moving everything forward.
Yes, Commissioner Steele.
Yes, Sheriff, in our backup, it also mentions replacement of the FACES system, the facial recognition system. So that's another decision package, or no?
Yeah, we've been able to work that out and found some existing money, so we withdrew that request.
Okay, thank you very much.
Great. All right. I guess that's it with that. I want to ask the board, do we want to take a break now because we have 4 other things to address before the end of this meeting?
Yes, please.
I knew you were going to say that. Okay. How about 12:30?
Yes, ma'am.
Thank you.
those of you who got back here on time, let's get started. Before we move off of budgets, Commissioner Peters, I wanted to address your request about looking at our budget in detail. I talked to Barry and that we're going to do that next month when we do detailed budget reviews, if that's okay.
That's fine. That was my intention.
Oh, okay, great. All right, then, let's talk about behavioral health.
Commissioner, since we presented our initial budget last month or 2 months ago with the decision packages, we had said there was still more work to be done with KPMG, or specifically around the mental health. Lourdes also has an update regarding some opioid issues, and so I'll turn it over to her. She can kind of outline and introduce KPMG. They're on the line. They're going to be given a short presentation about where we're at it and our recommendations for what we include in this year's budget. And then she's going to turn it over to Daisy for some additional follow-up. The one thing I'll say before she gets started is, as you've seen with our budget, and you will see, our budget recommendation to you is very conservative. I am particularly concerned. We've seen over the last 2 months a change in the way this pandemic is impacting us immensely, and so we're taking a pretty conservative approach. And you'll see that we're also increasing our reserves to be able to look at this in more of a 2-year budget, horizon. And that way, if additional things come up that impact us financially, we're prepared, to deal with that. So some of these decisions regarding how we approach some of these issues are reflective in those recommendations. And so it's a good discussion to have. I'm certainly welcome any comment or direction regarding how we approach these. But I'll turn it over to Lourdes and we'll get started.
Sure, thanks, Barry. So as you all recall, a couple of months ago, KPMG brought you the PowerPoint presentation report. It was close to 100 pages and shared that with you all. It was very lengthy. So we went back and wanted to look at 2 areas after hearing from the board. So we went back and put in some more detail, some more time frames, and that's what they're going to be reporting out today. The first one, which we see as the #1 priority, is the data and how we look at the data to see if our system is healthy. And the second one that we also looked at was the access model. So that's what they're going to go over with you today. We have Bill Sizik from KPMG, Vivian DeMann, and Brendan Davis. And I just want to say it's been a pleasure. I know it's been a lot of hours, lots of late nights, and they have just been a pleasure to work with, and very flexible, especially during COVID, to continue to work with us, even though their contract had already expired. So I just want to say I really appreciate the 3 of them for doing that. And then right after that, the board had also requested that we do more for opioids. As you all know, during COVID right now, it's gotten even worse. So Daisy's going to go over some information right after the KPMG report. All right, Bill, it's all yours.
Thank you. Can I be heard?
Yes, sir.
Okay, great. Well, very good. Well, good afternoon, Madam Chair and members of the board. Again, my name is Bill Sizik, Managing Director, your KPMG engagement leader over the last 6+ months. Pleasure to be here again with you today to provide an update on the elements of KPMG's recommended action plan following on the presentation we made back on May 14th. I know a lot has transpired since then, and your attention continues to have to evolve and stretch to meet a number of competing priorities, and we appreciate that fact. Again, with me today is Brendan Davis. He's a director with our National Performance and Operations Strategy Team for Government. Vivian Damian, as Lourdes mentioned, is our executive director, former clinician and healthcare executive. She serves as our global mental health and addictions expert based in Toronto. I would like to start with complimenting the ongoing leadership of the board, county administration, and as we heard today, the innovations that the sheriff continues to implement and other members of the PICA Pinellas Integrated Care Alliance team on continuing this important journey to improve outcomes for Pinellas residents and the consumers served by your behavioral health system of care. We recognize that you, as the leaders in the county, want to ensure that the system is putting the health of the county residents and their needs first. So if we could go to the next slide, please. So again, our core recommendations that we presented on May 14th and detailed in our report were aimed at improving the integration and management of the behavioral health system of care in Pinellas. And that includes the portion that the county funds and contracts for directly with providers, as well as the much larger portion of the system that is funded through Central Florida Behavioral Health Network via, originally from the state appropriation in DCF. Our key areas of action to focus on this last 60 months were, again, firstly, a minimum data set across all of your funders, across all of your providers, to enable you to truly see if the system is healthy in terms of having the right providers, knowing that our programs are working, whether for treatment or diversion from the justice system, as the sheriff stated, and where funding is needed most, so that we can actually see our residents get healthier. Secondly, the coordinated access model, which again enables all residents of Pinellas to improve the ease and speed of access to the right level of care for their needs, and a reduction on accessing crisis settings as the first point of contact for your consumers, families, and caregivers. This, of course, is complemented and underpinned and enhanced by the efforts around establishing a minimum data set. So we applaud the county's focus on starting with the minimum data set first. We do recognize that you may choose to move forward with some, all of the elements that we recommend to you today, and that given the acute pressures you face both operationally and fiscally, you will have to make hard choices as to what goes first. But rest assured that as and when the county is ready to proceed with this plan in its entirety, you will have a course of action, cost estimates, and other items that we'll detail today in place to guide your efforts. Next slide, please. So since the May presentation, and as Brendan and Vivian will describe shortly, we have worked closely with county administration and the human
this implemented and more directly some of those answers were needed. And we went back and we worked with the county. KPMG did quite a bit of research to bring some of these answers to bear. And the next few slides, we've tried to distill down presentations we've made to human services over the past 2 months since we spoke to you. So to get this done, these two recommendations, we did a broad market scan of other counties and entities that have done this, and you're going to need behavioral health specialists to do jurisdictional scans of what the leading practices are. You're going to need to align your minimum data set development to standards across the country. You're going to need a data and analytics capability to bring this together. You're going to need to use your current systems in place to set up a new data storage governance and management of that data and integrate it into your overall project. You're going to need project management to make sure that this is executed. And for coordinated access, as you'll see, you'll need vendor selection expertise in addition to vendor evaluation. Many of these capabilities reside within the county, but considering that at this time, and if human services was not busy before the current pandemic, they're quite busy. And so as we look at the situation, and not uncommon to many other government entities, we have set up some costs here for you to consider in terms of third-party assistance to get this done and bring this talent to bear, considering your current capacity issues with having these people leave their day jobs to try to do this. And those costs are estimated at about 1.6 million per year. We'll talk a little bit about the timeline in upcoming slides. Next slide, please. So very practically, starting off with coordinated access, what needs to be done? Your current system is based on using providers, and you do not directly provide services to residents. Consistent with that, you're going to need to go to market for a coordinated access vendor. In our market scan, there are not differential outcomes between government entities providing that service, and or like many other states and localities using a third-party vendor to provide that service, similar to what you're doing right now and with 211 as an example. And so you're going to need to develop the RFP requirements, evaluate those proposals, and within year one, you're going to have an evaluation, test, expansion program across all of your different providers to get this set up and rolling. Next slide. Very practically, we've tried to come up with a framework a cost framework that's going to give you the information you need to make a decision. We looked at other localities based on population size comparable to your county, and this represents a framework in terms of how to think about costs. So regardless of if you were to go externally, if you were to do this on your own, what are the positions you're going to need? How many of those positions are you going to need? And then what are the national benchmarks in terms of salaries, benefits for those entities? We've also added in here considerations for overhead costs and profit margins for external entities. And so this provides a range that you could consider a fair range, plus or minus a small percentage, considering the variability between market salaries. Next slide, please. And I'm going to pass this on to Vivian.
Thanks, Brendan. So we're going to talk about minimum data set, and I'm going to just recap briefly in terms of our presentation in May. So one of the importance of developing minimum data set is to ensure that the programs that you're currently funding are actually meeting the consumer's needs. And so it's important that providers offer services that are aligned with leading practices. Otherwise, what we have is for clients that might be going into the system, receiving services, but are cycling right back out again without actually getting better. And so to develop a minimum data set, we look at what is the indicators for what would be deemed leading practices. And we do that through a jurisdictional scan, as Brendan had indicated, and seeing what is leading practices out there, what is a state requirement versus what is federal requirement, and then really breaking it down and defining each of the common elements. And then the methodology of how each of the organizations will be collecting that data. And so from there, which takes about a 4-month period, from there we will then assist each of the providers in terms of notifying them as they're engaged in the process, but notifying them of their reporting requirements. And so one of the things that is really positive about the minimum data set is that as the county moves forward with their journey of transforming behavioral health, is that you will need to implement this as part of your contract or performance-based contracting. So your providers will be aware that in order for them to kind of continuously receive the funding that they receive, is that they are required to report back into the system the minimum data set that has been required. The third aspect of the engagement would be to design and launch a data warehouse and analytical tool for data reporting. And so while in other engagements, we have seen the providers actually be able to turn this back to the counties or back to the regions that are in terms of their minimum data set. What's really important is that the county will need to kind of develop or keep not just monthly, but quarterly, annually, so you could see the trends quarter over quarter or year over year of who are actually meeting the minimum data sets, who are performing fairly well, and as new funding comes forward, who are the organizations you might want to kind of continue to engage to expand the services. And lastly would be the test and expand. As we move forward with the final implementation of the minimum data set, we will assist with the testing aspect of it And then, of course, we expanded to other minimum data sets, et cetera. One of the key aspects of us doing this, and one of the things that we often ask organizations to do, and I'll ask for the next slide, is that you invest in your own staff. We get involved and we engage and we assist in developing the minimum data sets. What's really crucial is for the county to have staff that are comfortable and confident in both understanding the data, understanding behavioral health data, and then basically moving it forward with ongoing reporting, but also analysis of that reporting. And so two positions that we'd like to highlight is a data scientist, often someone with a PhD background, and then a data analyst, which is usually an individual that is able to really crunch data, large quantities of data. And so based on, again, going with what Brandon had said, it's the estimate FTE count, the estimate cost, and then with the salary and benefits at the 25%. And so you're looking at about the 280 to 304,000 for the high range. What's also important that we'd like to highlight in this process is that Central Florida Behavioral Health Network is interested and is agreeing to participate in this journey with the county, which we think is terrific. And we will lean heavily on their expertise because they have done this in the past and they do report their minimum data sets publicly. What we'd like to now see is a collection of both the county as well as Central Florida's data. And so I'm going to flip it now to Bill, and he will talk about the timelines for each of these.
That's back to me. So the big takeaway from the timeline presented here is that we believe the county wants to move forward first with the minimum data set. But based on our experience, you can see quick wins and success and implementation of both of these programs, including testing and expansion within a 2-year time frame from whenever you start with the appropriate assistance that we described earlier. If you don't have that assistance, it could take a little bit longer. But if you take these sequential steps within each work stream of the minimum data set and the coordinated access, we believe a 2-year program is a fair estimate to have all of this capability in place. Bill?
Thank you. And to the final slide now. So to summarize, we've made 4 key recommendations here. And again, these have to be viewed in the backdrop of that the county is facing many competing priorities for funding and focus at this time. And that we are really stressing that with constrained dollars and focus, the minimum data set is the most important step to take here. But our 4 recommendations are first to, at the appropriate time, look at going to market for a third party on coordinated access. Secondly, to authorize the transition to a performance-based contracting structure that's predicated on the minimum data set that Vivian discussed. The third is funding a third party to assist you in accelerating this work, because we know it's of utmost importance, even amidst these varying priorities that can change day to day. And lastly, to recommend that you authorize these new positions for data support internal to the county relative to sustaining both work done on the coordinated access, but importantly, the minimum data set in the short term. And we've tallied the costs for your reference here, knowing that these are recommendations that your team will have to make further prescriptions around. But we view this as an important investment in achieving the types of improvements in the system of care for improving access, efficiency, and outcomes for your community members. And we would also just say, as we've mentioned in our past remarks, that implementation is always where great ideas can fall down. And so ensuring that you invest in the appropriate infrastructure and resources is critical, both from perspective of leadership focus and funding. In closing, I would reiterate the importance of this minimum data set as a critical first step. And again, it's going to help you truly see and improve the health of your system and whether or not your residents are getting healthier with your programs. So we thank you once again for your attention in this opportunity, and I will now pass it back to Daisy, Lourdes, and team.
Hey, go ahead, Lourdes. or Daisy?
I'm sorry. Yes, thank you. I was getting online. And so I did want to start off just by talking a little bit about the minimum data set and the budget piece of that, just to kind of close the conversation with KPMG. We at Human Services had found $1.2 million worth of savings that we had from all of our work that we did with pharmacy, prescription, specialty care, as well as looking some of the operational efficiencies that we had in the department, and was able to give back to the general fund 7 vacancies. With that, the $555,000 and the $305,000 that are being proposed for the minimum data set, we could use some of that money, reallocate that money to build this out. This would be changing our priority to a system change. And I know that previously we had talked about potentially a decision package for the street medicine, but this would be shifting it, potentially shifting it from consideration from that to doing the minimum data sets. And if we want to go back to the beginning, we can talk about the opioids.
Well, I think you probably should see if there's any questions regarding first staying on this particular topic, and then.
Dr. Peter.
Yes, thank you, Madam Chair. I have at least 2 questions, if that's okay. So on your implementation needs a minimum data set, it doesn't say what page it is on here, but my question where it says design and launch data warehouse and analytic tools for data reporting, are we building software or are we buying and customizing in this proposal?
So I'll take that. This is Brendan. So neither. So we spoke with Human Services, and I have understanding that you're currently using Microsoft platform with Azure Stack that has Power BI built into that. So your data warehouse can be built upon your existing framework. You may need additional licenses, for example, if you move forward with hiring a new data scientist and data analyst. So it may just be access licenses that you need to that capability that you currently have in-house. You will need to build that tool out within the dashboards and the framework for the data warehouse, but you currently have the capability, and my understanding is there are other existing projects similar to this that the county is working on regarding data.
Okay, thank you. And then the other thing is really more a comment. Now, I think that your 4 recommendations are right on target, and I think they are exactly what we need to move forward and really have some kind of change in this county. One that I think is very, very needed. But I see that the year 2 total cost is it's high. I know it's expensive, and I know all of you have said this is the state's responsibility. The bottom line is we haven't been able to get the states to step up on this because nobody's really come up with a really good system that really, really works. And we haven't been able to give them the data that we need to demonstrate where the state should be focusing their resources, in my opinion. And I've spent a lot of time there, so especially working on this subject. And so what I believe is by developing this data set, it will help with the buy-in from the state. And we'll have, right now we have so little to show for what we're doing. We don't have the data set to show that, to get their support. But I think once we do this and we go ahead and make an investment in this, I think it's going to be well rewarded. And I do believe that then will facilitate the state looking at what could potentially be the best process or the best model in which to move forward. So I really am very strongly supporting particularly the data set and the coordinated access for services. I think it's critically important for us to move forward on those 2 elements. And I really believe that there's going to be a significant return on investment in many, many areas, not just fiscally, but I think there'll be a significant return on investment if we were to move forward and take these recommendations. Thank you.
And if I could clarify, Commissioners, and I'd like Lourdes to kind of weigh in on this, to just clarify the change in the presentation and what's being recommended in the budget. I don't think that's clear. So Lourdes, I'd like for you to clarify that. But, and I see some heads nodding, so I'm not alone. so let's be clear that there's two specific recommendations in here, and if we farmed all this out to KPMG, they are experts and they do a great job, as you can see, but it's expensive, and so we're challenged with that. So we modified that to be, to have them assist us and really kind of get the global effort, the regional effort going and looking at data and information. You've got a lot of different things that you started over the years in different pieces of this, but coming together and really addressing that data challenge. And so our recommendation, and Lourdes is going to hit on that, is really to use them for their expertise, stand up some internal capability we have. That gives us the ability to go down this data analysis piece. Let's have real hard conversations about what information we need and what it means. And then that will then help us to target funding and target the way in which we get better outcomes. The other piece to that is on this coordinated, access model. There's a lot of different ways that we can approach that, and I think everybody needs to be part of that. And as you see in their presentation, that takes time to even get there, and so we can be working on that while we're looking at budget issues, because you can also see the price tag for standing that up. And so we can be joining our regional partners, and because we all have a stake in this. And I know Lynn McKenna's on the line, but talking about how do we come together to solve that issue. But we have the capability of starting to get that process going during the year, so that can become a phase 2 of this, and it may look a little bit different than it does today, just by the county doing that. But if that makes sense, and Lourdes, you can certainly weigh in on that. You've been working this night and day directly with KPMG and others, and Bill, if you guys have comments on that approach, if that makes sense from my lay standpoint, then I'd like to hear.
And if I could just jump in just to kind of give the an overview, a brief overview. For the minimum data set, what is being proposed is $860,000. The first part, the KPMG part, would be exactly what they were saying in regards to system change, creation, assisting with the creation of the minimum data set, creation of performance-based contracts, and return on investment and those analytic tools. The second part would be the 2 human services additional positions that would have that level of expertise, both with data and with behavioral health. So the total would be $860,000 is what's being asked.
And Barry, if I can also jump in. So, Barry challenged us to find it within our budget. So we did have some savings, and after looking at what KPMG did, what we thought would be the priority, it would be the minimum data set, and it's exactly the budget that Daisy just described. So of the 7 positions that we turned in this fiscal year, what we're asking for is a couple of those back to be those 2 positions that we believe we need to do the data. And then the 860 that Daisy described is from the savings in the prescription program. So we're not asking for any additional funding. We understand that it is a tight fiscal year, and we don't know what's going to happen with COVID. So we heard that loud and clear. This would be with the savings that we have in the program.
Thank you. Commissioner Steele?
So that I'm clear on this, so how much have we paid KPMG so far, and what exactly are you proposing for having them continue on as a consultant? Is it around 500,000?
For the minimum data set portion of this, it would be 555.
Commissioner, it's $555,000 for the KPMG, and then $300,000 for the 2 staff positions. Different than the way we've done some budgeting in the past. So when they said they gave up, they eliminated 7 vacant positions, and they're not asking for those. Rather than reallocating within the budget, we're just being very transparent and saying that's back to the general fund. This is a new item, so therefore it is a decision package, right? And so that's how they're doing that. Bill has to work those numbers around because I think he already accounted for the 7. But again, if approved, we'll figure out the finances on this.
And what have we paid KPMG so far?
Lourdes?
$464,000 in that range.
Okay, my next question is, we had a contract with USF over the years to supposedly do research and data. So how does that translate or change to this minimum data set?
Yeah, it's totally different. I knew this would come up actually. What they do is more of a yearly outlook at data. It's not real time, and it's not this. That has been underutilized. I believe it's about $25,000 just off the top of my head, but I can get that. It is not this.
Okay.
And this is also, it's the same question I asked Commissioner Peters when we were doing our work with KPMG. This is not a brand new system. They have a good relationship with Microsoft already, which is what we use. So it doesn't mean that we're buying a whole brand new system or anything like that at all. Like Brendan said, it may be a couple of licenses. So don't be afraid of that, because I was, and that's not the case.
So in the presentation, it was mentioned that others are doing a system like this and touched on Central Florida Behavioral Network. So have they done this whole program previously, or where else in the nation have you seen these models work and work successfully?
As far as the data or the coordinated access?
Both.
Okay. We both, the county as well as Central Florida, has a robust, lots of data. And what we're trying to do with this, but it's not telling us if our system is healthy. It's just telling us, how many widgets, what have we done? So we've both agreed, and I know Linda's on the phone and can chime in as well, or can hear me, that we are going to look at this together, because us doing it on our own, it's not as valuable as if we do it with the state, because they're a bigger player in this. So we agreed to do it together and come up with, let's say 6 common data elements to see how the health of our system is doing. And then as far as coordinated access, it is something that some of the providers are working on. They continue to work on that. That is not finished. And I'll let KPMG talk about other places across the country, with the understanding that today, what we're recommending due to the budget is, if we had to pick one, it would be the data. Just want to make that clear. But they do have information on other places across the country and best practices on coordinated access.
Yeah, I'll ask Brendan and Vivian to comment on that. And to Barry's original question about the approach that's proposed, we agree. In a constrained environment, this is the right first step. Working with your partners on the coordinated access, leveraging what's already been done, and where you need support in the future, you can always come back to it if needed. So we think that this is the right plan, and we stand behind that. We have worked with other counties on the minimum data and performance insight issue. I'll tell you that there are not enough out there that are going where you are proposing to go and where we have taken other counties. It is very difficult. You are probably one of the few counties with a fully contracted out delivery system that would be doing this in the United States. It's been a very sort of difficult milestone to achieve for many others. Where counties run their own behavioral health system directly, it's still an exercise, but it's a bit easier to achieve. I would say it's not to be underestimated in terms of difficulty. The partnership with Central Florida, the partnership of the providers in this process is critical. And again, it's all about better care for the consumer, right? So, Brendan, Vivian, you can chime in on some of the other benchmarks we looked at for both coordinated access and minimum data.
Okay, I'll begin. So one of the examples that we gave you in the May presentation was Veterans Affairs. So Veterans Affairs has this across the United States of America, where there is a minimum data set. They have clear standards of care that is delivered in each of their assigned or allotted clinics, and they collect data across the entire country. And they are able to then adjust their programming based on the outcomes of their data. It's really well done, very well defined. It's in our report if you want to kind of dig a little bit more deeper into it. They're a great example. In regards to a coordinated access model, another example that was given in the report is Georgia. Georgia has one of the best coordinated access I have to tell you I have truly seen since I've been in working for KPMG. They started off small, but they are across the entire state. And they are very open to speaking to other people. They're a for-profit, and so if you actually do issue an RFP, there's a high likelihood that they may actually apply for it. But they do a really great job, and their information is quite transparent in terms of wait times, etc. But they have a very high number of FTEs, full-time individuals that run their coordinated access.
I'll just add that in the past few weeks, as I said, we did additional presentations with more detailed case studies and provided those to the county, and that might be helpful to provide to you, Commissioner Seal. But additional case studies that we provided regarding coordinated access was Houston, Harris County, and Denver. And what we did in our presentations, we're focusing on different types of components of their system. So did the government entity have it in-house? What were the technology integration components? What were the cost structures within those different types of entities at the state, city, county level? Those were some of the different things that we looked at in our research and presented back to the county in making this recommendation.
Okay, thank you.
Okay, thank you. The final question I have at this point in time, and I know we aren't going to be doing the coordinated access immediately, maybe next year, but you're only listing staff salaries. You don't have an 800 number or office space or operations and maintenance, and I'm wondering why that's missing.
So that is built into the total cost. If you move from left to right on that presentation, it starts off with the personnel cost, which would represent 80 to 85% benefits. Then the last column also adds in overhead plus possible profit margin for the vendor.
And again, there's many ways to slice this in terms of how you eventually write the scope that you put out to RFP or craft with a provider. You could provide those things as a county, and obviously that would come out of your fixed budgets, or you could totally outsource these things. The estimates we've provided you is based on a model of totally outsourcing it and requiring the vendor to come to the table with their own office space, their own hardware, their own systems for case management, telephonics, and the like.
But those are some, Commissioner, to your point, those are some of the things that we'll need to work on during this year. Again, we're recommending we go on a phased approach. I know Commissioner Peters wants to speak because she wants to see us do both. I'm not arguing that point at all. But there's pieces we need to get kind of an infrastructure in place for us. That includes the 2 additional staff members, and start working on the minimum data set. Getting all the players to come together to talk about the best way to go to a coordinated access model, and whether they can help participate in the standing up of something like that financially. So I think there's several things to work out there, but it's there's no right or wrong answer here. We all agree that this is a path we need to move forward on together.
Commissioner Peters?
So I got confused early on when Daisy spoke because she jumped into the next presentation on the opiates, which talks about the opportunities and solutions. And so my question now is, since you jumped to that presentation, Daisy, and you left this presentation and you went to the opiate presentation and you talked about solutions, I think we're doing that too soon. I think we went there way too soon because we haven't talked about that proposal. And so now I'm confused that, are you telling me that those 2 staff members and this data set is us? Well, wait, let me just finish my thought.
Sorry.
So I think you're knowing what I'm going to say, but at least let me finish it since it's a public meeting and people can hear it. I want to make sure that this solution that you're talking about right now, and this, because it's on page 9 of the next presentation, is this also what the plan is for the opiates? Since you brought it there, and we didn't separate these out, I think we should have. Because now I'm truly confused as to what it is what we're doing. And then relating to that, I hear what you're saying, Barry, and you want to do a little bit. I had a comprehensive proposal last year that you told me to wait a year for a study, and you promised me that after this study we would take action. I know we didn't know that there was a pandemic coming. That's absolutely true. But we've been in the middle of an epidemic for many, many years when it comes to opiates, and we have not been proactively doing anything to do that. And so there was a commitment. We weren't going to do budget requests that, and I would have done another budget request had I thought that we were only going to do a small little portion of this study that says we need to do at least more. And so very clearly, I just want that known, that regardless of this pandemic, we are working on an epidemic. And I think that it's incredibly important that we don't just take our time. And if you are implying that this is what's also going to be done for the opiates, then I've got real concerns with that.
Well, and I would like for Laura to address this, because this is very, very confusing. We've got two different pieces here. We've got the mental health and we've got the opioids, and we've kind of went back and forth between them. So let's start from ground zero. What is being proposed here for both? And I'd like Lourdes to address that.
Yeah, and we haven't done, and I'm sorry that I interrupted you, we haven't started the opioid presentation yet. So I think when we get to the end, we haven't even started that presentation yet.
Okay. So we're going to do that as a separate presentation.
Yes, Daisy's up next.
The two positions are strictly focused around the mental health, correct?
Yes, they're for the mental health for the minimum data set, right? What we're asking the board right now is for your agreement to move forward with the minimum data set and what Daisy's just proposed as far as the two positions and working with KPMG. That was outlined on one of the slides. That's it. So if we could just wait a minute for the opioids, that's the next presentation. And I'm sorry that was confusing.
Well, I have a question. So what's our guarantee that we're going to be able to get the information, the data we need to make informed decisions about this? I mean, we don't have it now, as far as I know, although you guys did say that Central Florida has tons of data and it's out in the public. I'm confused about that, because I think, we don't have information on wait times and
yes, we don't,
and that sort of thing. So
that's correct.
Go ahead. Sorry.
Sorry.
You know what I'm asking.
Yeah. So that's why when we talked with Vivian from KPMG, right, she is excellent at this, has done this with others across the country, and understands what we need, like wait times, that's a perfect one, to figure out the health of our system. We have some of that between Central Florida and the county. A couple of providers have that, not everybody does. So that's exactly right. That's what we would be looking at as an example. As far as folks not sharing that information or not being willing to, I certainly hope they will, because we can't work with people if they can't provide data. That we're not going to know about the health of our system.
Right. Well, and I guess I think about what we went through with the HMIS system and years of trying to get people to comply with inputting into that system so that we had joint data. And finally, it was written into contracts that you either do this or you will not get any county money of any kind.
And
or
that is what
be money. So,
and thank you for bringing that up. That's exactly what we've discussed, and with Central Florida as well, that this would be in the contracts.
Okay.
Because we feel it's that important.
And Central Florida is willing to put that in their contracts?
Yes, we have Linda on the phone if you could promote her, and I'll let her speak for herself on that. That is what we've discussed and what we've agreed to, yes.
Terrific.
Go ahead, Linda. You should be on the panel now.
It looks like.
Linda, you'll have to set up your audio and unmute yourself.
I'm sorry.
There you go.
Sorry.
You're good.
I am in, so having a little difficulty. I tried to be simple. So Central Florida really does support the minimum data set. I haven't had the opportunity. I just got to see the whole plan really yesterday. And so there's parts of it that, I can't really comment on in any kind of manner. I think the one thing that I would like to say is that whatever we do, we use existing resources in terms of the data and things that are in place. So for instance, Central Florida, we could add fields to our data to collect that information, and it would go in, and it might be a less costly kind of endeavor than building your own data warehouse, because we have that. We do projects like that with Hillsborough County and some other counties that we work collaboratively in that way. So that would, the mechanics of us being able to release data to the county is more difficult because we don't know, because of HIPAA. And so if we were receiving data from the county on specific individuals that we had an agreement on, anybody through county funds, that would not be a problem, and we could match it to a very large data set to look at those things. But the concept that I think is great, and I do support the coordinated access model. I know the community has really been working on that really diligently for over a year. So thank you.
Well, thank you for addressing the other issue, because that was my other question. How do we get around the issue that always seems to stop us in databases like this? And that's the confidentiality and the sharing of information. It sounds like maybe there are ways, and I'm sure KPMG has worked through that before, but that's always been a huge barrier.
And Commissioner, it has been a huge barrier. It's a huge barrier for a lot of places, but it's been done repeatedly, and different states have different privacy laws. But you can get de-identified, unduplicated aggregate data. And right. That, there's been many places that have been able to do that and really target and focus programs and be able to target what our wait times is and how to better address that system-wide rather than one in particular provider. And it's that type of discussion that will come out of having a good data set.
Commissioner Welch, should I see your hand up? No?
I did, Madam Chair. You answered most of it on the minimum data set, and that is not a sexy description. Minimum kind of lowers my expectations, but anyway, so you're extracting these data elements that you are going to define from providers from Central Florida, and who are the other providers? How many other providers have systems that we're going to extract the data from?
So I'll respond to that. So it's any provider that currently receives funding from you.
So how many are we talking about, just ballpark?
Oh, I'm so sorry. I don't know the number off the top of my head. Daisy or Lourdes, do you know the number?
Probably up to a couple dozen.
Okay, and each one of them would have to have these elements in their systems that we extract from in an automated fashion.
Or they deliver it, or they transfer it to you. And so I just want to go back 2 steps. So the reason why we call it a minimum data set is because it does need to be minimum. Often what we do is that we collect a lot of data and we don't do anything with the data. And so the focus is to really ensure that the key performance indicators that you are going to be collecting, you're going to be acting upon, hence the word minimum. But yeah, so the expectation is that the provider is to turn over the data, or that there's an easy pull, or that these systems are interoperable and they could pull from each other.
Okay, I know the difference between data scientists and marketers, so I get it. But so you're going to extract that into a data warehouse that we own. And you mentioned in answering Commissioner Peters that we have Microsoft tools to do that. What are the Microsoft tools that we have?
So I'll turn that back to Brendan or Bill, but I believe it's Microsoft Power BI. Yeah.
Power BI and the Azure stack, which would have the kind of data, the data tools that you need to bring it in, manipulate it, et cetera. And depending on the configuration, much of that is both HIPAA and CGIS compliant, in terms of the Azure cloud. But again, all of that would have to be validated so that everyone feels comfortable that it's protected. But to Barry's point, a lot of this, it's not about necessarily with the minimum data set. It's not, well, let me call it the optimal data set.
I like that.
With the optimal data set, it's about getting the picture of health for the system. It's not necessarily about following this consumer individually through the system. That becomes more important when you talk about coordinated access. Have we touched this person before? When did they last see us? Where should we put them now? But with the minimum data set, it's more about performance and health of the system. And so it's going to be easier to navigate some of those privacy concerns. But that said, the typical Microsoft stack comes compliant with those correct configurations in that
Okay,
way.
and in your full report, do you have an example data warehouse and the elements that might be in it? Is that in the full report?
I believe we have at a categorical level, yes. We've been working with the county administration and PCHS team to drill down on what those data fields might actually look like, but we can't determine that until there's sufficient engagement and partnership with Central Florida, with the providers themselves, whether fully county funded, jointly funded by you in Central Florida, or indeed what Central Florida's providers are collecting. We need to look across that for the common elements. And some people might have a data element that they call something different today. Others may have to create a new method to track it, to Linda's point, very well made, but you might have the ability to do so within the current systems. But then it's how does all that get joined up at the system level, no matter the funder, right?
Right. Okay, and Madam Chair, my last question. So at 100,000 foot level, because you guys live this every day, I'm just trying to get my head around, when we have coordinated access in place, how is it different from what we have today in layman's terms?
Sure. So I'll take that. So when you have a coordinated access system as a commissioner or as the county, you will know where your wait times are, regardless of which part of the county it currently has. Number one. Number two, you will be able to know where there's pressing points. So if you currently have a huge wait list for case management, and what's happening is that your sheriff's department's constantly being, hit by these, I don't want to use the word hit, but having to deal with these individuals, you will know where to kind of direct the funding if you have a very hot spot that's really impacting access to care. And lastly would be just to have a regular understanding as to overall spectrum, allowing consumers to actually choose and pick where they could go. So if currently right now there's a wait time that's in your
appropriate, consistent screening of the need. That today, many of your providers are using the same screening tool, but it's happening in many different places in many different settings. And not that that wouldn't continue in some form, but tomorrow it would allow that to happen in a virtual way, and especially given, until we're at vaccine and in a stable place in the future, virtual access to care and being screened and routed in that way is of tantamount importance.
Great. That's very helpful. Thank you so much, Bill. Thank you, Madam Chair.
Okay, so well, that's interesting. So the centralized screening, whatever you want to call it, access would have the ability to make an appointment with a private agency, or would they have to do a warm handoff, and they would have up-to-date information about what access there is in each individual agency, which of course requires the agency to input that on an hourly basis. But
yes, I mean, Vivian can drill down on this, but generally, and this all has to be, again, navigated and discussed with your partners, because they have to be willing and understand that this is going to benefit the consumer. But the best practice model in our view is you call or someone calls on your behalf, we are then screening and assessing. We're determining where you should go. We're able to see where you can get in the fastest at the appropriate level of care. And we have access. This is the best practice. This might take time to get to, but we have access as the virtual hub to those calendars of those providers to be able to book you in hot ourselves virtually, so that we can say, you're already booked in, you can show up today, tomorrow, next week.
So the other question is, the mental health system in this county is notoriously behind the need. For 25 years working in the system, it's been common knowledge that you can't get an appointment for 6 weeks. So what does that say about our capacity to deal with immediate access? I mean, if there's nothing to access, how does that help?
I would just say that we hear that a lot in every system of care that we work with. The data has to tell the true story. Right. Sometimes it comes down to, and again, I realize you as a county are not a direct provider of services, but some of it comes down to schedule management, practice management, managing the duration of appointments appropriately, consistency across the clinicians, right? All of these things can end up stacking up like dominoes to create a situation where there is zero capacity in a particular schedule. So we know that you're not in that business, but that is a very important lever in this when we have looked at systems of care that counties directly run. And we hear that, and we know that that is a true and valid feeling of the clinicians on the front line. But when we look at that at the schedule level, we usually can find sometimes 20, 30+% capacity that can be better utilized to create more access. So again, that's a hypothesis. It might be less for you. Yeah. But the data has to tell the story, and that gets back to why the minimum data set is so important to understanding the degree of capacity utilization, efficiency, and productivity as well.
So is there any way to know that before we start putting money into a whole system? And I guess I'm not sure how to ask that question. I mean, do we have the data that we need right now to know what our capacity is or isn't?
Correct. And I think to Barry's original point, and Lourdes and Daisy's as well, is that starting with the optimal data set exercise will get you there and get you that visibility at the system level to then decide, okay, well, maybe we don't need the full-blown coordinated access. Maybe it's something a little different. Maybe the providers already have something that can just be better connected. There's a lot of optionality that you will have. But that's why we, stand behind the strategy of start with the data first to get the systemic picture of capacity, productivity, health, access, quality, et cetera.
Okay, that makes sense. Okay.
Yes,
and I just want to add one other thing that we had actually put it also in the report, and it talks about your comment, Chair, is that until you kind of do an operational review to understand what is the capacity and what is the optimization of resources that are currently being funded, it is difficult to answer your question. And certainly that wasn't what our engagement was in regards, but until you kind of do the analysis, it's very difficult. It will be one of the key things that we will look at when we do develop a minimum data set.
Okay. All right, great. Commissioner Eggers.
Yeah, thank you, Madam Chair. So we'll go from Madam Chair, who's worked in this in this world for a lot of years, to somebody who has not. So my questions are a little bit different, but I really appreciate Commissioner Welch's question about how will it be different than what we have now. So it kind of tries to put a framework around that. I also wanted to say I appreciated the comment that Barry said at the very beginning, which is taking a conservative look at the next 2 years budget. In fact, Barry, that probably saves me a meeting with you, because that was really my concern as well. As we look at these budgets, it's not just about this year, it's about next year and how they work together, and making sure that we're doing what the residents need at the same time being, pretty careful. So I appreciate those comments. Lourdes and the folks from KPMG, thank you for the presentation this morning. I think it's been, again, it continues to be additionally helpful every time we hear more about it. I like the idea. Things that I like that I've heard is that we're doing, somewhat of a quality control review of the things that we have now. I'd like to think that the monies that we've put in over the years have had some benefit to our residents. Maybe not optimal, maybe not the whatever the right term is. I don't want to throw terms around because I'll end up saying the wrong one and insulting somebody, not meaning to. But I think we've done apparently some really good work out there that needs to be ramped up further, needs to be more efficient, more effective, and our residents ultimately have probably continually developing needs that that coordinated access system will help make connections for. And so again, I'm not trying to oversimplify, but I'm just trying to make sure I understand what each of those roles are. So we'll be starting with that data set, that minimum data set or optimal data set, whatever we want to end up calling it, getting that information from our contractors. And if they're not going to provide it, then we're not going to work with you, that kind of thing. I think that's really important. I mean, we're moving forward in this together. I think one of the complaints I've heard over the years, just from as an outsider, is nobody wants to share any information. It's like they keep it, everybody keeps it to themselves. The other part is this coordinated access system, which I think I understand. It's like a 1-800 number you call in, you can get triaged. I looked at your operational costs with intake workers, clerical staff, peer support workers. So we're doing some actual value-added service there. We're actually either in person or virtually making assessments to what they might need, where they need to go, the timeliness of it. Yeah, we have somebody calling in, they're really at the life's end almost mentally, they just can't deal with it anymore. That's one thing. Or they've got an ongoing problem, or they've, parents have found they've got some addiction, a child has some addiction, whatever it is. You guys are making some assessment yourselves. I mean, we're doing that. We're not just putting A to B, we're actually making some assessment, some diagnosis, if you will, and then trying to figure out where best to send them from a timeliness standpoint, quality standpoint, and all of that. Is that kind of where we're headed? I mean, with the coordinated access.
Commissioner, I think that's very well said, and that is the gist of it. I would just add that, we didn't envision that this would be a physical storefront, and part of the reason that many jurisdictions like that is because the market for talent for these types of roles is very difficult to get that in your geographic area. So when you can do this virtually, you can access talent markets and companies that are, around the country. And, especially when you're facing shortages in your particular region in Florida.
Yeah, I think in today's world of virtual accessing that we've been doing for the last 4 or 5 months, it'll help people think that way a little better. It also be hard to decide, like, where would that physical structure be that really takes care of all of our residents, since we're a pretty north-south, peninsula. It's like, well, we want to make sure that people feel that they can access it. And what better way than through a virtual to be able to immediately access it. Now, in some cases, they may need more hands-on, and that's something that I guess we'll have to look at. But from my perspective, this starts to make some sense. I was just curious about some of the funding. I heard what the request is in this coming year. I heard how we're going to address it. And I know Commissioner Seal a couple of years ago put together a suggestion about getting a nurse in every school, and we funded that through the DOH, I guess the Department of Health millage that we have set aside. And it would seem to me that long term, if we're going to be looking for a source for health issues related to mental health issues in our county, that to me, again, I don't even know exactly if that funding can be used for something like this, but this seems to go right to that need. Now, again, we're not talking about this coming year's budget and all of that, but I guess 2 things. One, there's still a benefit, number one, from doing the MDS, because we can do this quality control thing, we get data information, and we can still make folks accountable along those fronts. But the second part of it, the triage, the part that value added, putting people, that's an important element to me. And finding money for it sooner rather than later seems to be appropriate. And And so I was just trying to figure out where these monies could come from in light of the fact that we're going through all these adjustments that Barry, you were talking about, this conservative approach for the next 2 years. I don't know, just trying to figure out different places to get money. Thank you.
I need to, before you try to answer that, I need to interrupt. We're supposed to have a county attorney oversight meeting at 2 o'clock. And we have constitutionals come into this meeting. Do we want to try to still have it, or do we just want to continue on this path, however long it takes? Because we have several other items on our agenda, and try to reschedule the oversight committee. I mean, we need to tell them very soon. Commissioner Seal?
I would suggest that we go ahead and do the oversight committee meeting. It may not take that long. And frankly, trying to get everybody corralled on Zoom again and a common date's going to be difficult.
Well, that's the truth. Okay. Well, okay. We'll need to stop at a couple of minutes before 2 then and do that and then come back to wherever we are, if that's okay.
And Madam Chair, we would have to end this meeting and then start up the other meeting and then come back to this meeting, just because we're using the same license for Zoom in order to do that. So I'm not sure whether that'd be a problem, or we just notify the public and let them know if they want to continue attending. It would be the same link and everything, but it would be at whatever time we come back.
So since it's Zoom, is it that difficult to reschedule people's schedule? Because they're not traveling anymore. They're not traveling to meetings, and they don't have to get around traveling to meetings. I would rather postpone that meeting and finish this meeting.
I haven't heard from any of them, so I don't know how difficult it might be. But like you said, Commissioner Seal, I don't think it's going to be an extensive meeting. Maybe if we found another half hour where we could do that another day.
Last year's meeting took 30 minutes.
Thank you. Commissioner Welch.
That answers my question. We're good.
Okay. Yeah, I kind of really hate to interrupt this and go someplace completely different and then try to come back again. This is a discussion that is actually very helpful today, and trying to keep it on track. Does anybody have any, Commissioner Seal, you've said you want to do it, but do you have an objection to canceling and trying to reschedule?
I'm fine if that's what everybody wishes to do. I just know that it took at least 2 months trying to find a common date. So fine with me.
Yeah, Commissioner Long.
Well, and I just also wanted to say, just because we're not traveling doesn't mean that folks don't have other meetings that they've already got on their calendar. So I think we have to be sensitive to that as well. Just saying.
Okay.
It's up to you, Madam Chair.
Okay. I think we cancel the meeting, the county attorney oversight meeting. I will make my apologies, since you just put it on my desk, and try to reschedule. So, okay, continue. I don't know where we were.
Sorry, I was just gonna answer Commissioner Egger's comment. So for other organizations that have decided to put out an RFP, what they have done is that they've actually taken positions that are already existing within each of the providers, where it's like a 0.5 half-time intake worker. And through that, they have cobbled together the coordinated access model, but they still had a couple of primary full-time people that basically pulled it all together. Again, it just depends on which way, once the RFP gets issued, and who responds to it. And it will cut the
I think that's what we'll find as we kind of stand up this minimum data group, and we start working with Central Florida on this model. That is it's outlined in your proposal, that is a component piece to that, and there are several different steps necessary to move to that, to have that type of a coordinated access. And so this would fit in nicely, I believe.
Barry, can you speak to the that funding piece and what flexibility that one piece has in this whole thing? So again, and not that we don't want to put some pressure. I mean, not pressure. Not that we don't want to put some piece of this on the general fund, but that other.
You could, well, what you would do, I'm not sure about whether you could use these dollars under the health department. What you could do is there's general fund pieces to the health department that we fund. You could increase the millage over on the health department, and then that would free up dollars within the general fund that then could be used for other purposes.
Yeah, that's kind of what I was at.
You know, and you'll see, and of course, you can take this presentation and we can have this discussion as you talk about your overall budget. What you're going to see in the budget, let's be real clear, is you're going to see our reserves go to about 23% because we've stockpiled, or not stockpiled, wrong word. We've increased our reserves because we don't know what in fact is going to occur. You heard from our property appraiser saying that we very likely could have a lower property tax for the budget year 2022, and so we're planning for that. We're looking at this as kind of a 2-year budget. You'll see that the departments will report to you come in lower than their 2020 budget in real dollars, and even with their increase for salary increases is lower than their 20 budget, because we've taken a conservative approach, really tried to look hard at that. That does free up dollars to be able to do things like this. But we're going to get to the opioid issue in a minute. That's another funding request. What we've shown, you in the past, you remember the charts as we've shown, is that in some of these areas, and these are absolute needs in these social service areas, though, that has grown. And so that stresses the general fund. And so we're trying to take this one step at a time and look at these and be able to make sure that we're making the right decision. This whole study with KPMG is excellent, because it puts us on a clear path in terms of the things we need to do. Last year, we weren't talking about the same things that they're proposing here now in terms of a path forward and the things we need to analyze and the data sets and the coordinated access. And some of the other things are out years, but all of them have a cost, and we're going to have to look at all the funding and determine what is the best strategy to address that. Just adding additional programming specifically isn't necessarily, it's also looking at better ways of utilizing existing dollars.
Thank you. And I guess I definitely want to make these decisions based on data. So I like the approach. The question I had, so when we talk about common data sets for, or whatever it was, we ended up with optimal data sets. We are talking about mental health and substance abuse services.
Correct. We're talking about all of behavioral health, which is both.
Okay.
Correct.
Two very different things, but okay. Yes, Commissioner Peters.
So I took notes from the last meeting that we talked about this, and I just kind of want to go over them, and then I have a request from all of you. So Barry stated in May, this budget cycle will do big things. And Mr. Dillinger sent in an email that there's no connection for mental health services through diversion. And the sheriff stated, we do not have a system. The purpose was to be strategic, and this was Barry said this, and not throw money at the same old thing. And it was also stated that a coordinated access to care puts the consumers first and not programs first. And it was also stated that we have nothing but silos. There's no coordinated system in this county at this time. So the first two elements are what I'm asking that you all be bold and go ahead and follow through with these first two elements, including that access to care, instead of just only doing the one data set. Because, and this was stated in this meeting, and I can't quote it because I didn't think I wrote as clearly as a quote, but the first two elements are foundational strategies for any pathway in the future, critical given the COVID with this community needs, access to care and delivery of care, because we're going to have to be going remote regardless of how this goes. The current focus currently in Pinellas County is on outputs, not outcomes. Currently, we collect number of clients served, ethnicity, veteran status, things like that, instead of, is the program making a difference? Are people really getting help? Are they getting healthier as a result of going to this program? Is the door that they went into the right door? And so what I'm going to ask you, especially, and today the New York Times came out and said that as a result of COVID, nationwide, the number of mental health issues have increased significantly. So this problem isn't going to go away while we wait 2 years. This problem is present, and it's only comprehensive system that can serve us long term. I also asked for the funding to come out of that health system like Commissioner Eggers had suggested, and that's how I had proposed to fund it. I also had a proposal for what to do with the addiction system, is what we're going to talk to next. Now, last year I tried to get your attention to get to do this, and we decided we were going to do a study. And I wasn't very patient, and I've tried to be incredibly patient this entire year during this whole process to get the study. And when Barry said in that meeting in May that we are going to do big things in this budget cycle, I was incredibly excited. And so please don't disappoint the citizens in this community who desperately, desperately need a good mental health system, a coordinated system. So let's just be bold. Let's do it. We've got the money in reserves. Let's go both pieces, not one. Don't minimize this. Be bold, and let's give these citizens a good, healthy system. They deserve it, every single one of them. And if they don't directly suffer from mental illness, their family members do, their parents do, their spouses do, their children do. It's a huge number of this population that suffers either directly or indirectly from mental health, and it's time that we step up and we do something. So I'm going to ask you all please to consider doing both pieces that are the coordinated access model and the minimum data set, because that's what we need to move forward. And with this COVID situation, the demand for these services are only going up. And I believe that if we're the one that contracts with that coordinated access model, that gives us control over that central receiving virtual system, that those contracts for who gets the referrals will have to accommodate the data sets that we need if they want to be part of that referral system. So I do believe that this system would allow us to have a good quality system that one day can be replicated someplace else. And I really wish Pinellas County would be the leaders and not do it at baby steps and not kick the can down the road any further, but really be bold and really do this now. Barry, I'm looking for those big things you said in that May meeting. And I know a lot of things have happened since May, but our citizens deserve it. And I'm really hoping that we do big things. So please, please consider funding both the coordinated access model and the minimum data set this year based on the timeline on page 9 of 10 in the presentation. I think it's absolutely critical to our citizens. So thank you for your consideration.
Well, thank you. Since we're not making any decisions today, you may need to repeat that argument. Commissioner Long, did you have your hand up? No?
Yes, I did, Madam Chair, but my better angels are kicking in and I've decided to speak. So thank you.
Okay, Commissioner Seal.
Okay, so I hear the passion and the rationale from Commissioner Peters, and this is what I would propose you all to think about. I think it's going to take some time to get the minimum data sets together, especially since we're going to have all the partners cooperatively working. So I think we do that as step one. If we get it done sooner, then we'll go ahead and do the coordinated access. But I think we got to have that data set first, correct, KPMG, before we can do the coordinated access, because you have to have something to be able to monitor and to follow. So that's point number one. Point number two is as far as the health department millage, what we could probably move over is our indigent healthcare program. So over the years, you know, I've worked in this arena, and generally that funding can only be used for primary care and for the health department's services. So we have an RX program, our prescription program, so that could possibly be moved over today or in this budget to the health department, and that would free up some money. However, that'll most likely take a unanimous approval by the county commission, because you would be increasing the millage and under the state guidelines for that. But Bill Berger can check into it. So that's what I would propose. And so there would be money there if we needed to go into the coordinated access, but I think we really got to get the data set done first. And that is the question for KPMG.
Commissioner Eggers?
Yeah, on that front, I was just looking at the timeline again, that it looks like year one for the coordinated access model is a development of RFP requirements, a release of RFP for submissions, an evaluation of, you're not really even finishing a contract negotiations until the end of the first year. So I'm looking at next year's budget year. What is the amount of dollars that we'd be spending on the coordinated access model piece? It obviously wouldn't be any of the people yet, because we're looking at year two for that. So I'm just trying to think out loud. To get started down that road, I think it would be, we could do a lot of that and probably minimal cost. Maybe I'm wrong. Question.
I think that's correct. There's certainly pieces that we could do, and especially, you know, during the year if we're able to do more on this. I also think there's a way to have, you know, several of the partners participate in in the way we do this. I mean, a lot of places do a mini version of this within their own particular silo right now, and so we really should come together in terms of not just the way in which we coordinate this, but also the way we fund it. And so it's an opportunity to kind of flesh some of that out over during this next year also.
And the only other comment I would make, and I really do appreciate Commissioner Peters' passion on this, and I think it's, well, so I think there's been a lot of work in this arena over the years, and I think this is a way we can really maximize the effectiveness of our system for our residents. And I think, you know, input, would you call it output versus outcomes? I think that's really critically important. However, having said that, I think it's always, you know, these are very, you know, we're changing, we're creating, we're putting in place something that's foundational, that's going to last presumably and be kind of a leadership model for years to come. I mean, so to do it carefully and deliberately right now, even though maybe we could have done this 3 years, 4 years, 5 years, we're here now, to be careful about it, I think is smart. I mean, even waiting a year, we went from bricks and mortar to now we're not even looking at that right now. And I think that was a great decision to get this work done by KPMG. So I certainly would like to see that coordinated access model work that they're identifying in year one being done. It doesn't look like it's a lot of dollars to get started on the RFP requirements and RFP submissions, et cetera. So I would support that part of it. And then obviously as we get closer to next year, thinking about the following year's budget, we'll know more about where we are in our own case, in our own budget, plus this incremental piece that we're looking at. So anyway, that's just my thought. Thank you for your time.
So I have a question, Barry. On page 10 of this presentation, are these basically what you're recommending we put in the budget this year, this coming year and the next year, 1.6 million for a consultant to do all this work, and then funding actual things?
No.
In the second year?
So,
I mean,
yeah,
I'm a little confused between that and the other
I know.
budget pieces.
If we would have fully contracted with KPMG, that's what the cost would have been. Is that correct, Bill? Under this model, it's $500,000. So we've cut that down significantly for KPMG's assistance and us adding 2 positions. When we get to things like RFPs for these next phases, that's really where it's critical. Us coordinating with our partners, building that internal capability of being able to carry and work this program is critical. And so that's the reason, Lourdes, you guys come up with having those 2 staff positions, which KPMG recommended, getting those on board, utilizing them in targeted areas, but also utilizing our own resources. So it's $500,000 for KPMG and $300,000 plus or minus for the staff members.
For the minimum data set, the optimal data set, yes.
Right.
And if I could just make that's absolutely correct. And if I can make a point just to not, when we say define RFP requirements, and we applaud the prudent path of saying, let's do minimum data first. Let's see how this year goes. If we can get started on some of the coordinated access, great. But we do need the data first. But I would say that it's more, in our experience, it's more than just defining the RFP requirements, because in order to do that, you have to design the model that you're contracting for. You have to know to some degree what the capability and willingness of the partner, the providers, and the funders are. You have to clearly spell out for the vendor not only what the incoming pathways are of potential demand and consumers and calling, but also the referral pathways out to the appropriate level of crisis care. And again, some of those they'll have direct access to book people in, others maybe not, but they're going to have some degree of clarity on what the job is you're asking them to do. So there's a fair amount of design work that has to go into that. But again, we fully appreciate that if you have the capacity, the skills and the focus, that those are things that you can do yourselves and only utilize us as and when you need as an external partner.
Just to that point, Bill, could you look at this timeline again and maybe add another part called design and shift this coordinated access model out a little bit then, so that we can actually see what is reflected in your comments on this timeline? Because I think that's a good point. I mean, what you just said, but what the timeline says is we're going to start at the same time we're doing our minimum data set. So maybe that'll help us think through this a little bit more realistically and being more deliberative as we develop the different stages. So that would be helpful for me if you could.
We can absolutely do that. Yes.
Thank you.
Mr. Long, sorry.
Yes, thank you, Madam Chair. And I would just like to, it's not so much a question, it's just a bit of a reflection, because in this presentation, we have millions of dollars of items to unpack as we go forward on an issue that I feel compelled to say there are many of us on this board who care deeply and passionately about this issue. And we have been talking about solutions to this issue for as long as I've been on this commission, as have several of my colleagues here. So while I know we would all like to get it all done 2 years ago, I clearly heard, I think it was Barry say, that while we've been really solid right up to this point in terms of how we've handled the budgets and the conservative way in which we have approached these amazingly big ticket things, we have got a long, long history of being very thoughtful and deliberative in terms of how we move forward. And I think keeping that great big picture in mind is really critical right now, especially because everything we don't know, given the COVID virus and how it has the potential to impact every one of us in ways that we cannot even yet imagine. And so I appreciate Commissioner Seal, as always, with her long history of institutional knowledge, slowing us down just a bit to say, let's make sure we have the data And let's make sure we know what we're doing before we go rushing into embracing the whole entire piece, because it might be interesting to reflect that I think I remember the presentation we heard from your group last year, Bill, was recommending we build a brand new building that we now know we don't really need. So data is important, and I think that we are on the right path with the way we are trying to be methodical and make sure that we know what we're doing. So thank you for allowing me to just share that, because we are a team. We are all in this together. And that's why we do such great things in this county. Thank you, Madam Chair.
Thank you.
Madam Chair, I just wanted to say I appreciate those comments. Just to clarify, though, I don't know if you meant to say someone other than me, but KPMG was not involved last year on any of those other solutions that might have been presented. That might have been a different group.
Yeah, I did. I just got that a little bit confused. But you get my message. Do you know what I mean?
Understood.
I
Yes.
think it was you folks that said, "Hey, wait a minute, you're not ready for that yet," which was my point.
Got it.
Right. Okay. Can we move on to the opioid discussion then?
Great. And so, yeah, the next item, and that's Daisy.
Thank you. Thank you. Good afternoon, commissioners, and thank you for your time to talk a little bit about the opioid landscape in Pinellas County. If we move to the next slide, I'd like to just take a moment to look at the national landscape. As we all know, it is a national problem across the board. It's not just in Pinellas or our neighboring counties, but across the nation, it's a complete challenge and a misfortune. Moving on to the next slide, looking at Pinellas County in particular, we can see that over the past 5 years, Pinellas County has had an increase, continued to increase in accidental death rises attributed to opioids. If we look at the numbers of 2019, all of the deaths, accidental deaths, were 423. You could see that trajectory had gone up. Those specifically related to opioid were 319. And the current data that we have from the ME's office indicates through April 2020 indicates that we have 132 drug-related accidental deaths. We're waiting for the ME to give us the breakdown of that 132, but clearly we could see that we're on the same trajectory of not going down, but either staying the same or potentially going up. We also saw, there was some conversation around COVID and seeing increases. And so 911 has seen a 9.74 increase in calls of suspected overdose during the month of March to May, compared to the same time last year. So when COVID really started to hit us for the same time from last year to this year. So we've seen a 9.74 increase in that. We also saw that in the month of May, there were 633 transports for suspected overdose, with Narcan administered 268 times. And in the month of June, there were 657 transports, suspected overdoses, with Narcan administered 247 times. So that creates a total of 1,290 transports, and of those, 515 times Narcan administration had been applied. Of the 515 incidents, we wanted to see how many of these were repeats. So for the same period of May through June, of those 1,290 transports, 515 incidents, 435 people was a one-time, had received a Narcan administration one time. That's during this period, so they could have received Narcan administration previous, but during this time period, I was surprised to see that 92% were unduplicated. 7.6% had two, or 36 people had two Narcan administrations, and 2 people had 4 Narcan administration 4 times. And so in November, there was a group, Lourdes, staff from Human Services, the Department of Health, Operation PAR, and the Pinellas County Sheriff's Office. We received the Technical Assistance Award to go visit Buffalo to observe how they have decreased the numbers in their opioids. If you see the graph, at one point they had 301 opioid deaths in 2016, and they made significant strides in bringing those numbers down. And the ways in which they did that is through a product called Buffalo Matters, which is medication assisted treatment and emergency referral services. And so in the emergency room, patients are treated and immediately linked via an app to their substance abuse outpatient provider. They also have a very robust opioid task force that work on collectively on 7 key initiatives. They have subcommittees that report up to the task force, and it's a very action-oriented task force. They have expansion of Narcan. It's accessible in all of their clinics and law enforcement offices, health department and emergency kits strategically placed around the county. And they have a very heavy peer program that's also integrated not only in their emergency room, but also integrated in their outpatient programs. And the peers assist and help individuals get to their appointments and kind of acclimate to what the next steps are. So in December, we took a step back because that's when we started working with KPMG to see their strategy document. But recognizing that opioids, especially around COVID, has continued to increase, we did meet with Tampa General Hospital. Tampa General has a very, very robust medication-assisted treatment pathway program. Again, they have an app, they have a physician champion, they have a director of social medicine who's a certified addiction professional who oversees the program, and they treat the individual and immediately connect them to outpatient services. And similarly with Baycare and Operation PAR, they're doing a similar thing at St. Anthony's Hospital. Working in the emergency room, they have a peer that's integrated in the emergency room, and they have access to treatment and medication and referral to PAR. And so here on the opportunities, we always continue to look for grants and to look for funding opportunities to address this issue. Here we talked about, again, not knowing the uncertainty of COVID, the fiscal impact, the budgetary impacts, what it's going to be. I understand that there was $500,000 that had been set aside that we proposed could be used for the opioid response. And some of the recommendations might be to help fund some additional Marchman beds, detox beds, specific to opioid disorder. The DCF changed their funding, so they do not fund for detox beds for opioid disorder only. It has to be co-occurring. So this could help fund some additional beds there. It could help and or transportation from the emergency department to detox or treatment, and or provide one-time funding to help strengthen the current hospital bridge program. And we talked about this slide already as it related to KPMG. And so that concludes my presentation.
I just have a question again, Daisy, about capacity to treat. I mean, I like the idea of the immediate intervention, but do the community agencies have the capacity to provide ongoing treatment? And we have very few detox beds, am I right?
I don't know the exact number of detox beds, but we did with Diane very recently, and she has indicated that the program at St. Anthony's is working relatively well.
Okay.
So the idea here, Commissioner, is there's a number of areas that they could do more in this arena, but up until this point, so for instance, you have Baycare has implemented a mini version of this, and they're doing that with their resources, but there's probably more that can be discussed there and learn from that and expand it out like Tampa General did, across the Bay. We'd like to also see other hospitals do similar things. And so we set aside some money to be able to address any gaps in the system. And then that way we can work with them and leverage those dollars to try to have a more robust overall program countywide.
Well, that's interesting because we heard something similar. I think it was Manatee County that's doing something like that. And we were talking about that in the context of the opioid settlement money, but certainly we could try something earlier.
We did contact Joel and with where the settlement money would be, but I wouldn't.
Yeah, not holding my breath.
I wouldn't expect to see a check this year on that.
No.
The lawyers will continue to get rich off of that for many, many years to come. And
no, I was just saying that's where it's surfaced, that whole issue. I think Lord is a lawyer.
There's a delay. You all probably read, many of the defendants have filed for bankruptcy. There's a lot of issues going on that's complicating that right now. So I echo what Barry said. You're not going to see that money this year.
But again, back to treatment. I mean, what my question is, what do we have in terms of treatment in this community for people, particularly for people that have no money or insurance?
Daisy Lourdes.
Well, I think that's part of the problem is there's just not enough, right? And we're not getting people early enough.
Right.
So like when we went to Buffalo, why it works so well is they get people right in the EDs, they give them medication right off, so they don't keep cycling through, and they give them the therapy that you're talking about, that quite frankly, I don't feel we have enough. Central Florida does pay for some of that, just like they pay for some of the St. Anthony's program, and they also pay for the Tampa General program. We just don't have enough is the problem.
Right. Hence capacity.
Yes.
Yes, Commissioner Peters.
I have an enormous amount of questions, so I kind of wish Daisy had contacted me earlier so I wouldn't have taken up time, but I'm going to step by some of them, but please indulge me. The Baycare Operation Power Hospital Bridge Program, how is this currently funding and for how much longer? And for how much is the total amount?
That bridge program is being funded by Central Florida Behavioral Health. It's the state opioid response. It's the bridge program for $150,000. And I think Linda indicated that they're not sure if it will be reinstated in the new fiscal year.
Okay, so that's not the one that's a grant?
No.
Okay, and my other comment about Tampa General, that's great that that pathway, are they administering drugs then?
Yes, they are, right? It's right out of the ED.
So they're doing it right out of the ED, but there's something else that you also have to take into consideration with Hillsborough County, is Hillsborough County has 30 Marchment beds. And they have a good coordinated system of care with their central receiving facility where those 30 beds are located. And she's got step down and she's got respite and she's got residential. Hillsborough County has significantly more resources for this than Pinellas County does. So I did have that question. My concern is when we look at the data on Narcan administered, where the ambulances go, and I'll lead into something that the hospitals are working on. And I'm really pleased that I was able to bring these folks together. So Northside and Largo Medical are the #1 transport locations if Narcan has been administered. St. Anthony's has a lot of suspected overdoses, but Narcan isn't necessarily always the thing that's been administered when they go there. And when you look at the zip codes, for the highest number of overdoses, 2 are in Clearwater, 1 is in Lellman, and 2 are in St. Petersburg. 1 is Central St. Pete, and 1 is south of Gandy. So, so what I've gotten Largo Med and Northside to do is they're going to do training with their staff and have their psychiatrists meet with every single person that comes in that's been Narcan and has been transported there. And they are willing, because they were Narcan, that means that they were a danger to themselves and nearly died or did die. And then the Narcan brought them back into life. And so a Marchment, for those people that don't know what a Marchment Act is, it's the same as a Baker, that if you're a danger to yourself or someone else because of your addiction, you can be involuntarily committed for up to 72 hours. So Northside and Largo, especially with their frequent flyers and using the Narcan as the indicator, as a danger to themselves, are willing to have the physicians Marchment those patients and send them up to the 10 Marchment beds that we have on Keystone Road. When I had spoken to Barry, he said it was all right if we use the ambulance to do that. I think the mental health ambulance would be the way to go. When ACTS has done some transports, people have actually opened the door of the van and gotten out. So that's kind of I didn't mean to mention that out there, but things like that can happen and we don't want them to happen. So I think now I will say up front, I think the best system isn't just marchmenting. I think KPMG has said in their report that, or at least in a presentation, that often something like a marchment is only going to help about 50%. Now, we had 423 people die last year, and if we were to help 50% of them, I would be okay with that, right? But I think we need some kind of coordinated system. It can't just be the marchment. Currently, we only have marchment beds for males. Granted, most of the people that get Narcan, I believe, I haven't seen the data recently, it's middle-aged white males. So that is the highest number of population, but we don't have a system for women, and women are in this data set as well. And so so rather than to go on, and Daisy, I don't know if you even knew much about that. They haven't started it yet because of COVID. There was an outbreak at hospitals. Of course, hospitals have been overrun, so we haven't started that yet. But I worry about if it's grant funded, if it's not going to make it. And I think, like Tampa General does, they have some kind of system, but I just think that, you know, I'm really proud of these hospitals doing this, but we need to do something else. That the other 50% that aren't going to, it's not going to work for a marchment, then how do you get them? How do we, you know, curb the death rate? Because based on your presentation, we've had nearly a 10% increase of responses for overdoses. We've already had 102 drug-related accidental deaths, and I do know it takes a long time to get those reports on whether or not they're accidental or not. And so it appears to me that we're on the path to even exceed the 423 deaths we had last year. So we're going to be pushing more than 400 deaths this year. Even in a lockdown in a COVID situation, we're going to lose a lot of lives. And I think every life is precious, and I hate to lose any life. So I guess I'm rambling and not asking my question, but I have a lot of questions about the SIP grant. And how does this SIP grant fit in?
I would need to get more information on that, Commissioner Peters.
So, okay, and how about the task force, the Pinellas County Opiate Task Force model, adapting to what you saw in Erie and Buffalo? What have they done based on what you saw last year? It's been 7 months since you went. What have they done that would implement something like that in Pinellas County?
Yeah, and I'll take that because I was in Buffalo, and I want to say that Gail Guidish, who most of you know is Dr. Cho's second in command, went and she also oversees the task force, her and Diane, along with Dr. Cho, came back and was very excited about what we saw in Buffalo. Our task force, who I think does a good job, but a lot of it is about strategic planning and education, and it needs to be more action oriented. And they all agreed when we got back. So we had a couple of meetings right when we got back from Buffalo, a core team of folks to look at the task force and how we need to do it differently. And a lot of it is what you heard Daisy describe as the different committees. For example, they have a committee of moms whose kids have overdosed, talk about passion, commitment, working hard, wanting to get things done. They on their own, as an example, brought up vans to transport folks that didn't have transportation to go to drug treatment or to an ED or any of that. So that's just one example of how different it is in Buffalo than what our task force does. So we've been working on that. Again, there's been a couple of meetings, and that's PAR, Dr. Cho and Gail are the leads on that. But it has a whole renewed sense of energy compared to what our task force had been doing.
Okay, and I have a couple more, if that's okay. On the OD maps. The OD maps are free, and the data is now fed in by the Department of Health. So how are we using the OD maps now in Pinellas County?
I'll need to follow up on that, Commissioner Peters.
Yeah, and I can tell you some about that. So we do have another grant with, I believe, the Department of Health, some law enforcement, and PAR to look at the zip codes, right? So one of the things that we learned, for example, again in Buffalo, is the Narcan and how they give it out. They give it out everywhere. They even have it in like bus stops that are readily available. So we've taken some of that data, Commissioner Peters, that you just mentioned from OD maps to look to see where those places are. I know we talked about that we really don't want to give those out publicly, but I can tell you one of them is in St. Pete, one of them it is at a bus stop. So that is something that that team has done to look at that area and what can be done differently because of using all of that data and what we learned in Buffalo.
So don't you think there's value in using those OD maps that are free and the data is available to share those overdose locations with law enforcement so that they can more quickly get into that area and collect those drugs before other people get them? Because when someone's going to get their heroin and shoot up, they don't wait till they get home to shoot up. They don't even wait till they get into a car or go to a new location. They get their drugs and they shoot up right away. And when our overdose response goes to the same block, the same location, repeatedly 10 times, don't you feel that there's value in sharing that with law enforcement so that law enforcement can get there after the second one and get those drugs off the street and maybe save lives? And
yes,
I know we're not
100%.
doing that, but is there a plan to do that?
Yeah, and that's part of what they do. And I know you've attended, and I believe Ashley has attended some of the fusion groups. That's a whole different group. It's not the task force. It's more, and for those of you who have never attended, it's more law enforcement, medical examiner. Dr. Jameson's a big part of that to do exactly what you're talking about.
Okay, so, but see now, you're right, I've been to those and there hasn't been any movement that I know of, unless something's happened since the last meeting that has done this. And we talked about this in the last 2 meetings. And as far as I know, no action has been taken. And so I'm asking you, there haven't been any of those meetings this whole year because of COVID. So have they moved forward on that? Clearly within, and I believe it was within a 6-week period, our death rate spirals. It spiraled. It was, and according to my son, who's a firefighter, instead of having to Narcan somebody 2 or 3 times to bring him back to life, the drugs that were on the street in April and May, we had to Narcan them 4 and 5 times to bring them back to life. And unfortunately, that drug affected the heart rhythm, and therefore we lost many people, weren't even able to save them. So if we know that we have a lot of people dying in one particular area because of the OD maps, why would we wait even to have a further conversation than use that free data to have access to law enforcement to go in there and get the drugs off the street before more people die? And I would like to see a faster action on that, or at least some action. As far as I know, we talked about it twice the last 2 meetings. They meet quarterly, and as far as I know, nothing. And it's free data. It's not costing us anything.
So if the law enforcement agencies can get it for free, and why aren't they getting it?
It's redundant for them.
Seems like
EMS is already entering the data, and therefore law enforcement would have to re-enter. It's redundant. So EMS could provide that. OD map them.
But you're saying that the data is already there, right?
The data is already there through EMS.
Well, why isn't law enforcement
Department of Health
accessing that then?
I can't answer that because it was my understanding law enforcement has it. So I don't want to, debate that here.
I think like they'd be interested in that kind of information if they were doing enforcement things. I hope they are.
So I guess my question then would be, I see your recommendations. I'm not sure what the right solution is on this one. I really want to see how it works out with Largo Med and with Northside. I think what they're doing over at St. Anthony's is, and I don't know is that the one that you're talking about, the bridge program? And if not, it might be that other program that was funded with a grant. And I don't know how that one's working. I have never seen a report on how that one's working. I think it's I don't remember what grant that was.
It's a HRSA
Daisy.
grant.
Okay, and has that program shown any promise?
While Daisy's thinking of that, I'll just let you know that I know that the Sheriff's Office as well as Largo PD, and these are things that we try not to talk about too much in public, has used that data. And maybe I just need to leave it at that, you know, with different hotels and different things happening in the community. So a lot of times when you hear us being a little vague, and, you know, we are not the law enforcement side, but I can assure you that they, you know, they're doing that. And they do talk about it at these meetings, but it's not something that we typically, you know, put out and share. Daisy, go ahead with the grant.
No, I'll have to get the numbers for you. I don't have the numbers with me here today.
Okay, so it wasn't something you recommended as a best practice on your list, correct? I don't see it on here, so I'm assuming not.
Commissioner Peters, which one are you referring to? I'm sorry.
The other one that is a grant funded at St. Anthony's.
Yeah, it's a very similar program. It's just that it's for the healthcare for the homeless individuals.
Yeah, it's just for homeless, that one. It was a grant that we got.
Okay. So your suggestion is, let me go back to that page. Are these listed the way you suggested them and what you think is a priority or not?
These are just ideas that we were listing and not necessarily as priorities.
See, I have a hard time with just designating $500,000 without looking at something specific. And you know, unfortunately, I don't know that KPMG really looked at this issue. I think they looked more at the mental health issue. This issue upsets me only because it's been an epidemic for years and the numbers are still climbing, and I think we need to do something. I think Northside and Largo have really stepped up, and when they can finally do that program, I think we can see some impact, but I think there has to be more, an additional something more that we can capture. I think coming out of the hospital, if you know, if instead of March Man, every single person, that if there was somebody there that, you know, there was, if we've got a good enough professional to determine, yes, we can do outpatient without an involuntary commitment. How do we do that? I know we have a lot of hospitals. How do you pick one or two? Clearly know where we're transporting the most. There's three hospitals that get transported to the most. We can put our energy and focus in those 3 hospitals, but that does leave a lot of areas in the county untouched. And so I worry that 500,000 isn't enough, but I think more than anything, I worry that we don't really have a plan to consider that money for. And we need it. There's definitely a problem, but I don't see a plan. We're on the mental health thing, we're talking about it, and there's a plan that we could execute, and I don't see a plan here.
Yeah, part of the reason, if I may, is we'd like some flexibility with that. What we've learned with the hospitals, they're a big partner on this. We also know that we don't have enough Marchment beds. So what the plan is that we would use some of that for Marchment as needed, right? Because as you all recall, ACTS is doing some beds, right? Some Marchment beds, and they're not funded right now, by the way. So most of those were for the sheriff. I reached out to him and asked if we could have some of those beds because, quite frankly, the jail program that was set up was not working. So we didn't want to have empty beds, right? So some of those beds would be for the hospital now. We've opened that up. And we'd like to add more with that, as well as having some bridge money to work with the hospitals to see what it is they're missing. But, you know, this is a huge benefit, of course, not only for our residents, because they'll be, you know, better off if they have an opioid addiction, but it's a huge benefit to our hospitals to get folks out quickly, because that costs them a lot of money. So our hope is that we'll be working with the hospitals to see what they can add to this solution and continue to work with them, because they've been amazing partners. As you all know, you hear me talk about COVID all the time, what we're doing with them. Also with all of our human services programs, Daisy meets with them on a quarterly basis. They've been outstanding partners. To me, this is just another step in what's needed in the community and working with the hospitals.
Okay, I agree, and they have the most to gain financially if something is done because they're the revolving door in the ER. But my next question is on that hospital program that you saw in Erie, that they're giving a medication, you said in Tampa too. I'm assuming they're only giving them either Suboxone or methadone, because if they give them, oh gosh, Vivitrol, if they give them Vivitrol, it would be very dangerous to release them, because if they were to drink alcohol or take drugs, they could die. So I'm assuming that they're giving them either a methadone or Suboxone.
I believe so, but I can
correct?
tell you there is some controversy with what you've just said. And if you talk to the doctors, they don't always see it that way. So, you know, in the future, if we ever get to do this program and do it properly, we would have a doctor. And that's what they do in Tampa General, to make those decisions and to talk to other doctors and educate them, because doctors worry about that, exactly what you just said, Commissioner. So I don't know, I'll just leave it at that for right now, if that's okay.
Okay, thank you.
Okay. All right, anything else on this?
And this again is with the funding. You know, I know we're going to talk about this at a later date during a budget meeting, but what we did was, this was the KPMG money that wasn't spent for that project. So that's what we were thinking on our end. And Barry is smiling, and I'm going to give it back.
Just to not confuse it, because I don't want to get involved in the KPMG report again. Okay, so it's basically Lourdes come up with money within their budget. Bill had captured that though, and so we're just going to reallocate that. So it's $500,000 for KPMG and $300,000 for the staff. That covers the mental health. Then separately $500,000 for the opioid initiative, and those will be built within the budget. The budget that you're going to get, since it's already printed and coming to you on Tuesday, doesn't necessarily capture all of this conversations. We're going to have to clarify that going forward, but that's the intent of the budget that'll be recommended to you.
It's a proposed budget.
That is correct.
So, well, thank you very much for Lourdes saving all that money, and for Bill opening up his hand again to let
Oh, Daisy.
All right, let's move on to the airport master plan.
All right.
Let me get everybody set here. Hold on one second. We'll get Tom and Doug DiCarlo from ESA. They should be here on the panel now.
It's like they're here.
You guys are gonna have to unmute and share your video. All right.
All right, we're ready to go. First of all, good afternoon, Madam Chair and members of the board. Tom Gisberry here, your airport director, along with Doug DiCarlo, who's the project manager with Environmental Science Associates, which we will refer to as ESA, who is overseeing the development of PI's new airport master planning process. We are with you today to present an overview of a recently completed airport master plan. Okay, Brian's bringing up the first slide. Appreciate that. First of all, airport master plan. It's just that. It's a planning tool that'll help guide the short and long-term development of the airport, and also meet the future operational demands that may be required over the next 20 years. The master plan will provide us the required guidance to satisfy the aviation demand in a financially feasible manner, while at the same time addressing aviation, environmental, and also socioeconomic impacts. In fact, the last airport master plan was approved by the board back in December 2004, and then back in September 2013, the board approved an agreement with the ESA to go ahead and move forward with the development of the new airport master plan. One thing that I do want to note for you is that the FAA doesn't approve the master plan document. Rather, they approve the aviation forecast activity and the airport layout plan that are products of the master plan. The airport layout plan drawing, that depicts the existing and also future airside and landside conditions, and that will be approved by the FAA, subject to the board adopting the master plan when it is brought before you later this summer. It's also important to note the final adoption by the master plan by the board will not necessarily constitute approval of each capital improvement identified in the master plan. So any and all major capital improvement projects will be brought back to you, to the board for future approval. And with that, I would like to go ahead and turn it over to Doug DiCarlo with ESA to present the projected passenger enplanement forecast. Doug.
Thank you, Tom. Good afternoon. Can you all hear me?
Doug, you've got an echo on your sign. Can you do you have another broadcast going right now somewhere? In another
Tom, maybe you're muted.
Okay, there you
need
go.
to mute, Tom? Is that better?
Yes.
Yep.
Okay, I apologize. Good afternoon again, Madam Chair and other commissioners. As Tom said, Doug DiCarlo with ESA, the project manager for your master plan study. Just to get into, like Tom said, an overview, this slide is one you saw last summer when we did an update. This is the aviation activity forecast, one of the elements that the FAA does approve as part of the master planning process. And the reason we wanted to present it again today was because obviously the big issue with any airport or the aviation industry as a whole is the impacts of the COVID-19 pandemic on our industry. But that's not to change the master plan as it's noted here at the bottom of the slide. These were approved back in April 2018. We had a base year of data for all the different forecasts done of 2017. And I guess the thing that I really want to point out is that this is still valuable for the study, even though we've certainly had decreases in activity at the airport since the start of the new year, or actually March of this year. And the reason being is in the master plan, the larger development programs or items that we look at for improving the airport over a 20-year horizon are certainly based on these forecasts. But also, as it says at the bottom there, these forecasts are an unconstrained look at what the market will bear. And the bottom line is these help us define planning activity levels within the study or the elements of the study that follow, so that we know at certain thresholds, for example, when we hit 3 million passengers or other numbers such as that, what changes or improvements need to be made to keep the airport with the adequate capacity and certainly the level of service that you desire for your customers. So there's still a value here, even though we've certainly experienced a hiccup of sorts, is one way of saying it, for the annual enplanements or passenger numbers, which I wanted to remind those that may not be familiar, the enplanements are really half of the total passengers that are handled at your airport. That's an FAA matrix that basically represents the number of people that get on an airplane at PIE. So the total passengers are effectively double the numbers you see here on the slide. But the thing we wanted to point out is that while the forecasts were static at that time, the airport has already seen some improvements in the number of passengers, and they do expect a full recovery within 2 years. So I think the bottom line point again of this slide is that the forecast, while it's based on 2017 data, still serves a purpose moving forward in the study and the program that we have developed to identify the key thresholds for capacity and other improvements at the airfield. So with that, I'll turn the next slide, please. I'll turn it back over to Tom.
Alrighty, thank you, Doug. The next slide, we'll talk about everybody's favorite subject, aircraft noise. But specifically, what we're going to look at is the noise contour modeling for the next 5, 10, 20 years. But first, I want to give you a little background or education on noise modeling so you can better understand really what we're looking at and what these colorful squiggly little lines really represent. The FAA uses DNL, which stands for day-night average sound level, as a noise metric.
Did we lose Tom?
Oh, I lost his sound.
Tom, can you hear us? I think we might have lost him, Madam Chair.
Okay.
Okay.
Doug, Tom?
Somebody?
Here, let me see. Let me see if I can recover him here.
Oh,
Hang on.
Well, Tom's still there.
Yeah, it looks like we lost video and audio on both of them at the same time, which is a little bit strange. Oh, hold on. They're back. Tom.
Unmute.
Tom, unmute yourself.
Tom,
can you unmute yourself? He's going, but
sure, it's fascinating what he's saying.
Yeah. Tom, can you unmute yourself?
Am I there?
Tom, yeah, we lost about the last 60 to 90 seconds. You had some network issues going on there, so we were hoping you can kind of start over on this slide if it'd be okay.
I'm back with you. Can you hear me?
Yes, sir.
I apologize. What do you know what area we left off at?
I would start over on this slide. I think you were
Okay.
You were kind of getting started, and then we lost you.
All right. Apologize for that. Again, what we're looking at here is our noise contours for the next 5, 10, and 20 years. And a little bit of background as far as education. Yes, they can, please. Cool. I'm sorry, can you hear me?
Yes, sir.
Okay, I'm sorry about that. I had somebody say that it wasn't working. Again, I will try to make this quick. I apologize for that. A little background on the education as far as noise modeling, so you can better understand what you're looking at and what all these colorful squiggly little lines really represent. The FAA uses DNL, which stands for day-night average sound level, as a noise metric to measure a person's cumulative exposure to sound over a 24-hour period. Based on an average day of the year and also the number and type of annual aircraft operations. So the DNL is actually the sole noise metric that has been adopted by the FAA and is accepted measurement of aircraft noise. The FAA also considers aircraft noise exposure greater than 65 decibels in residential areas to the orange contour, the 2008 contour. And that is a result of the elimination of Allegiant's MD-8 aircraft. And also another impact is the elimination of the early morning and late evening UPS flight activity that we used to experience. So even though portions, if you look at the 2038 or the 20-year 65 DNL, which is in purple, you will see that it does extend slightly to the north and south compared to what we have in the base year, but still does not incorporate any incompatible land use. And certainly a positive in this, you will see by the where it shrinks considerably on the east and west ends of the airfield, particularly towards Feather Sound community. So that is certainly advantageous for us. Next slide, please. All right, now let's take a look at some of the recommended airside development. First of all, in the center of the slide, you'll see a gray, what is a general aviation runway labeled 36 right, 18 left. This is currently on the airport's layout plan that was approved under the previous master plan. So if there is a placeholder for this. We will look at initiating design and construction only when airfield capacity necessitates. And we really don't even feel that we're going to probably see the need for this in the 20-year period. But again, we still want to keep that land available as a placeholder for that future development. On the north end, you'll see the terminal development. We'll certainly talk a little bit more about that and in detail. Again, we would be expanding the existing terminal footprint and also setting aside land to the west of there for future development past the 20-year horizon. Another big part of this airside development is the construction of a new parallel taxiway that provide airfield connectivity to the Airfield Golf Course. As you know, we are looking to go ahead and actively moving towards trying to develop that for both aeronautical and non-aeronautical use, but right now the aeronautical does not have any connectivity. So that is a priority to look at getting that moving forward in the years to come in our CIP program to provide that. Another thing that I did want to note, a lot of you or all of you are familiar with the commitment that we made to the Feather Sound community back in 2010 to preserve a green buffer area. That's the small triangular piece of land between Airco and Feather Sound to provide a visual and somewhat of a noise buffer for that community. So again, that commitment is codified and preserved in this airport master plan. The other areas you will note, some of the areas that are located or shaded in orange, focuses on the non-aeronautical development as well. We still have the 8.5 acre Turtle Club site that is, we are now ready to look at possibly putting an RFP out there to develop that. We set that aside years past for parking capacity, but that's no longer needed at this time. And then to the south or to the left of the slide, you'll see an area that's actually already under lease with Brookline Development, and they're actively looking to build a hotel as well as a small business park. Next slide, please. Okay, this is the current Landside as we will see it when the Gateway Express project is completed. We have the current Landside parking lot project, which is scheduled for completion later this summer. And that will increase our airport parking capacity on the north side of Roosevelt by as much as 38%. That'll expand our short-term, long-term rental. You still there?
Yeah, we're here, Tom.
Okay. Yeah, it'll expand our parking lots, including a rental car, and also provide a much improved roadway circulation. Now, with parking demand, if you had asked me 2 years ago, where are you going with parking? I tell you, we're getting ready to, next step would be going vertical with a parking garage. But we're going to scale that back. And the reason is we really need to get a better handle on what our parking demand is. We've been highly impacted, not only by construction activity, but the impact with Uber and Lyft over the years. And now with the downturn in traffic as a result of the pandemic. So we will be initiating next year a parking demand study that will better sort of ascertain what that demand is and whether or not a parking garage is actually needed in the next 5 to 10 years, because we're talking a significant price tag of $20 to $25 million. So we will also look at the possibility of expanding our long-term parking even more, potentially by relocating our rental car parking off-site by constructing a new consolidated rental car facility. So those are some of the larger impacts associated with that future development. So with that, I would ask if Brian, if you could please advance the next slide, and I'm going to turn the presentation back over to Doug.
Thank you, Tom. The second slide, or this slide here, kind of shows what Tom showed 2 slides prior on the ultimate build out or the future passenger terminal expansion areas. So this is beyond the 20-year planning horizon of the current master plan that we're working on. But it's, as you've heard the term before earlier today, it's a placeholder. We want to make sure we reserve or preserve that capability in the future to go beyond what the 20-year horizon is in the study. So what I'd like to do is just take a few minutes to walk you through the terminal program within the master plan CIP or capital improvement program for the 20 years, because that's the shorter term build out, the more realistic that we see happening. So the next slide, please, Brian.
Oh, there you go.
So the first phase of the terminal development program, I don't have the ability to the point, but hopefully you can see we're showing the improvements kind of in a yellow hatch with a red outline there. It's the expansion of the terminal building to the north of your existing facility in front of what is currently your gates 7 through 11 hold room area that was just recently improved a year or so ago, and your current baggage claim area. And what's important to note here is all these terminal phases, the future terminal expansion and improvements, are 2-story structures. And that's important because that will give the airport the ability to hang, if you will, or install jet bridges so that we have also termed contact gates for the aircraft, and the passenger level of service has improved significantly over what you currently have. And that was something that was identified very early in the study. was that we wanted to be able to provide that higher level of service in the new future improvements of the terminal. So this first phase does that. It creates the first 4, if you will, contact gates or jetways, in addition to the 2 you currently have. I also want to point out, before I go to the next slide, at the top of the screen, and it may be hard to see, there's the old runway Tom mentioned that has been decommissioned, has the yellow X's on it, but above that you'll see, just above that, thank you, Brian, is a new taxiway. That is being dubbed at this time Taxiway Charlie, and that's a project that needs to occur before phase 2 of the terminal, because once phase 2 of the terminal, as you'll see in the next slide, the current access to the terminal gates would be cut off by the first expansion of the concourse. And there's that image Brian just pulled up. So phase 2 of the passenger terminal improvements is the beginning of that first concourse finger going to the north. So as you can see, it does kind of cut off the aircraft access to the west side or the left side of this figure of the current building, or even the first phase of the terminal. So that taxiway is an enabling project to get to phase 2. Phase 2 of the terminal is this first expansion to the north that I just said. It will add a couple more contact gates, again, a 2-story structure. But what's important about this one and that wider throat of the building there is it creates a consolidated concessions area. Pretty much the long-term consolidated concessions area will be developed within this first phase. If you don't mind, the next slide, please, Brian. Phase 3 is a little harder to see. It's right where he's pointing. It's connectivity to your existing gates. So this would be a second floor kind of access to be able to bring those passengers back and forth between the consolidated concession areas and the gates that you currently have on the east side of the terminal, or gates really 1 through 6 or 5 on this figure. As well as in the middle there, you see again, the red box with the yellow highlight. That is where we would expand and change or update what is now your gates 7 through 11 hold area into a consolidated TSA checkpoint. So this is where all passengers would enter into the gate area or the concourse area, and then depending on certainly the airline or the gate that they're working with, they would go either straight ahead down the new concourse to the left to the gates of phase 1, or back to the right to your existing gates and hold areas. Next slide, please. The fourth phase extends the concourse to the north, only one side of it though. The ultimate length of that concourse would go to the north, and it adds more contact gates, as well as it starts to expand, or this is where we really have to make some improvements to the aircraft apron or aircraft parking areas for the aircraft coming to those gates. And then simply phase 5 is the ultimate build out of this concourse, again, within the 20-year horizon of the master plan, where we finish that extension of the concourse to the north and build out the aircraft parking apron areas on the east side, or to the right there, as you are seeing with the pointer. That is the 5 phases of the terminal program that we have within the short term. Again, there would be an ultimate phase to the left on the west that we're preserving that ability that's reflected in some of the past figures and certainly the ultimate ALP set. And with that, I'll turn it back over to Tom to talk about some of the financial considerations of the overall program.
Tom, you're muted. You're gonna have to unmute.
Okay, we're with you. So you've heard explanations as far as the various improvements, Airside and both Landside. So we talked about how we're going to look at funding some of that and the costs involved with that. If you take a look at the first column, we look at the short-term developments, which represents the first 5 years, beginning in 2019, looking at about $96 million. Now, it's important to note that out of that $96 million in the short-term horizon, approximately $67.5 million is already underway or has been constructed out of that $96.1 million identified in the first 5 years. The runway improvements noted at $25.5 million. That is our for runway of 1836 pavement rehabilitation, which is underway. Terminal improvements, we have future funding with FDOT that's already in our program. The $22 million was recently completed. That includes the terminal renovation phase 3, the new inline baggage system, and also the improvements we made to the U.S. Customs facility. Now looking at the intermediate, okay, our intermediate is going to represent in the next 5 to 10 years. This primarily includes the first phase of the terminal expansion, also a placeholder for the potential parking garage, and then the terminal roadways. That would be really, that is infrastructure improvements that we're looking at for Airco. So that's the $64 million for the intermediate. Whereas the long-term improvements, that's for a 10-year period from 2029 to 2038, that will primarily focus on further pavement rehabilitation construction that will be needed at that time, as well as further terminal expansion, the construction of the new airport fire station. And by that point, we'll be ready to certainly look at updating the airport master plan. So now let's talk about how we can potentially fund these $301 million in capital improvements over the next 20 years. So next slide, please. Focus on the short term. And we'll be looking at the different type of funding sources. I'll explain them that will support that $100 million in proposed capital improvements. First of all, FAA entitlements. I think most of you are aware that's money that we receive from the FAA based on the number of annual passengers or enplanements. In 2019, we received approximately $4.5 million in enplanements from the FAA for eligible projects. Now, discretionary funding is more of a competitive process whereby airports compete for discretionary funding, and the FAA will weight it or put priorities on projects that enhance safety, security, or capacity. We were very fortunate that it took a lot of work, but last year we received as much as $15.7 million in discretionary funding, which is the most PI has ever received in discretionary. So we will be looking at trying to leverage that certainly in the years to come. We are a recipient of FDOT aviation grants for eligible projects similar to those FAA. The FDOT also has a separate pot of money called SIS, or Strategic Intermodal System. There are certain airports that meet the SIS criteria. PIE is one of those. We were fortunate. We received $4.5 million in SIS funding for airport capital improvements, and that money needs to be utilized starting 2023. So we have that at our disposal. We also collect different user fees to help fund these capital improvements. We have passenger facility charge. It's at $4.50, and we receive that per enplanement. For every passenger that boards a plane, we'll receive that $4.50. We receive approximately about $5 million a year in PFCs, and those can only be used for FAA eligible projects. We also have the ability to utilize funding that we receive from other user fee, which is referred to as a CFC, or a consolidated facility charge. The board approved that a couple of years ago. That is a $4 user fee per rental car transaction a day. That collects about $2.7 million a year. We've also been the recipient of various TSA grants, Department of Homeland Security. In fact, we were awarded $5.2 million a couple years ago to help fund the automated inline baggage screening system that we recently completed a couple months ago. And then we also have the airport's match for these various grants, whether it's a 50-50 match for FDOT or 90-10 for the FAA. You'll see in there that there's a significant amount in the short term. That's because we have utilized the damages and cures that we received in the amount of about $12.7 million from FDOT settlement for the airport property sale to support the construction of the Gateway Express project. So that, in short, provides a summary of the capital improvement program along with the funding sources that will help fund that. So before I open it up for questions, I certainly would like, again, to reinstate that when you do approve the master plan in the next couple months, everything contained in it and capital improvement will be brought back to you for further adoption and approval. So with that said, if there's any questions, certainly like to entertain those. Commissioner Eggers?
Oh, you're muted, Commissioner Eggers. I'm sorry.
Yeah, that's the after lunch. I forgot. Never forget that, the muting. Thank you for the presentation. It's always great to see successful airport continuing to do well. In that short-term plan, the 2019 to 2023, I mean, we've always talked about, maybe expanding another airline or so or two. Do we have room now to do that within that short term, or is that more kind of an intermediate term thing? What does it usually take? How long does it usually take? Probably the big to land another group.
Well, it's a good question and a hard question. Actually, to be honest with you, it takes several years usually, as far as convincing an airline to go ahead and come into your community or into the airport. We certainly want to position ourselves to always be able to handle additional growth, and we do have that. We are fortunate that over the past couple of years that Allegiant has better utilized or has better gate utilization. What I mean by that, instead of having massive banks going out and coming in at the same time, they've based aircraft at outlying cities. So we do have gates available to be able to go ahead and handle additional airlines. And of course, we're actively in discussions with the possibility of some new entrant airlines that hopefully will pan out in the future to come. So the development that we have going on right now, we are able to acquire or handle additional aircraft, and then that next phase of terminal development will expand hold room capacity and add boarding bridges more than actual gates. It's the next phase that you'll see that happen.
And I would be remiss if I didn't ask the question about our continuing efforts to make sure that our airline or the users of our airport really respect the landing and takeoff timeframes that we allow, the late night kind of things. And maybe you could speak to that again, just to remind folks of what we're trying to do, what control we do have over it and what control we don't have over it. But clearly that's a concern with people living primarily in the Safety Harbor area. But just a quick comment on that. And just finally, I'd just say, since this was my project in engineering school, it was redesigning airports. This was really fascinating to see. We didn't have to do the phasing part, the reality part, that you guys had to do, because the airport has to keep operating while you do it. So that's a little tough part to it. But I really appreciate the work that goes into something like this. So thank you. But just to comment on the level, thank you.
Certainly, appreciate the comments. With regards to noise, we have in all our airport operating agreements a condition that we encourage the airlines to abide by our noise abatement procedures, and then also try and avoid scheduling flights within our voluntary quiet window from 11 p.m. to 7 a.m. We don't have the authority to levy fines to mandate that. The airlines are partners of ours. They do realize the sensitivity of noise communities surrounding us. So they do try to work with us when they can. But unfortunately, there are times where their schedule will not permit them to go ahead and avoid that voluntary quiet window. The only other option would be to eliminating those flights altogether. And it's certainly not the direction we want to go. So we do monitor those. In fact, we monitor every arrival and departure for compliance. We have regular, and I mean almost weekly, conversations with the chief pilots, providing information back and forth. Now, unfortunately, we have seen an increase in flights scheduled in that voluntary quiet window. The reason for that is it goes back to the pandemic. What has happened is airlines always focus on trying to do a quick turn so they can get a better aircraft utilization and time. Well, there's more time being spent cleaning aircraft, the time spent between deplaning and boarding the aircraft. So that has expanded their schedule and pushed it into those later hours. So the hope is, when the time comes that maybe some of those conditions and requirements are lessened. Maybe they can get a quicker turn time. We'll be able to get those flights out of that voluntary quiet window.
And final question, then, when that happens, obviously it becomes more important that we deviate the flight path away from the city of Safety Harbor, as much as possible around it. What percentage of those flights that are in that window that we don't like, so to speak, what percentage of those are we getting to comply with those flight patterns that we need? Would you say? Is there a
not exactly, but I can come pretty close. We're probably seeing close to a 90% compliance rate at times when they can fly it. What I mean, if there's weather conditions that require instruments, they have to fly straight in, or if there's conflicting traffic. When those conditions aren't in place, we have seen a very good compliance, especially during those late night hours.
What would you say the big reason for not complying under those situations? You said 90%, but there's some that aren't complying. What would be that main reason for not complying? Again, I'm not talking about the weather piece.
Yeah. Well, that's the thing. Ultimately, it's up to the pilot whether or not he wants to fly the procedure or not. Sometimes, it could be a newer pilot that's not familiar with the procedures. It could be something that late night flights and pilot fatigue and just feeling more comfortable flying the instrument approach in. So there's different factors such as those that come into place that may result in the pilot not flying the noise abatement procedure.
And from your experience, 90% compliance like that is fair, good, excellent. Where would you?
It's certainly a lot better than we've seen in years past. I think it's good. It's on the right track. Certainly, we're not going to be satisfied until we see 100% compliance. And again, the nice part is we have a really good relationship with the chief pilot that we communicate those concerns, or when we see pilots deviating from it, that we investigate and try to determine what that is. So, we've had the task force that's been in place for some time now under the leadership of Mark Sprague, who continuously focus their attention and do a good job on it. So again, we're doing good, but we can do better.
Thank you.
Thank you. Commissioner Seal.
Thank you. Commissioner Eggers asked a lot of my questions, but from one of the constituents who's been concerned about the noise, he mentioned that there is a modernized offset ILS, i.e. a localizer type directional aid, an LDA. Could you comment on that and whether that would be possible and help? Because I remember going up to the FAA trying to get additional technology to be able to solve this problem. Now that was several years ago, and it still seems like we try to address this again and again.
Yeah, there's certainly different technology that comes out from the FAA. It's slow to come out, but we do look at that. We've spent a lot of time, effort, and money as far as studies that we could go ahead and take advantage of. The procedures that we have in place are actually you can't improve using that type of technology with what we have. We continually take a look at it. You may be familiar with the FAA's initiative with Next Gen that they're rolling out. We worked with them to ensure that we are protecting any of our procedures, instrument procedures that can and will benefit the airport now and into the future.
Okay. My next question is, I'm surprised about the parking garage, and I know we received FDOT damage and cures because of the Gateway Express. I thought part of that was being programmed for a parking garage, and the parking garage was a due result of the Gateway Express.
Yeah, we certainly used a significant portion of that for the parking expansion project that's underway. We also implemented the CFC, the Consolidated Facility Charge that I referred to earlier, in an effort to utilize that funding to help support a garage also. and that's still identified as such. Again, parking garages are very expensive to even maintain. While we want to see that, we just want to make sure that we're investing responsibly, that we're not building a $20, $25 million garage that may go vacant. So it's important before we invest that type of money that we get an understanding of that parking demand that I had spoke to before. So yes, we were hoping that we would be able to spend part of those cures for the parking garage, but due to the significant costs associated with this parking project, we weren't able to do so.
Well, I again urge you to use any technologies possible. You know, we fought used to be that the path went over more of Safety Harbor, and it was being altered to go more over Oldsmar in the open water. And that's really the best path to keep it on the open water in the bay to avoid the noise.
Yes, absolutely. And that's what our noise procedures do. They do, in fact, keep the aircraft over the bay. I would add one caveat, though. I had mentioned that our primary air carrier runway is under construction. There's a phase of that project where it closes full length for a period of 4 months. So all the traffic, including airline traffic, has to utilize runway 422. We knew that was coming. We took the opportunities during the master plan, during the AEA to communicate that. We've also talked to our community liaisons, specifically with Feather Sound, Safety Harbor, and also advertise that to let them know that there was going to be that temporary shift. But once that portion of the primary runway is open, everything will revert back to 1836.
Hey, Tom, on that point, you did say that up front, but when is that going to happen? When will that 4-month window be, and what can we do to get that word out now? Kind of a reminder to people, because that flight path is totally different. I mean, as you leave. So just what can we do to get that word out and reminder?
Sure. That permanent closure and shift to runway 422 occurred this Tuesday. So that 4-month period has just started, and it's scheduled to be completed in November. Again, we have done a lot. We advertised with the media, tried to get that out to our noise abatement task force liaisons, different community leaders, to get it out so they are aware of it, so they're not taken by surprise. So a lot was done leading up to that actual shift.
Well, as a Pinellas County resident, just one resident out there, I haven't seen a big difference where I live, but I didn't know that had changed or had happened. So if the word got out, I didn't hear that word. It was quiet I didn't pick it up. That's what I'm getting at. So
okay. Yeah, and we know that's a challenge to try to get that word out. That's why we tried to do it several times and use numerous opportunities.
Okay, thank you. Chair Gerard, are you back?
I am back.
Okay, thank you.
Thank you.
Yep.
Okay. Do we have any more questions about the airport master plan? All right. Thank you, guys.
Okay. Thank you very much.
All right. Next issue is Gulf to Bay and Belcher Road improvements.
And Ken Jacobs is on the line.
I'm getting him there. Hold on one second. There he is. Hey, Ken.
Right. Hello, everybody. Good afternoon, Madam Chair and Commissioners. My name's Ken Jacobs. I'm with Pinellas County Public Works Transportation Division. We wanted to update you on the intersection improvement project that we have going at Belcher and Gulf to Bay. We've been working on the PD&E study, which is the project development and environmental study for the intersection, and we've completed the technical analysis and developed a few different alternative designs. So the next step in the study process is to take these design options to the public, get their input, and determine which alternatives meet the needs of the project and the preferences of the public the best. And so what we wanted to do today is we wanted the board to review and approve the alternatives before we move forward to the public information meeting. So several of you may have seen a version of this presentation at if you're on the Ford Pinellas board. That was last year. We've taken feedback from that presentation and others that we've done and modified it, and hope to provide a good overview of the project and the different alternatives. So Kevin Kulo, I think, is on the line also, our project manager with Ayers and Associates. He'll be doing the presentation, and after he's done, Kevin, Hasham, Suna also with Ayers, and myself will be glad to answer any questions that you might have. So with that, I'll go ahead and hand it off to Kevin.
Thank you, Ken. You can go ahead and advance the slide. Thanks for having me today. Yeah, as Ken had mentioned, a study is underway that is investigating improvement alternatives for the Gulf Bay and Belcher Road intersection. As I'm sure you're well aware, this intersection is currently experiencing significant delay and safety issues. There is an existing traffic signal at the main intersection, but there's also a signal to the south that services the Walmart and the Publix intersection as well. So that actually is kind of a big deal when we look at intersections to the main intersection, how they all work together as we go through the process. So next slide, please. So as you can imagine, one of the alternatives is taking the existing traffic signal and expanding it. So we looked at adding dual left turn lanes in each direction, as well as adding right turn lanes. No additional through lanes were proposed, just to the ability to grow a lane prior to the intersection and then having to merge them back down, plus all of the additional impacts that would be associated with that were not analyzed for this expanded traffic signal alternative. So even with these additional lanes added to the intersection, we still have failing operations. And what's similar today when we look at our design year, which in this case was 2037, there's significant delay that's occurring. You may not get through this signal in one cycle. So you may have to, if you get to the back of a queue, you may not get through that signal through one cycle. So this alternative also requires the removal of the Publix traffic signal on Belcher Road to the south. We'd be installing raised medians that would be restricting access and providing, those dual left turn lanes long enough to provide and store that traffic. So that signal would be removed, as well as there'd be closures along Gulf to Bay that currently provide access into some of the businesses. And those two are pretty significant when you think about it, because those vehicles now, for instance, a northbound vehicle on Belcher that wanted to go to Walmart, for instance, would now come up to the intersection and make a U-turn. So when you add those U-turns into the intersection, that has a pretty big impact on the operations of that intersection. So when we did a comparison of these different alternatives, and the comparison cost for the signal was between $15 and $18 million. We looked at alternatives with Belcher Road moved to the west, centered, as well as to the east. So that's where we get that range for the comparison cost for the signal alternative. Next slide. Thank you. We also looked at a single point urban interchange alternative. And that is what's similar to Gulf to Bay and US Highway 19 intersection to the east. So we investigated that. We'd have the Gulf to Bay Boulevard would have a bridge over Belcher Road that would provide improved operations, especially for traffic on Gulf to Bay, which would not have to stop anymore. They would just continue and go up and over. But as you can imagine, with anytime you put a bridge over the top, you go, as shown in the graphic on the bottom, over 2,000 feet in each direction. And then you've got retaining walls, and you've got, one-way ramps and kind of little frontage roads going. So significant right-of-way and access impacts with this alternative, as well as a large price tag in that $80+ million range. Next slide, please. So other things we do is we look at other innovative type of intersection alternatives, and we use the Federal Highway Administration, and Florida DOT has customized it for work in Florida, and that's the CapEx tool. So that allows us to look at other potential feasible innovative intersection alternatives. And the one that ranked number one going through this particular exercise was this median U-turn and east-west, meaning that there would be the U-turns would be on the east and west legs of the intersection. There would also be, the potential for north-south, which we also looked at, but the one that operates or provides the best for this intersection is the east-west one. So to better, just explain what a median U-turn is and how it works, we have developed a video that we can walk through, and then we'll be able to finish the presentation after this video. So thanks, Brian.
Give me 1 sec, Kevin. Hold on.
In their commitment to improve safety and mobility for all road users, Pinellas County, the City of Clearwater, and the Florida Department of Transportation are considering the innovative median U-turn at the Gulf to Bay Boulevard and Belcher Road intersection. The Gulf to Bay Boulevard and Belcher Road intersection is experiencing increasing user delay and crashes due to growing traffic volumes. To provide acceptable operations with traditional traffic signal improvements, traffic models indicate that additional through lanes would be required along Gulf to Bay Boulevard, which is not practical in this densely developed corridor. The innovative median U-turn alternative would provide improved traffic operations by removing left-turning vehicles from the intersection without adding through lanes. Let's take a look at how a median U-turn will help to address the increasing traffic congestion at the Gulf to Bay Boulevard and Belcher Road intersection. The median U-turn will comprise one main signalized intersection that will look similar to what is there today, except with the left turn lanes removed, and two new signalized median U-turn intersections along Gulf to Bay Boulevard. Left-turning vehicles will be accommodated through one of the two median U-turn intersections. The median U-turn intersections are designed to accommodate all roadway users, including larger vehicles such as school buses, emergency vehicles, and trucks. Median U-turns are easier to navigate for pedestrians and cyclists because of shorter crossing distances and larger refuge islands. The main benefits of the median U-turn are increased efficiency. Median U-turns eliminate left turn movements from the main intersection. This means that there are fewer interruptions and more vehicles can move through the same space more efficiently. Shorter wait times. Median U-turns typically operate with fewer traffic signal phases, which means motorists spend less time stopping. Improved safety. Median U-turns reduce the number of points where vehicles cross paths, which decreases the potential for crashes. Let's watch how a driver would navigate the median U-turn at the Gulf to Bay Boulevard and Belcher Road intersection. On Gulf to Bay Boulevard, all motorists who wish to continue straight or turn right will proceed as they would through a conventional intersection. To turn left onto Belcher Road, motorists will go straight through the main intersection, make a U-turn at the adjacent median opening, and then turn right onto Belcher Road. Let's follow along as the red car demonstrates how a vehicle heading east on Gulf to Bay Boulevard would make a left turn onto Belcher Road. As the red car approaches the main intersection, they will first continue straight through the main intersection in the left lane, then move into the median turn lane. Make a U-turn at the signalized median opening, move into the right turn lane, and finally then make a right turn onto Belcher Road. On Belcher Road, all motorists who wish to continue straight or turn right will proceed as they would through a conventional intersection. To turn left onto Gulf to Bay Boulevard, motorists will turn right, go to the adjacent median opening, and make a U-turn. Let's follow along as the blue car demonstrates how a vehicle heading north on Belcher Road would make a left onto Gulf to Bay Boulevard. As the blue car approaches the main intersection, they will first move into the right lane, make a right turn onto Gulf to Bay Boulevard, then move into the median turn lane. Make a U-turn at the signalized median opening, and drive straight through the main intersection and onto their desired destination. To learn more about the proposed median U-turn at the Gulf to Bay Boulevard and Belcher Road intersection, visit Pinellas County website at www.pinellascounty.org/publicworks.
Okay.
Okay.
Questions about that? Yes, Commissioner Justice.
Thank you, Madam Chair. Well, I have a few questions about the whole thing, but specifically about that proposal. Where you've seen it installed before, how long does it take for the local drivers to get used to it? That's my softball for you.
Obviously there'll be education, and that'll be a big component of getting people used to it. There'll be people that, won't get in the correct lanes appropriately. Similar to roundabouts that are being introduced, right? Anything innovative or different, diverging diamonds, right? They're all innovative type of intersections. To give you an actual timeline, everybody's is going to be a little bit different, but education will be important. But it's pretty intuitive once you figure it out and once you know how to get through there. It is a nice solution that provides great safety as well as operational improvements out there.
How often would you think that people, instead of turning right, if they were heading north on Belcher, instead of turning right, they're going to go north on Belcher and try and do a U-turn just a little bit north of the intersection?
Well, and that you will see that for sure. I'm sure there'll be a number of people that will do that, especially early on. That's where good signing will be part of this. That wasn't part of this particular video, but there will be signs in advance that show, kind of the arrow and tell you which lane to get into if you want to go, westbound on Gulf to Bay, for instance. You need to be in that rightmost lane.
And then did I hear that for this to kind of function well, that you would have to remove that second stoplight that's just a little bit south on Belcher at the grocery stores?
So that was with the relocated or the expanded traffic signal alternative. We would not need to, and that's one of the huge benefits of the median U-turn is that full access at the Walmart and Publix would remain.
Hey, Brian, could you bring up, this is Ken, could you bring up slide 8? And
Yeah, we do have a couple more slides if we wanted to quickly go through them, but Ken, do you want me just to finish up, or I'm not sure?
I can go ahead. What I did want to point out, just relative to this one, is on the other two alternatives, we did give you a ballpark cost, and so I wanted to go over a couple of the benefits of the east-west median U-turn, and that includes improved safety, improved pedestrian accommodations. But again, to Commissioner Justice's question, it maintained that signal at Walmart, which neither of the other two solutions would do, and it reduces the right-of-way impacts because we're not having to add any additional lanes through the intersection. And that comparative cost is around $13.5 million versus the 15 to 18 for the widened intersection and the 80 million for the overpass. If you could go ahead to the next slide real quick. I just wanted to give you the kind of the next steps to close this out. So the PD&E has a very linear process to it, and the next step is to take a variety of alternatives out to the public so they have input into what they think works best, and that becomes what we refer to as the preferred alternative. And so we'll have that meeting. We're not exactly sure what that meeting looks like at this case, whether it's virtual or depends on how things go in the next few months. But we'll have that meeting, we'll get that public feedback, and then we'll come back to the board one more time with basically the results of that public meeting. At that point in time, the board needs to kind of pick one of the three alternatives with the input from the public, and that's the preferred alternative that the consultant will use to finish their study. So the study should be done, and we should be able to go and design either late FY21 or probably more like FY22. That way we'll meet construction sometime in the FY26 timeframe, 25. So that's kind of the time frame from here on out, but we just needed to go ahead and move forward with the public meeting. And with that was actually the end of the presentation. So any additional questions, we'd be glad to handle.
Yeah, I just had one more global question, I guess. And I do prefer not having to eliminate that second stoplight at the grocery store. I think that's important for access. But can you just give me a big picture view of why this particular intersection has been so dangerous over the years? I mean, just looking at it, it looks like any other intersection in a major thoroughfare. Is it just volume? Is it why has it been so dangerous over the years?
Well, in my opinion, it's a very urban area. A lot of different businesses, a lot of different maneuvers. It's fairly tight in that area. If you take Almerton and 66th Street, those have been expanded to accommodate the dual left turns, the right turns in all the directions. So it handles that heavier volume a little bit better. To do that in this particular area, because of the restrictions to right-of-way, we have the transmission poles for Duke Energy down the east side of Belcher all the way north-south of there, so that makes it very difficult. But just the type of businesses that are adjacent to the road and the type of facility that Gulf to Bay is, with a lot of driveway cuts, a lot of businesses, makes for a lot of maneuvers that people aren't expecting at intersections like this.
Okay, all right, that's helpful. Thank you.
Mm-hmm.
Mr. Seal?
Thank you. So the three alternatives will be this east-west median U-turn, an overpass, and then the capacity improvements at an intersection?
That's correct.
Okay. So how do the City Council of Clearwater feel about this?
We presented it to the city. They, for the most part, had positive comments. Commissioner Johnson's comment was, do it and do it as quickly as you can. That was before when he was still on the council. So I think there's we haven't been back to them. That was last year that we went through that process. As part of the public process, I think we'll get more feedback from the city, but we didn't hear any absolute negatives to the east-west median U-turn as an alternative to look into.
Okay. Well, there's been 3 changes on the council, including the mayor. So I think it might be good to go revisit this. So with this U-turn concept, you have to acquire right of way. So has that been figured into the cost?
Well, I can, the biggest purchase of the right of way is to expand those U-turn locations out past the existing curb line to be able to accommodate the big truck traffic and things like that. That is included as an estimate in that $13.5 million as the estimate, cost estimate.
Okay. And I guess the only other question I have, did you give, I know Commissioner Justice asked this, but do we have a specific other locations in the United States where they put these in that we could hear about?
Kevin, do you want to?
Sure. Yeah. So these are popping up more and more throughout the U.S. Michigan is where they started back in the 60s. They have a lot of them installed, and they really work well when it's a corridor, so multiple intersections where you can kind of restrict all of the access and use the U-turn. So that they have a lot of their locations. But Idaho, Texas, Louisiana. I mean, yeah, we could send you links or Google Map of other locations. I know I was at Gulf Shores, Alabama recently, and last year, I guess, and they implemented that along their busy corridor along the beach there. They implement these U-turns as well. So, yep, there are many more places doing that. Really what's happening is adding more and more lanes, especially when you talk about complete streets and bicyclists and pedestrians. And, when you try and bring these all together, that's why people are starting to look for more and more innovative type of solutions such as this.
Okay. So when they put it on these different corridors, do they do more than one intersection? Because I guess that's, when we had it presented at Forward Pinellas, that was one of my concerns is it's only one place. If you're going to put it one place, then you've got to make it a similar ride down the corridor so people know what to expect, because we have a large tourist influx. So therefore they won't get used to it like the residents will get used to it. And that could create some problems. And then secondly, the other thing I guess I'm concerned about, and I do thank you for the video, that was very well done, is are we now creating even more congestion and traffic volume on Gulf to Bay by doing these U-turns? And with a signalized light, more wait time for people to travel through the corridor.
Let me kind of answer the timing side of it.
Okay.
Every time you add a dedicated movement at a traffic signal, you have to dedicate a certain amount of time to that movement. So when we added left turns to a lot of these signals, we have to basically take away time from the main street. So what this configuration does is it takes those left turns and moves those away from the actual traffic signal. And we projected, just based on the existing timing that we have at that signal, that we would actually provide 35% more time to the through movements by moving those left turns away from the intersection. So the delay to the left turns is probably going to be similar or maybe just a little bit higher than what it was before, but the trade-off is going to be a lot more green time for the through movements that are going on the main street and the side street. So from a timing perspective, you're kind of distributing the delay to multiple different locations instead of concentrating it all at that one intersection.
Yeah, and I'll add a little bit onto that. When there is additional signals at those U-turns, but they are coordinated with that main intersection. So if you are traveling on Gulf to Bay, east or west, you would, if you were to stop at the far one, you would not get stopped at the middle one. They're coordinated, so they work together. So they'll both turn green for you, so you progress through as one coordinated system.
And to kind of address your other question about multiple intersections, the DOT has basically implemented a review of these innovative intersections as part of any project development. So even if it were to be a proposed new signal, the DOT actually wants you to go through and evaluate if some intersection, innovative intersection may work better or may work instead of a signal, or delay installation of a signal, or plan towards that innovative intersection. So this innovative intersection is a way to basically make better use of the existing capacity that you have on a roadway without necessarily expanding it and having to get into the impacts of right-of-way and everything else. So I think you'll see these pop up a lot more, not just on Gulf to Bay. I think as part of any of our intersection improvement, we'll be looking at these as a potential for how we could modify those intersections to make better use of the capacity.
Okay, thank you. Commissioner Eggers?
You're muted, Commissioner Eggers.
Okay, well, most of the questions that I had, Commissioner Seal really touched on. I guess some of these, you said it works best on corridors. I would imagine traffic counts coming into intersections and whether they go straight, right, or left have something to do with the likely success of this. I do like the idea that you get more throughput. I like the idea that we're maintaining a light at Walmart and Publix. I do think that's an important access point. I remember when they did that on 19, where a lot of businesses, you had to turn left. You can't go across anymore. You have to go down to the light and do your U-turn. And
Correct.
People at that time were very upset and said, "You'll never get used to that." And of course, you get used to it. It's a lot safer. It'll be interesting to see how it plays out. I mean, I heard the timing thing that you bring up, and that if timed right. I just know that the traffic counts through there are just out of sight. So, I mean, it's almost like, the devil you know versus the devil you don't know. We know how that one works now, and it really has problems. We get that. And those two left turns to get through the intersection means to me there's a lot of left turn going on. So now you're going to send it over to one right turn lane to get out onto Gulf to Bay. As if you're going north on Belcher and you want to go west on Gulf to Bay, now you're going to take those two lanes and put it into one lane. So are we going to get people through there? And what's the wait time to get traveling left? So just a lot of questions, probably because we're just not used to them, and people would ultimately probably do that. I would tend, for a lot of the reasons that I mentioned, to be interested to see more about that system, that east-west median U-turn, for a lot of the reasons that we talked about. I do think I think your dollar estimates on these costs are a little bit low. I mean, we were talking about the bridge costs on 19. I know that's probably a little bit bigger bridge, but it was significantly north of 80 million. I'm guessing this would be too, but nonetheless, probably from a comparative standpoint, they hold. But yeah, very nice presentation. Thank you for that visual. I think it at least helped understand how it would work. So thank you.
Thank you. Yeah, if I could, I'll add to that a little bit. You're right. These would not work at all locations, and locations that have a real heavy left turning volume, they're not really a good solution for that. At this particular location, it's about 75% of the traffic travels through the intersection, just straight, and then the remaining 25% are the different turning volumes. So it is a good candidate based on that heavy, as you know, east-west traffic just kind of going through this intersection. And the reason, when we talk about the dual left turns at intersections, it's really to get as much traffic in the intersection as quickly as we can on that green time that we give for those arrows. So, I mean, we are adding more left turn lanes, but there is a good amount of left turning traffic, but it's, a lot of it is having to do with just trying to get as much time to the other movements as well, that we add additional lanes.
Yeah, Kevin, thank you for that comment. That was going to be, I guess, if I figured out to ask the right question, was the percentage of the traffic on throughput versus turning, I think would have a big bearing on whether it's Absolutely. A good candidate. And so you're saying it's 75% throughput, which means there's 25% turning one way or the other, makes it a good candidate.
Yep.
And it'd be interesting to hear some of those other places that you talk about and what their throughput is and how they're working, just as a comparative.
Yeah, yeah. I'll also add, as part of that video that we developed, you saw what we call simulation, which is the cars driving down the road. So we have that for the signal as well as the median alternative. So part of the public involvement that we're going to be doing is putting a video, and we can do the signal and the median U-turn kind of side by side, showing how they interact and the differences between the queues. So that's a very powerful tool at public meetings, just to show, first of all, how they operate, as well as the differences in their operations.
Thank you.
Okay, thank you. Anything else on this intersection? Okay, let's do agenda review then.
All right, thank you.
Thank you.
Been a long day, so ready? Here we go. Okay, items 2 through 9 are receipt for file, miscellaneous filings. Same thing, 11 and 12. Item number 13 is a plat for Riverbend Village, a private residential commercial subdivision. Item 14 is an award of bid to Keystone Excavators. That's for ADA ramps on Lakeview Road and drainage improvements. Item 15 is a joint project agreement with the City of Clearwater for utility work. They're going to be replacing the bridge at Old Coachman Road over Alligator Creek. The city will be contributing $356,000 because of a 12-inch reclaimed water main. Going over item
16. Item 16 is a lawsuit. The plaintiff is seeking return of the property where the Gulf Beaches Historical Museum is located, alleging that we have not maintained the property in accordance with the deed. Item 17 is a trip and fall. Item 18 is a result of a sewer backup. And item 19 is a dispute over costs incurred to repair a utility pipe.
Item 20 will be an extension of the local state of emergency. 21 is declared county-owned property surplus and transferring it to the town of Kenneth City. Item 22 is the second amendment of a lease agreement with the YMCA of Suncoast or Largo for an additional 10-year period. Item number 323, it is a long day, is Human Services Social Action Grant Funding recommendations. They had 73 applications received. They had a review committee that was comprised of a group of stakeholders from throughout the community, and here are the recommended awards for 15 agencies.
Item 24 is a proposed, oh, I'm sorry.
We have a question on 23 from Commissioner Seal.
Yes,
yes.
Mr. Seal, sorry.
Thank you, Madam Chairman. I would like to, I looked at the backup, and the backup that gives you the whole summary chart, when you pull it up, it's very difficult to figure it out because it's spread over multiple pages. So you almost have to count where the agency is and then go to the final page to do the scoring, find out what the score is. So if you could give us a one page or something more simple that's a summary of all the rankings, or easier to read. And also, if we could see who had the funding last time, this past year,
okay,
comparing to this. And finally, I'm glad that, my passion for dental, and I'm glad we're looking at doing dental more in St. Pete as well as Tarpon Springs, but that doesn't help us with Mid-County at all. So just a concern. Thank you.
Okay. I see Lourdes taking notes, so we'll prepare that and send that to you, and so we can discuss that on Tuesday.
Okay.
Item number 24 is a settlement. This is a confidential matter. As with weeks past, I will give each of you a call to discuss item 24. And should you have any questions on any of these items, that would be an opportunity to ask me at that point. Items 25 and 26 are cases where we are asking for authority to file litigation. These are both cases that were investigated by your Human Rights Department. Both involve housing discrimination. And I'm not anticipating any county attorney reports.
Okay.
Under item 28, we will be presenting the proposed FY21 budget. Item 29 is appointments to the Parks and Conservation Resources Advisory Board, and you have multiple people that applied for 2 positions. Moving over to the number of public hearings. The first case is a map amendment from residential low medium to multimodal. This involves an annexed property along 19. This was formerly a mobile home park that was closed in 2019. So this will be within the city and be designated as the remainder of that corridor is. Item 32 is a map amendment from public, semi-public to retail for 1 acre. Involves on 58th Street. This involves an applicant that is interested in selling to the 7-Eleven who wants to construct a new grocery store, which is adjacent to it. So they'll be constructing a new grocery store on the consolidated parcel. Item 33 is public, semi-public to residential, 5 acres, 58th Street North. This has it currently has a development agreement restricting the property to assisted living. That expired in February. After the demolition of the assisted living, the properties remain vacant. The owner intends to construct single-family residential developments. Allowable use is 5 units per acre, so it would be, and the property is limited to 25 units. Recommended by both Forward Health and Planners Advisory Committee unanimously. Item 34 is an ordinance amending the countywide rules. This would allow us to restore the residential rural future land use category, which is 0.5 units per acre. Previously discussed. Item 35, this is a petition from Christopher Mueller and Laura Mueller for an 80-foot right-of-way, formerly known as Illinois Avenue. Staff objects to this based upon a variety. I think many of you have been up and seen this parcel. There'll be a robust discussion, and I know the petitioners plan on attending.
Barry?
Yeah, David.
Yeah, it looks like that you all are agreeing to part of it, right? Approval of the southern vacation. At least it's a 20-foot wide alley to the south. So you're agreeing to that vacation.
That's correct. So there's part of it, but the remaining, so we'll have a complete staff presentation, but yes, we could agree to part of it.
And the other question I had, just, you don't need to answer it now, but just the idea that on the north, the other one that we're not agreeing to, and is that a situation where the reasons that we're not are things that are coming down the road a ways and they can continue to use it as it is now, or is it just it's pending quickly that we need to clear it out now? I mean, is that, again, maybe we can think to that, just, you know, as far as, you know, clearing it out when we need to do that. So if we don't agree to it, if we take staff's recommendation. Did that make any sense at all? It's just after 5 hours. I thought after I asked that, I'm going, wow. So, you know, in the interim, Barry, maybe they can use the land as it's being used now, unless we need it for the work that needs to be done. question mark.
Yeah, I mean, I think the staff has a long history on this property, and there's been a lot of discussion. So
Okay.
they briefed me on it, but frankly, I think we should really go through the presentation and hear the various pieces on this. Because frankly, if I repeat it now, I'm going to get it incorrect.
Okay, thanks, Barry.
To be real honest. Item 36 is a petition for vacating a 12-foot wide alley. They want to construct a swimming pool. Staff has no objection. Item 37 is a petition to vacate a portion of a 10-foot wide drainage easement. They vacate the northern 2 feet of the easement, allowing the petitioners to construct a pool. Again, staff has no objection. Item 38 is a petition to vacate a portion of 118th Avenue North down east of Starkey Road. This is remnants portion of an unopened right-of-way. This was previously on, but CSX had objected. We've not been able to receive a response from CSX, so county staff has no objection to vacation. And they did find that CSX has access available at another spot. So the vacation removed any county maintenance responsibility for the property. They also grant Duke an easement because they have infrastructure on the right of way. Item 39, this, and maybe Joel, you want to take this?
Yeah, 39 is an ordinance that is modifying your risk finance ordinance to adjust the delegation of authority to some of your staff members. Your risk finance program right now, currently your county administrator has the authority to settle cases up to $25,000. The county administrator, acting in conjunction with me, the county attorney, has authority to settle matters up to $50,000. What this ordinance proposes to do is to modify the authority of the county administrator acting in concert with the county attorney to reject offers to settle between $50,000 and $200,000. So it would up that authority only to reject. All cases where we would be recommending from staff that you settle a case in excess of $50,000, in other words, where the county would be paying out $50,000 or more, would still continue to come to you. So again, this ordinance just proposes to modify authority, increasing it from $50,000 to $200,000 for staff to be able to reject proposals for settlement. The reason why we selected $200,000 is, as you know, $200,000 is in line with your sovereign immunity caps. It's actually 200, 300, so 200 per person, 300 per occurrence. However, we thought 200 was a better amount to propose for this ordinance.
Okay. Item 40 is an ordinance amending the Pinellas County Code. This aligns us with federal requirements. So this is federal and state requirements. Would put us in for requirements to add dental facilities and dental discharges, hazardous waste, pharmaceuticals, sewer ban. This would update our language for our industrial wastewater permit program, the discharge permitted discharges. Item 41 is an ordinance adopting the downtown Palm Harbor master plan and amending the comprehensive plan to expand the activity center future land use and amend the future land use categories. I think when I first got here, we were talking about that one. So
yeah.
So item 42, this amends the current HUD action plan to receive the second round of the emergency solutions grant in the amount of a little over $3.9 million, almost $4 million. And item 43 is a standard 5-year consolidated plan and a 1-year action plan. Then finally, item 44 is a resolution accepting the City of Largo's 15-year review of the West Bay Drive Community Redevelopment Trust Fund. And this comes to you back in December. They've looked at this. They recommend a continuation at the present rate of 95%.
Can I ask, Do we have correspondence? I know we have interaction on one of these, but in terms of the public hearings, do we have correspondence on any of the others?
So far from the clerk's office, we've only received correspondence on agenda item number 34 thus far.
Okay. 34 or 30, 35? No.
34.
On the comprehensive plan?
Make sure you have there was a new, make sure you have an updated agenda. I had an old one also. It's 35. It's the petition for Christopher Mueller. Is that correct?
It was for the countywide plan. We received an electronic correspondence on it. I can check to see if we received one as well for the Mueller.
Okay. Well, we've received correspondence for the Mueller. Okay. All right.
Is that
Is there
all?
anything else? Does anybody plan on bringing up any new business? Or are you going to surprise us? Okay. All right. We are adjourned.
Thank you.
Yeah, Commissioner Edwards, I'm sorry. Oh.
No, that was a goodbye.
Goodbye.
Take care, everyone.